The Maine Mom Initiative is a statewide effort to expand access to services for pregnant and postpartum people with substance use disorder. The goal is really to give them the support that they need so that they can succeed in their recovery and help them address any barriers that they might be encountering. Patients with substance use disorder experience stigma, but there is no group that experiences more stigma than the pregnant patient. This is a group of folks that is so shunned by society, even shunned by other people with substance use disorder, that I think they feel helpless, they feel alone. If they've been using substances for a long period of time, they may not be connected to the healthcare system. And part of it is really fear. They're thinking, I know I need help, I want to get help, but where do I even begin? I think getting the word out there to other providers that this is a care model that they can deliver is hugely important.
When I was arrested and in jail, that's when I found out I was pregnant with him. The first reaction I had to being introduced to Maine Mom was, oh, I can't do that. I just had been gone to so many doctors and, seen so many counselors and specialists or whatever, just, people to help me. And all it did was just pile things onto my plate rather than take them away. So I was really scared. I was worried. I was like, I can't do this, because that's what I thought Maine Mom was about, was just, here's the resources, now go with it. But it's totally different than that. It takes it much further. It's made recovery something that I don't dread.
I don't really know of anyone else who helps moms in recovery the way we do. Our roles start early on when we first meet the mothers, whatever it is that they need. We also are integrated into a OBGYN office, so all your care is in one place.
All Maine Mom programs, have an MAT or MOUD prescriber. There's a substance use counselor. There's a perinatal provider of some kind. There's a nurse care coordinator who kind of runs the whole thing. And then we also have peer support. So there's at least 5 members of the team, all with unique and different roles, experiences, that can support the mom wherever she's at. People come, from any walk of life, any personal experience. It doesn't have to be that they had a baby. If they had a recent pregnancy and they had a miscarriage or a termination, they're still welcome to enroll in Maine Mom. We want to support them. And the most important sort of reference point I think, is really educating folks in the community that this exists and that we will treat people with respect that they deserve.
These people do care, and they are going to help you. It's not an if or maybe. They are going to help you, and they will help you so that you can help yourself.
They can make it. They can do it. I have seen grit. I have seen feistiness. And for Amanda, I there may have been days in the early on where she just wasn't sure, let alone what this was going to be, but would I be able to parent? Will I be able to bring home my child? And all of us sitting here today is exactly what this program is about. Exactly.
I think we're successful because we understand substance use disorders. And the one thing that, when patients say it to me, it means is incredibly powerful to me is that, you're the first person who treated me like any other pregnant patient. And that's always surprising to me because I'm like, you are any other pregnant patient. You have a treatable chronic disease, which could be depression, it could be diabetes, it could be substance use disorder. Why would we treat you any differently? But I know that it happens. And I read the notes and I see the experiences people have in other settings. And it's heartbreaking.
I feel like Maine Mom has made all the difference in my recovery, in what I'm trying to accomplish. I don't think without it that I would be here right now at all.
We're excited to have anyone join us on the initiative. There's lots of opportunities, I think. Even if people think, I want to do this work, but maybe I'm not super experienced, that's okay. There's clinical support that's available, and we're here to help anyone who's interested in providing the care. I think being able to be part of life-changing events and help people in a way that no one has ever helped them before is incredibly powerful and really rewarding, and I'm just grateful to be able to do it.
It's okay to applaud. I see Elaine standing up back there. Elaine, thank you. They do a fabulous job, the Maine Mom program, and I'm glad we could start with that brief video. I'm Gordon Smith, the State's Director of Opioid Response in Governor Mills' office. It's my pleasure. That's my sister down here, so she's been instructed when to clap and things. It's my pleasure on behalf of Governor Mills to welcome you all here today. I've got a lot of people to thank, but I'll kind of do that in the course of the next hour. I have some special guests to introduce as well. But I want to thank all of you for giving up your day to join us here for the 6th annual summit. We've got some fantastic presentations for you, and I think I really want to start by thanking the Voices of Recovery. We have 27 courageous individuals who will talk. Yes, they're incredible. And this year, I want to thank Recovery Connections of Maine in Lewiston, local treatment organization, Jeremy, Victor, Chantel, who helped to recruit and coach our Voices of Recovery. I think they arranged to have 18 of these individuals, and I think I probably found the other 8 or 9 or 10. So nothing is more important to this conference than those voices, because that's why we do the work that we do. That's why you do the work that you do. The governor will have some important new data to share with you. We're excited about the directions that things are moving in, but it's not about us. While we're proud of the things that we've done and the direction things seem to be moving, it's you on the ground. You are our foot soldiers in this war, and so, you are to be congratulated for the work that you've done every day. We'll have the full day together. It's really packed with presentations. We really want to thank the college, the Central Maine Community College. We'll hear from the president, Betsy Libby, in a minute. But for them to open up this beautiful campus to us today, and they've been just beautiful to work with, Allison and Betsy and the whole team here, Scott, the security people. We'll have times today that we'll laugh together, we'll cry together. It's okay. It's okay. I think before introducing some of our guests, that I really want to start with our two welcoming talks from, first, we're going to hear from Jeff Harmon, the mayor of this fine city of Auburn. And we really appreciate Jeff taking the time this morning to be with us and opening up his city to us. And then when Jeff gets done, I'll introduce President Libby. Jeff?
Thanks very much, Gordon. Good morning, everyone. I appreciate the opportunity to be here today to welcome you to the City of Auburn and Governor Mills' 6th Annual Opioid Response Summit. It's exciting to see all of you here today. Clearly, the opioid epidemic is one of the most serious public health issues that we face today. Opioid misuse has had far-reaching personal, social, and economic impacts on our residents and communities. Seeing all of you here today, gathered to share information and to learn from each other, gives me hope that continued progress will be made to address this crisis. I want to thank Governor Mills for her leadership on this issue. Early on, Governor Mills recognized the importance of a coordinated response to the opioid epidemic. She had the vision to bring people together to work cooperatively to find the best solutions to address this crisis. Her leadership was instrumental in the progress that has been and continues to be made, and we're grateful for that. The motto of the City of Auburn is Vestigia Nulla Retrosum, which translated means no steps backwards. Here in Auburn, we try to live that motto every day. I would challenge all of you to do the same. So celebrate your accomplishments, as there have been many. Recognize that there is still hard work before you, and continue to work together for the common good to improve the lives of the people living in our communities. With that, welcome to Auburn and the Central Maine Community College. I hope you have an enjoyable and productive summit.
Thank you, Mayor Harmon. Now I'd like to have you meet the president of Central Maine Community College, Betsy Libby. Betsy will be joined later today. David Dagler, the president of the community college system, will be here with us for the governor's talk. Again, I know I said this a couple minutes ago, but we are so appreciative of this beautiful campus. I wish that you could see it on a nicer day and that could walk around. And I think as the day goes on, I was only responsible for everything except the weather, and the governor was responsible for the weather. So I don't know, we could have got our signals crossed, but I'll actually take some precipitation in exchange for having a little lower temperature, because this room, you may notice as we go on this morning, is not air conditioned. All the other breakout rooms are, by the way. But Betsy, thank you for the tremendous effort you've made to welcome us here. We've made 4 or 5 trips to the campus. We've disrupted your life, but thank you so much. And please join me at the podium and welcome people to your campus.
Thank you, Gordon. Good morning. I'm thrilled on behalf of the college to welcome you to Governor Mills' 6th Annual Opioid Response Summit. The theme of the summit is creating a brighter future for individuals, families, and communities. That might as well be the motto of the college, making people's lives better. Substance use disorder hits very close to home for the college. Faculty, staff, students, whether they're experiencing it themselves or they have a family member or friend who is. And thankfully, some folks are in recovery. Recently, we've begun implementing things at the college that we didn't do 10 years ago. Part of the Faculty Staff Professional Development Day is where the Narcan is located, how to get it, and who carries a pouch. Those are kinds of things that we are taking as a college to add safety measures. On our workforce training side of the house, we've begun to work with the correctional system. We've had students in short-term trainings, skilled areas that prepare them for careers upon completion. Part of the program is having employers come in and meet these students who are in the correctional system. Students have told us that with a plan, they've been able to leave our program, become employed, secure housing, get custody of their children back. Previously, when they were released, there was no plan. They went back to old crowds, old decisions, and ended up back in the correctional system. Nothing I'm telling you that you don't know about, but we're very proud of that work. On our academic side of the house, we have an associate's degree in human services. That program has 180 students. A great majority of them are folks who are in recovery or close to someone who's in recovery. And the reason they've chosen that program is because someone like you helped them and they want to become that person for someone else. We have a lot of graduates of that program here today. I saw them in the audience when I was, saw them in the parking lot when I was walking them. A huge shout out to you. Yeah! The work you're doing here today, the work you do every day, the focus areas, priorities, and strategies outlined in Maine's Opioid Response Strategic Action Plan are so crucial for the health and well-being of our state, our community, and the success of the college, actually. We are so thankful for the good work you are doing, and I would just like to further welcome you to Central Maine Community College.
Thank you very much, President Libby. A couple logistical items. You all have lunch tickets that are color-coded. There's 3 places. It's not easy to take 1,300 people and feed you. But there's 3 different stations around the campus and places to sit, tents, inside seating as well. So on the slip that you have, and if you don't have a slip, then just go to the registration table and get a slip for lunch, and that will dictate which of the 3 areas that you are in. I don't know what color they are, but that says right on the ticket where you're to have lunch. That starts at roughly, I think, about 12:20 to 1:30. We have some additional security around because of some issues we had last year in Portland. But one thing that we do have some bathrooms in this building. We also have some portable restrooms, nice ones, out these 2 doors. And although it says emergency exit and alarms will sound, they will not. You can use these. It's kind of, I don't want you to have to go out front and wander around back to find these bathrooms. So if you want to use these front doors where the 2 of our security people are, that's fine. Before introducing our first substantive speaker from the state, I do want to thank the tremendous team of people that put this meeting together and have for six straight occasions. And we've been able to keep the team intact, and that's not easy. So our team from AdCare, led by the amazing Lorena Liberty, she's probably in the lobby, but please give her a big hand. She is truly one of these people that you run into in life that's just an amazing person, will work all night if that's what the job requires. Makes my job very easy. Also, our AV team from AV Tech, Dan Willis and his team over in this corner, there's 5 of them, so any microphone today, any AV problem, they do a tremendous job. I hope you also enjoyed the slideshow as you were coming in this morning. Those are mostly slides from last year's program, but also from all the events that we've had this year at your recovery centers, at your recovery residences. And again, I so appreciate AV Tech and AdCare, and also our Office of Behavioral Health staff. Director Squirrel is here, and we'll be hearing from her in a few minutes. But the team is great. I mean, they make my work so easy. I mean, I played golf yesterday. I mean, people said, you've got 1,300 people coming, you're playing golf. And I said, yeah, there's nothing for me to do. These people will be at the campus organizing, and it's just a beautiful thing. And I so appreciate their help. Points North Institute as well. I'm sure Sarah Irwin is here somewhere. We're unveiling a new film today. We've had it premiered in Brewer in Portland, but it's about some of our LGBTQ youth and the intersection with SUD, and we're showing that right after the governor's talk. So I think I did want to comment and thank, obviously, our exhibitors. Most of them are in the tent, right, that you couldn't miss as you came in. There are different periods of time, particularly this morning. I think we're free from 10 to 10:15, and then there's 2 other periods of the day, and lunchtime. It takes a lot to bring their materials. There's 70 tables out there, so please stop by and see them. I'm not going to name them. There's 70. And next year we've decided we'll get 100 tables because we had to turn people away. I also want to thank our signers because they work so hard, particularly for people like me that I'm as usual in awe of their work. So the next speaker has become a friend and a colleague. Pudieri Var is the director of our Maine CDC, the Center for Disease Control and Prevention. Dr. Var has been with us now for a year, close to a year. She's going to tell you something about, what brought her to Maine, and also tell you some of the amazing things that the CDC is doing. So it's such a pleasure, Dr. Var, to have you at our first summit for you, and And please give her a good Maine welcome, although she's been with us for a year. Thanks.
I think this will work. I was a little nervous, actually. I was like, oh, I should have asked for a stool. But good morning, everyone. Yes, my name is Dr. Va, and I just want to, thank Gordon Smith, President Libby, and Mayor Harmon for those welcoming words and for kicking us off today. And thank you, Gordon, for the kind introduction. With that being said, I am honored to be here today with all of you for this important summit. This is my first time here. And it is indeed important to see all the faces in the crowd, to be able to bring together people and communities integral in addressing Maine's opioid challenges. It's amazing, just the degree of folks here today. I see my role before I even talk about my role, as Gordon said, I am the director for the Center for Disease Control and Prevention, and that's really key. It's an office of Maine's Department of Health and Human Services, and yesterday I was giving a talk about equity, and one of the things we talk about is what are those categories you would fill out when you fill out a survey? It's like, well, I guess, I would fill out, maybe I'm Asian, maybe I'm a female, maybe I'm short, maybe I'm just other. But really, when I think about it, how would I describe myself? Probably as a physician, as an epidemiologist, as a wife, and a mother of 2 kids. But I think what's also important is that my history as an immigrant and refugee, it's really has driven much of my journey here and why I stand in front of you here today. I see my role in this job as helping Maine people live their healthiest lives by carrying out the mission of the Maine CDC, which is to protect and promote the health and well-being of the people of Maine with a focus on values of service, equity, integrity, and scientific excellence. And we all want a safe and healthy, resilient Maine. So really, that's what we're here to talk about today. And as we think about that, today's conference is focused on creating a brighter future for individuals, families, and communities. As Gordon alluded to, what you're going to be hearing is a lot of stories and sharing of our experiences and our lives. So I think it's important that I do the same as well. That vision at the heart of Maine CDC's mission, it's something that resonates with me deeply as an immigrant to this country, and as a core reason why my parents chose to flee Cambodia, flee the Khmer Rouge regime with their young families, because they wanted to create a brighter, healthier future for their family. But that's not where the journey ends, right? And that's what we're learning. Life is indeed a journey, and there requires some level of perseverance and resiliency. And the reason why I say that is because when we landed in the United States, I eventually grew up in what I would call upstate New York. But I'm going to share with you where that was. It's a zip code. It's 5 numbers. It's 14621 in Rochester, New York. That doesn't mean much for many people here in this room, but you know what that means actually? Is what the science shows us is that where we grew up, that zip code, is actually quite a predictor of your health outcomes, of what your life might be like. And that says something, because that zip code doesn't represent just an area. What it represents is systemic inequities and years of what we can say maybe divestment. So in 14621, what does that mean? How does that describe me? What it means is, in this zip code, half of the people that lived there were renters. The median income for a family of 4 was about $35,000 to $40,000 a year, compared to maybe 70, 77. What it also meant is it meant that there were high crime rates and there were high levels of substance use and misuse disorders. What it meant is that we went to a public school, which is great, right? Access to school, probably more than I would have gotten if I were to stay in Cambodia. But what it also meant was that I went to a public high school where the graduation rate was 50%. Where In the early 90s, they already had metal detectors because crime rates were high in the neighborhood, where teenage pregnancy was so common that teachers and counselors were talking about establishing a daycare. So 14621 meant a lot because it really reflects years of investment or lack of investment and systemic inequities through policies and programming. That's what it really meant. But what it also meant to me, which I think it's important to note, is that it meant a sense of community and belonging too, despite all of that. And despite what it told us, that more than likely you will have all of these preventable chronic diseases, obesity, diabetes, heart disease. But despite all of that, there was a sense of community because even in those 5 numbers and those years and years of divestment in a neighborhood, there are still people, right? And at the core of any number or any neighborhood, there are people that are willing to move forward because they want just that. They want to create a brighter future for individuals, families, and communities, and for generations. And so in this neighborhood, in this zip code of 14621, I found teachers that were mentors. I found counselors that were mentors. I found friends, colleagues that walked me through, that were support networks when I was going through difficult times. I found families and friends that protected one another. So a sense of belonging, a sense of mentorship. Those two are also protective factors. And I want to underscore that because, it relates, it's what actually drove me into this work. Growing up, I knew there was all these invisible threads that would pull people, it felt like they would pull people down. And it bothered me because it's what are these threads? What is this? Why do we feel like we're being drowned, we're being pulled down, it's so hard to leave, it's so hard to seek that brighter future? And in doing that, what it brought me to was, how do I answer those questions as a scientist, but how do I also pay it forward? And it brought me on a path to science, but it also brought me on a path to being a provider, a physician, because I wanted to provide care. I saw all those problems, and I was like, all these things are preventable, so what am I gonna do? Where is the need? The need is in primary care. Guess what? I will go to medicine and provide primary care. I came to medical school in Maine for that reason. It had a strong primary care program at the University of New England, College of Osteopathic Medicine. And that's where I understood rurality and how communities do struggle in similar ways. After my studies in medicine, I went on to do my internal medicine residency in the Bronx, New York. Again, very similar. I'm drawn to populations that I feel connected to. And in the Bronx, similar struggles. It looked different, but guess what? The struggles are real and the struggles were similar. And there, as an internist, I focused on primary care and how to connect care to people. But I felt very very, very limited. I see the interactions with my patients, and a lot of by the time they see me in that room, there's all of this other stuff that already happened out in the healthcare, public health ecosystem. So I felt that intervention should not just be in this one point in time, it should be a continuous spectrum of care in the environment. So I need to get out of this room. I need to be able to provide care in the environment, in the communities, in the public. That's what drove me to understand public health and epidemiology. I did my fellowship with the US CDC in epidemiology. And typically when you think about the US CDC, you think about Ebola, you think about outbreaks. But for me, no, I wanted to do chronic diseases because that's where the burden of need was in chronic disease. And so I did chronic disease epidemiology instead. But again, with clinical care, I was focused in a room. With the US CDC, my fellowship, I was way up talking about guidance and recommendations, but it was very disconnected, that guidance and recommendations is what we say. I'll give you an example. What does that mean? When I was going back to 14621, my neighborhood, when I was there, the doctors would say, eat healthier. Well, how do I do that when there's a highway that separates my neighborhood and the closest grocery store? And we had more corner stores than grocery stores near us, within a mile. So how do we do that? Or the doctor would say, go outside, physical activity is important. Well, again, how am I going to do that when I'm worried about violence and crime rates and bullets whizzing past my head? So not that what they said was bad. It's just there was a disconnect on what was recommended and my ability to actually do it because the environment was not promoting it. With that being said, I recognized that when I was at the US CDC, we were doing all this guidance and recommendations, but I needed to see what it felt like on the ground. And that's what brought me to population community health. And I went and served with the Indian Health Services on the Navajo Nation for the last 5 years prior to coming to Maine, where my focus was just that. I don't care about these boundaries, these artificial boundaries of walls and doors, and this clinic where everyone had to come up and find care. Let's bring care out to the communities. Let's make health just easy to find. Not even easy to find. How about we just live in it, right? So there I focus heavily on population health. How do we make that easier? How do we reduce those barriers? How can I help these Navajo families that I serve and care about? How do I make it so that health is outside their door, within their homes? We did this through a mobile health clinic program. We did this through school-based health centers. Any way we can, we try to make it easier for families because supporting families means supporting young kids and adults and generations. And I think that's important to note. And eventually, Maine had this position when Dr. Nira Shah left. And I was like, oh, I'm going to go back to Maine. I've always wanted to go back to Maine for a lot of good reasons. I've connected with Maine. I felt like I needed to give back to Maine. It was a state that gave a lot to me, took a chance with me, let me go to medical school here, something that I didn't even think was possible when I was living in 14621. So I knew I wanted to come back to Maine, and when the opportunity came, I came too. I jumped on it, and I came. And now I feel like, finally, this is where I want to be. My patients, yes, is no longer a 1-to-1 ratio, but now I see all 1.3 million people as folks that I need to care for because I feel committed to care for, and Maine CDC feels committed to care for. So with that being said, I wanted to share that story because I think it's important. When you think about creating a brighter future for individuals and families and communities, it's something we all want. And it's something that we're all capable of. But it's something that takes time and patience and ongoing work. So I'm going to talk about what that looks like, because you're probably wondering that right now. Like, she's been here a year. What have we done at Maine CDC? But really, what have we done as a collective team, right? So with that being said, because I wanted to share those stories because I felt it was important. If others are sharing, I should share too. And I wanted to make sure that this relates, the work that we do, the experiences that we have, the experiences that I have or my family have, also relates to the individuals and families across Maine who are also dealing with these different struggles in the depths of tackling substance use disorder or fighting to stay on the path to recovery or working to maintain sobriety, or just as equally important, the families and friends that are trying to help those individuals out through a very tough time, because that takes work and a lot of patience. Across the state government, as you heard from our Opioid Response Director, Gordon Smith, and you'll hear more about this very soon from the governor, from my DHS colleague, Director Squirrel, who runs she's the director for the Office of Behavioral Health of Behavioral Health, and then others. What you'll hear, though, is that we are working tirelessly with individuals, families, and partners across the state to foster those brighter futures. And so with Maine CDC, what are we doing? What we are doing is in our name ourselves. It says Maine Center for Disease Control and Prevention. Is that we recognize that we are not in this alone. In public health, you're never in anything alone. Like I said, you notice that there's a healthcare, public health ecosystem where we play, live, and work. So what that means, though, is that we actually have a team, a collective team. And our focus, our role in this team is the prevention part. We are focused on preventing substance use in the first place. And prevention remains one of the core pillars of our opioid response. And there are many fronts that our prevention team is working on, but there are two things that I'm really excited about and I want to focus on, is upstream prevention. And folks in the room probably know what that is, but I'll just level set and explain what that means. When you think about caring for a person or a family or a community, it's a continuity of care, right? A continuum of care. Imagine that being a circle, where prevention really starts at all points, even at intervention. But let's move upstream a bit to upstream prevention. What that looks like is this. is that children and youth are setting long-term health trajectories in their earliest years, and we have an opportunity to intervene earlier, to mediate the impacts of adversity and trauma, and to promote resilience and prevent larger problems from developing. The bottom line is the earlier we intervene, the better those outcomes are. So we aim to reduce known risk factors and support known protective factors. Goes back to what I was talking about earlier, that environment in which we learn, live, and play. Those counties, those zip codes, right? So if we know, the science shows it, what those risk factors are, what can we do to reduce it, to mitigate that? And if we know what those protective factors are, what do we do to put those on steroids, right? Ramp that up. And so that's why we're working with young people across the state to create connections, a sense of caring and belonging, and provide education early on in schools and communities so that opioids don't become something that our young people think of as an option, or so that our teens aren't reaching for an unhealthy method of escape or coping. That's really critical. So since 2020, the Maine CDC has supported implementation of this program called Sources of Strength in 18 schools, with 7 more starting this upcoming school year. What that is that it's a peer-led school culture program that brings together trained advisors and peer leaders to create campaigns for their school communities that focus on positive, uplifting, and hopeful messages. We've trained 161 adult advisors and 507 peer leaders to help improve culture and foster a more positive attitude among students as it relates to mental health and help-seeking behavior. That is quite impressive. That's creating that fabric of support and promoting protective factors and resiliency. The other upstream effort that we're doing is called Maine Youth and Young Adult Screening Brief Intervention Referral to Treatment. That's in collaboration with our school-based health centers. And what that does in the pilot in 3 schools, what that is doing is that it screens students enrolled in their school-based health centers during annual visits for students aged 12 to 18. And among those students who are screened that are positive for past substance use, healthcare providers then take that time and have these conversations, engage for the possibility for change. And guess what? Then they match those kids with treatment referrals at that moment in time. This coming school year, 3 more schools are going to be joining: Lawrence, Morse, and South Portland High School. So as you heard me say earlier, one of the monikers that I do relate to is an epidemiologist. What epidemiologists do is that we look at patterns and trends, and then we don't just look at it. We try to figure out what do we do better, or what do we put on steroids and promote more, and then what do we do to reduce those other things if it's heading in the wrong direction. Maine's trend in this opioid epidemic are beginning to show signs of progress, and you'll hear more about that. But we are cautiously optimistic, and the reason for that is because any work takes time. And it takes continuity of care. It's never going to be done, and that's okay, right? Those prevention efforts are always ongoing. Those interventions, that level of care will always be ongoing. And that's where it should be, always ongoing. Because it's us, it's now, but it's also our kids, our communities, and those generations that come after it. So with that, I want to close, is that, we're here to talk today about what we've done so far, what more we can do to help create a brighter future for Maine individuals, families, and communities. But like I said, the work isn't done. You're going to hear about that, and you're going to hear about opportunities of where we can grow. So I'm glad to see the faces in this room, and I know we've got this team on the job with the leadership of Governor Mills. And with that, I do want to hand it off to our U.S. District Attorney, Darcy. Thank you so much.
Thank you so much, Dr. Barr. We're so fortunate to have such strong leadership. We wish Dr. Shah well. We miss him. We're excited about the work he's doing in Atlanta, but it's great to have you with us. We couldn't do the complicated, complex work we do without the help of the federal government, and we're so lucky to have these partnerships that Dr. Delphin Rittman will be sharing with us shortly. But the U.S. Attorney, Darcy McElwee, is she's a friend. She's runs a large organization headquartered in Portland. She's a Carol, but when you get right down to it, she's just a terrific Maine girl from Caribou, Maine, and I love her to death. She fills up a room. She's fun to be with. We really had a wonderful dinner last night with a number of our faculty, and she and the Attorney General were both able to join us. But she's going to share some thoughts from the federal government. The U.S. Attorney's Office is a significant law enforcement organization in the state of Maine, and I welcome my friend Darcy McElwee to the podium.
Good morning and welcome. I'm so pleased to be here with you today at this important and special event for the third time. And I'll go off script because Gordon said I'm just a girl from Caribou, which is so true. I could not tell you how happy I am that there's not that big screen that we had the last 2 years, or my face, like planet-sized Darcy, with every pore on my face was showing. Because I don't know if you noticed, but I'm not a morning person, and it is like 8:20, and I don't live anywhere near Auburn. So I'm so thrilled to be here and to have you see me from a distance. The genuine and productive partnerships which my office enjoys with Gordon, the governor's office, the Maine's Attorney General, Aaron Fry, the Maine Department of Public Safety, Commissioner Soschuk, and Maine's law enforcement community, and so many of the organizations represented here today is so critical to our shared work as we tackle this opioid epidemic in Maine. As Gordon said, I am Maine's Chief Federal Law Enforcement Officer. I am the lead Department of Justice representative for the President and the Attorney General Garland here in Maine. And as I say every time I have the honor of speaking at this event, I am also a career federal prosecutor, a former Maine state prosecutor, a native of Aroostook County, a mother, and a proud daughter of a father in his 39th year of recovery. I'm here today to learn along with you, to share ideas and show support for a holistic approach to our public health crisis, and particularly this year to celebrate the successes we have seen with less overdose deaths of our loved ones across the state. As I'm sure you will hear throughout the day from many people, we still have much work to do together. As we know all too well, fentanyl remains the deadliest poison we've ever seen in our streets. In response, the Department of Justice is laser focused on disrupting drug trafficking networks and preventing overdose deaths. We are working every day to get fentanyl and other deadly drugs out of our communities and to bring justice to those who put them there. In larger urban areas across the country, agents and prosecutors are working with state, local, tribal, and territorial partners to break apart every link of the cartel's global supply chains, which includes cartel leaders, drug traffickers, money launderers, clandestine lab operations, security forces, weapons suppliers, and chemical suppliers. These are companies and individuals who are making millions of dollars on the backs of individuals struggling with substance use disorder, including right here in Maine. And through the Drug Enforcement Administration's One Pill Can Kill campaign, we all know that fatal overdoses do not only impact those struggling with substance use disorder, as we hear more and more of our nation's young people unknowingly taking sometimes just one lethal prescription pill laced with fentanyl. While my federal colleagues are attacking the supply of fentanyl internationally, here in Maine, my office and federal law enforcement agencies are working closely with our state and local partners to address the supply of this deadly drug by disrupting those who are trafficking it directly into our state. Like last year, our caseloads reflect that this crisis is not just restricted to our most populated or urban communities. My boss, Attorney General Garland, has said the Justice Department understands that no one person and no one family can defeat this epidemic alone. That is why, in addition to our enforcement efforts, the department is working every day to support communities in their efforts to confront the public health challenges of substance use. On his behalf, I am here today to assure you that the Department of Justice is doing absolutely everything it can to stop fentanyl from being manufactured and trafficked in the U.S. and Maine so we can eradicate this lethal foe while helping to support those of us who have already been devastated by impact. Among the successes worth celebrating this past year are progress made by the Department of Justice right here in Maine. As a result of the tireless efforts of several individuals in my office, in partnership with the U.S. Marshal Service, both of our offices in Bangor and Portland, as well as Maine's 2 federal courthouses in the same cities, now have naloxone available. We recognize the importance of this life-saving medicine and its availability being critical to the safety of the individuals with whom we interact, including defendants, witnesses, and victims whom we serve. And we learn this from all of you, those who work within communities across Maine to keep the number of overdoses declining again and again. So thank you for the education that you gave the law enforcement community. At today's summit, I look forward to hearing more about dozens of policy strategies, including those centered on prevention, harm reduction, coalitions, treatment, and recovery. We will hear about strategies which will include strengthening coordination among public safety leaders and community partners. I am so proud of the work being done by the local law enforcement communities throughout the state of Maine in collaboration with the Options Program. And numerous Maine police departments are engaged in truly unique and innovative alternative interventions within their communities. And as a result, those with whom they interact are more often finding their way to safety, stability, and recovery instead of jail. This should make us all feel hopeful. Additionally, in the unfortunate situation where someone struggling is sentenced to jail, more and more county jails and all Maine Department of Corrections facilities are providing medically assisted treatment to residents. For those leaving custody of Maine DOC, the opportunities and resources upon reentry are more robust and supportive than ever before. I am inspired both personally and professionally by stories of those brave enough to ask for help. I hope through this summit celebration of the work being done to respond to this crisis in Maine, we will encourage those we all serve to do the same. In addition to continuing prosecution efforts to address public safety, please know that we stand with all of you in this fight, particularly those of you who work for organizations and state agencies committed to expanding awareness about and availability of important interventions like naloxone, harm reduction, and treatment, as well as to provide opportunities for those in recovery like safe housing and employment. You all do tremendously difficult work. And as the statistics you will hear today reflect, you are making a huge difference. On behalf of the entire Department of Justice, I want to thank you for continued commitment reflected by your presence here today. There could not be more work for us to do together. Our partnerships have never been this important, and there is so much at stake. I'm grateful for the work that you do, and I'm committed to continuing to work with you to protect all Mainers. Thanks for having me.
If the Attorney General could start making his way to the podium. He likes to sit in the corner. I'll give you thank you, Darcy. We really appreciate you being here. It's my pleasure to introduce the Attorney General for the state of Maine, Aaron Fry. Aaron has been a tremendous partner in this work since we all began in January of 2019. And Commissioner Soschek and I were talking this morning that it's just fantastic, the team we've been able to keep together. I consider him a friend. I consider him a colleague. He cares deeply about this issue. He's a Mainer, proud graduate of now famous Nokomis High School, as I recall, and represented section of the city of Bangor in the Maine legislature for many years before being elected Maine Attorney General, which he is now in must be his 6th year or so, succeeding Governor Mills. So he's going to share some thoughts from the Attorney General's office. And again, we couldn't have a stronger partner in our work with public safety, and I'm so appreciative of every day being able to work with him. Attorney General Fry.
Well, thank you, Gordon. Good morning to everybody. I just one of the things that struck me as I made my long walk over and sat next to Gordon while he was saying nice things about me, is that this is my sixth opportunity, sixth privilege to join you all for the Governor's Opioid Response Summit. And I was reminded that every single time I stand up here to address you, I think of how awesome it is that so many people across our state are dedicated to making sure that we address the opioid crisis and epidemic, not through some sort of negative intervention, but through support, meaningful care, understanding. Because year in and year out, from the first to now, we have seen, 1,300 people, I believe, have turned out to this conference. That number has been increasing year over year over year. So unlike other things that we see happen on a regular basis that get stale, the motivation to make sure that we are all available to help those who are struggling from the opioid epidemic, our motivation to help them has not failed and instead has just increased in its energy. And I just want to take this opportunity to thank you all for the feeling that you give me when I stand up here and look at how many folks are dedicated to helping our communities, families, and individuals. So thank you all for that. And this is the sixth annual, right? So, we've had what was a really novel event 6 years ago, and Governor Mills really changed and reset the tone for our state. I served in the legislature, as was mentioned by Gordon before. When I was in the legislature, we were fighting just to make sure naloxone could be available, period, right? Not like available generally like it is now, but just available, period, as an intervention. We had a chief executive that did not believe that folks deserved a second chance when it came to opioid use. And so when Governor Mills came in, it was a breath of fresh air. She understood exactly what it is that was the appropriate role for the state, had a legislature with compassionate legislators behind her to make sure that we saw an opioid epidemic through the eyes of how can we help support people to recovery. And so now, sitting here, looking at how this conference is not only allowing ourselves to learn about those successes that we've had, learn about those positive interventions that we've had over the last 6 years, but also allowing us an opportunity to rededicate ourselves to that healing and that help and that support and that community that we all want to provide to those who are working their way in however it's affecting them through the opioid epidemic. Now, progress has been evident. We have an increased range of interventions that have been provided by nonprofits, by medical facilities and providers, by the legislature and the governor. There's so many different ways now in which somebody can access some form of treatment or support when they are ready to receive that support, right? There is no one way, and we all know that. You don't need to hear that from me. But since there is no one way, it has been important that we provide so many different opportunities for folks to access help when they need it, right? When they are at the point where they know that intervention will make a difference. Prior to serving as Attorney General, I was a criminal defense attorney. I worked with so many people who, when they came into my office and I saw that they were struggling with an opioid use disorder, they were struggling with their substance use, there were not options that I could direct them to. And it was really a challenge on how to help guide them on how do you avoid the impact of a criminal justice system that doesn't have doors for you? How do you deal with getting your child back in a child protective system that doesn't have as many doors for you, right? Not because people weren't working, but because there wasn't this collective effort to make sure that folks could access support at the point that they needed it in the way that was going to work best for them when it was available. So we've made progress. We are seeing that in the numbers. You're going to hear that from the governor later. But let me just say, for me, I still think about every single individual could be that next number. And so when I think about the numbers, I'm not thinking about them in a cold, calculating, what does this mean for our bottom line? I am thinking about how there are opportunities that we can still take to make sure that when somebody is at the point where they have a decision that they are making about how they proceed, that somebody supportive with a supportive intervention can be there for them. So that is why I think we all come together today. That's why I think we all rejoin for our 6th year, not to be our last, to rededicate ourselves to this work of making sure that whatever progress we understand we are achieving today, we will continue to achieve. And let me just say, I want to provide a thank you again. There have been so many different people who have been involved with that, right? We have treatment providers, we have individuals, families, friends, all those who have opened their hearts, doors, minds to making sure that people receive the attention and care that they need. Our legislators, our governor, our first responders, everybody really is organizing in a way to make sure that they are available to support folks who are struggling, who have families who are struggling with an opioid use disorder. Now, my office, as you all know, has been coordinating with subdivisions and with the state to close down litigation with those who, in many ways, were very responsible for the opioid epidemic. They fueled the opioid epidemic, right? These are the folks that manufactured opioids, the distributors, those who sold them, the pharmacies that sold them. We have secured $230 million that's going to be coming into the state of Maine over the next 18 years to address the opioid crisis. Now, it's worth clapping. I appreciate Gordon's sister. I was on that memo about when to clap, so thank you, Edie. So at this point, 65 million of that has come in. More information is going to be provided on that later. There is a breakout session where the Maine Recovery Council, my office, will be talking about how that money is going in. But I want to highlight one thing that my office just addressed, and that is the Maine Substance Use Outreach, Engagement, and Evaluation Center. If you look in your, and I'm sure you've all so far gone through your packets, there is a handout in your packets that will tell you about this center. But here's what's more important, right? And that's this QR code right here. This is why. My hope with this, and this, by the way, this center is going to be facilitated by the Catherine Cutler Institute. It's going to be driven by researchers, and these researchers are going to be driven by what information they are able to receive. The QR code that I just mentioned to you, that is a way in which you can provide input as to what you understand is working, what's not working, what you see as trends in dealing with the opioid epidemic. Because my goal in creating this partnership, in creating this center with Catherine Cutler Institute, is to try to do two things. One, it's going to be to provide support to those subdivisions, right? Municipalities, counties who are receiving opioid dollars. Provide them with technical support and assistance on what is working best, how can their communities best be served by those dollars that they are receiving, and then also help coordinate amongst them how we might do that, right? Here's the second thing that's going to be very important to everybody, and that is it is going to collect up information that you all are going to be able to use. The governor, the legislature, the Maine Recovery Council, my office, our federal partners are going to be able to use in terms of directing how different strategies are going to work, which ones are not working and can be retooled, how money is actually affecting the change that we hope it's going to impact. So please keep your eye on this center because it's going to do really good things. I think it's going to provide some excellent information that's going to be useful in all of your work, and that's why I direct you to the Maine Substance Use Outreach, Engagement, Evaluation Resource Center handout that's in your packet. Here's my final thought. I think I've blown through my 8 minutes, but I guess that's my privilege. No, that's awful. Let me thank you again, right? And I want to thank you by recognizing something. So you heard earlier, I believe it was from the community college president, that our motto today that Governor Mills has branded this conference is creating a brighter future for individuals, families, and communities. I guess I actually don't see that as something that is prospective. I see that as something that is reflective of what it is that you have already been doing for so many years in your personal and professional lives, right? You have created a brighter future for individuals, families, and communities by the work that you have been doing and by the fact that you came out today on a Thursday to talk and listen and learn and engage on how we can all do our part to make sure that the opioid epidemic here in Maine continues to be confronted with all the vigor that we want to apply to it. So I want to thank you because by doing what you are doing, you are making the difference. And I hope that you will find that with the U.S. Attorney for the District of Maine, Darcy McElwee, with my office, the Attorney General's office, with Gordon, with Governor Mills and her administration, I hope you all find very willing partners and collaborators to make sure that we continue to move forward in creating that brighter future for individuals, families, and our communities. Thank you for this time this morning.
Thank you, Attorney General Fry. I don't want to cause a mass exodus, but I did check out the auditorium for the live feed to see if anybody was there, and it's just so much more comfortable in there. And there's 230 seats in there, and there's probably 50 people. So again, you can't all go in there for the next hour, but anybody that's really uncomfortable, maybe has health conditions, there's some lovely air-conditioned seats that are 100 feet away. No mass exodus, please. We're going to turn now from some of the state and federal people to the private sector, so to speak. We're really pleased to have from Millinocket here this morning with us the CEO of Millinocket Regional Hospital, Bob Peterson. Bob's been at the Millinocket Regional Hospital 10 years. It's an independent, rural, critical access hospital, and he's been working really hard with us to improve the services that they provide to people with addiction, particularly in the emergency department. We have a 1,000 Lives campaign. I know my colleague Andy McLean is here from the Medical Society, and Bob is really here to represent the 1,000 Lives campaign because Eric Steele, who you remember, those of you who were in Portland with us last year, we announced the 1,000 Lives campaign, an effort by the medical community in Maine, Maine's hospitals, Maine's physicians, Maine's nurses, to step up and do a better job of treating people with substance use disorder, and with the goal of saving 1,000 lives that we would otherwise expect to lose in the next 5 years. We're on the first year of the project. Bob's going to talk about what he's done at the Millinocket Regional Hospital. We are so appreciative of him coming down today from Millinocket. Bob Peterson.
Thank you, Gordon, very much. Good morning, everyone. I was asked to speak with you today as Millinocket Regional Hospital is the most recent hospital to initiate the 1,000 Lives campaign. Through the leadership of attorneys Gordon Smith and Andy McLean, Dr. Eric Steele, and Governor Mills, this campaign aims to prevent the overdose deaths of 1,000 Mainers over the next 5 years. This effort brings together the Maine Medical Association, the Maine Hospital Association, state government, and other key stakeholders to formulate targeted action to reduce the number of drug overdose deaths in Maine. The 1,000 Lives campaign provides the vehicle and the process for willing individuals to free themselves from substance use disorder, and specifically opioid use disorder. When mapping out one's future, no one suffering from this disease puts it on their life's plan as something they want to accomplish. This campaign removes the stigma associated with substance use disorder and treats SUD as the medical issue it truly is. And yes, it is a medical disease, not unlike any other diagnoses we see in the ER. And it needs to be treated as such without extraneous judgment. The vast majority of you in this room are medical leaders, doctors, nurses, advanced practice providers, pharmacists, social workers, counselors, therapists, EMS, and many, many more. You chose healthcare as a profession to take care of patients and promote better patient outcomes. As leaders, our main driver each and every day is just that, to promote better patient outcomes. If this is not a main driver for you, I would challenge you to reflect and refocus. The 1,000 Lives campaign requires us to return to our core roots and advocate for those patients willing to take charge of their lives. Note that I refer to you all as medical leaders, not just providers. To promote better patient outcomes, regardless of your title, you must choose to lead and consider patient outcomes in virtually every decision you make. A classmate and colleague of mine, Dr. Leon Moores, recently defined leadership as the art of influencing thought and behavior to achieve desired results. To give you some perspective, Leon is an impressive individual. He's a West Point graduate and practices as a pediatric neurosurgeon in Northern Virginia. In addition to his medical practice, he is a noted lecturer on leadership and holds 2 doctorates. What a privilege it was to be in class with him. So for today's purposes, our new definition of leadership is the art of influencing thought and behavior to achieve desired results. Doesn't that sound like a lot of our jobs? Isn't that the essence of our job? Specifically, our job is to influence our team members to achieve a desired result. I'll get back to this in a second. The 1,000 Lives campaign is actually quite simple. Here's how it works. Doctors and other advanced practice providers identify patients who would A, benefit from buprenorphine therapy, and B, are ready to make a change in their lives. We provide the first dose of buprenorphine in the hospital. We then arrange for a very timely initial appointment with local follow-up providers to continue the medication-assisted therapy and provide counseling support. We provide a prescription for buprenorphine to cover the patient until they can be seen by the new prescriber. And we provide naloxone, or a prescription for naloxone, to be used in the event of a problem anytime during the treatment period. Not too complicated, right? Seems pretty straightforward and reasonable, correct? Despite the apparent simplicity of this process, concern was raised by my staff on multiple levels. Here are some examples of the concerns raised by staff, and these are pretty much direct quotes. Most of our patients don't want treatment and are nasty to us when they wake up. All they want to do is leave the ER. It'll never work. Who's going to pay for the buprenorphine and naloxone? Many of our patients are uninsured. It'll never work. We don't have buprenorphine in the Pyxis. It'll never work. What if we provide them buprenorphine and they just sell it on the street? We don't have any local providers and counselors available for medication-assisted treatment, so it'll never work. We don't have time to make appointments for them. It'll never work. What about pregnant patients? They have special needs. What's our plan for them? Our patients come in on Friday nights and on weekends. The referral offices are closed. Without a warm handoff, it'll never work. And on it went. This dialogue illustrates the stigma that is pervasive in substance use disorder and one that must be overcome by effective leadership. It's time for all of us to step up. Here's how it played out at my hospital. After listening to the concerns of those who will be doing the work, which is an integral part of leadership, by the way, I challenged them with a simple directive and empowered them to get it done. First, I defined the endpoint. Specifically, we are going to participate in this initiative because it promotes better patient outcomes, period. Second, I challenged them professionally. Much like the motto of the Apollo 13 ground team, failure is not an option. Third, I defined my personal expectations. Namely, I don't want to hear no because, I want to hear yes if. It's up to the team to work through any and all barriers that stand in the way of success. Fourth, I offered sincere support. What do we need to do to make this a reality? What are your yes ifs? And how can I help you with those? And lastly, we provided our team with a final compelling perspective that everyone understands, the standard of care. Dr. Steele pointed out that as more and more Maine hospitals adopt the 1,000 Lives campaign, this protocol will become the standard of care in Maine. The vast majority of Maine hospitals are now on board with the 1,000 Lives campaign. It is now the standard of care. To do anything less would be negligent. Never put yourself in a position to have to defend why you're not practicing at the current standard of care, especially when doing so is not really that difficult to accomplish. And our team did it. They found solutions for each concern and overcame every barrier. We actually go live on September 1st. The most fulfilling part of this project is that the team assumed a leadership role. They influenced thought and behavior, and they achieved the desired result. And that result will be improved health outcomes for this vulnerable and complicated cohort of patients. This is how healthcare should work each and every day. Think about your normal day. Shouldn't everything you do and every decision you make be focused on promoting better patient outcomes? If we focus on this goal, I assure you our jobs will be much more fulfilling and much more meaningful, and we'll be earning our paychecks and making a difference in patients' lives. Never lose sight of why you chose healthcare as a profession. Bill Owen once said, "True leadership lies in guiding others to success. You must ensure that everyone is performing at their best, doing the work they are pledged to do, and doing it well. As leaders, we must provide our staff the environment and the support they need to be successful. Leave the details to those doing the work, provided, of course, that they consistently achieve the desired endpoint." So my message to you regarding the 1,000 Lives campaign is, if you haven't already, please get this invaluable program in place and functional. Good people's lives depend on it. Influence thought and behavior and get the desired result. Give your team a clear directive and then give them the tools to overcome barriers and get the job done. And finally, remember the words of John Maxwell. People buy into the leader before they buy into the vision. Thank you all very much.
Thank you very much, Bob. That was incredible. We need that 33 times in every emergency department. We need the governor to be able in a few months to say, if it's 1 a.m., we have 33 emergency departments welcoming you without stigma and with compassion to start treatment. And that's what we're working on. I'm going to make a little adjustment. We're not too bad. We're about 6 or 7 minutes behind, but because Dr. Delphin Rittman needs to leave right at like 5 minutes to 10. I've talked to Sarah Heel-Langevin, who was our first voice of recovery. I'm going to have Sarah do her story at the end instead of beginning, just so that I don't want to rush Sarah, I don't want to rush Dr. Delphin Rittman, and I don't want to, she put an incredible amount of effort to get up here from Washington, D.C. or Connecticut or wherever you started yesterday. So I want to just introduce a couple people before I turn it over to Director Squirrel, who will make some welcoming comments, and then introduce Dr. Delphin Rittman. And then when Dr. Delphin Rittman is done, Sarah is over here somewhere, who is an incredible individual. You've heard many of you, we've featured Sarah's story in one of the Maine recovery films. But I want to introduce 3 or 4 people, and then over the course of the day I'll introduce some more. But we have 3 commissioners with us. I just took one out of the room, so she may not be here. But our new commissioner of the Department of Health and Human Services, Sarah Gagne-Holmes, is here. Commissioner Randy Liberty from the Department of Corrections, and Commissioner Michael Sawchuk from Public Safety. Could you all stand up and just thank you for being here. Thank you for the incredible work that you do. I also want to introduce the Director of Maine Care, Michelle Probert. I know Michelle's out there somewhere with her team. You can't imagine the important role that Maine Care plays. Well over 100,000 patients in the expansion population, well over 20,000 of them filing claims for SUD. I never call that office without getting an immediate response. Michelle and her team, just Olivia, and I can't name all of you, but Michelle, where are you so that we can give you a hand? Oh, well, brightly attired so we can find you today. Thank you. Finally, I want to remind you, in the packet that you have, there's 1 or 2 documents that we haven't talked about. The legislative document, I want to acknowledge the support we had in preparing that document, the bills that passed this session that you need to know about, and we did that with MERAP, the Recovery Advocacy Project. I don't know if Courtney's in the room, but we really appreciate it. We just liberally borrowed and stole from their document, and I'm so appreciative of them letting us do that. And it does have that logo on the bottom. My intern Tucker put that together, and Tucker's here as well. But I'm even more excited about the document about the detox beds. We have 1,300 now of you that have the access to the phone numbers, the facilities, the 100 beds that we have tonight available for people who need help with detox. I promise you, these beds are not all full tonight. And that's now a new concern. I think we believe that if we opened them, we built them, people would come. I think they will, but we have to do a much better job, the facilities themselves and all of us, to let people know we are open for business. One other gentleman I want to introduce, I think he's in the audience, our relatively new superintendent of insurance, Bob Carey. Bob, are you here? Where are you? Oh, there he is, right in the middle. Bob, thank you. Bob is fairly new to Maine, but he attended college in northern Maine. I had recently a chance to sit down with him and talk about mental health parity, the promise that years ago the insurance companies would treat mental health and behavioral health and substance use disorder the same way we do every other medical condition. We have failed at that promise, and we need people like Bob to help us meet that promise. Thank you, Bob. With that, I'm going to turn it over to Director Squirrel. She's been a great partner for these last couple of years. She's former commissioner of mental health in Vermont. She's an athlete. She's a friend. She's a terrific human being. She's a mom. She's a wife. But in my life, she's the director of our Office of Behavioral Health, a very, very important position. Sarah.
Good morning. Great to see everyone. Thank you, Gordon. It's an honor to be here this morning with all of you, and it's even more of an honor to serve in this role as the director of the Office of Behavioral Health and to join everyone in welcoming you here today. I first want to thank everyone who made this day possible, including the team at the Office of Behavioral Health, Richard Friend, Madison Barassa, Sarah Wade, Elizabeth Fortier, Rob Porter, and Catherine Coutu. Can we please give them a round of applause? And most importantly, I want to thank Governor Mills for her leadership. She has brought the full force of her vision and commitment to our opioid response here in Maine, leading Maine to become just one of 4 states in the country with an annual decrease in fatal drug overdoses of 15% or more. Governor Mills has demonstrated time and time again that the most powerful tool for success is both fortitude and the ability to listen, to empathize, and collaborate. And I want to thank you for bringing us here today. I also want to thank former DHHS Commissioner Lambrou for her tireless dedication, and to welcome Sarah Gagne-Holmes, our new Commissioner of the Department of Health and Human Services. For anyone who has worked with Commissioner Gagne-Holmes knows that she leads with integrity and compassion. And thank you to our Opioid Response Director, Gordon, who leads with both his clever wit and his full heart. To work with Gordon is to work with someone who is willing to challenge the status quo, to break down barriers. He is dedicated and he cares deeply. Just last week, he volunteered to drive hygiene kits across the state to recovery centers. And if you ever have a long car ride or need to pass some time, just call Gordon. I also want to thank my fellow leaders at the Department of Health and Human Services. Michelle Probert, who was just introduced, the Director of Maine Care, Bobby Johnson, the Director of the Office of Child and Family Services, and Dr. Thierry Va, who you heard from this morning. It's an honor to work side by side with these amazing leaders. They and their teams contribute greatly to our unified response, including reimbursement and payment reform for providers, addressing substance use in families, and comprehensive prevention and harm reduction work. While this work is never done, we should be very proud of what we accomplished here in Maine. From prevention to early intervention to treatment and recovery, we are saving lives. Expanding health insurance coverage for Mainers through Medicaid expansion, with nearly 30,000 individuals receiving treatment for substance use. Expanding substance use disorder treatment with increases in medication for opioid use disorder and expanding our opioid treatment programs. Since 2019, we've recruited and trained over 2,300 recovery coaches. They're embedded in our communities, in our emergency departments, and now in our family recovery coaches, or recovery courts. And we've invested $1.3 million to embed substance use disorder specialists in 8 of our child welfare districts across the state. We know substance use disorder is a factor in 53% of cases when a child is removed from their home. These specific and targeted opioid response interventions are powerful, and we also have to stay focused on the co-occurring nature of mental health and substance use, which is why we must continue to take an integrated approach to behavioral health service in Maine, with treatment models that provide both mental health and substance use. We should expect that individuals who walk through our doors may be struggling with co-occurring issues. Every aspect of our behavioral health system needs to be welcoming. It needs to have co-occurring capability so that individuals and families with complex needs have no wrong door. We've advanced several initiatives here in Maine that take this integrated approach. In June, at the Department of Health and Human Services, we announced that the U.S. Centers for Medicaid and Medicaid Services and SAMHSA selected Maine as one of 10 states to participate in the Certified Community Behavioral Health Clinic Federal Demonstration Program. This will be a catalyst for a potentially transformational model of service delivery that addresses both mental health and substance use. We've also established the first crisis receiving center here in Maine in Cumberland County, providing 24/7 low-barrier, same-day access to an array of behavioral health services and supports, peer services, and same-day access to medication for opioid use disorder. 48% of the individuals who have been evaluated at the center met criteria for substance use disorder. Individuals have same-day access to Suboxone, peer support, and connection to recovery resources. They've served over 1,600 individuals, preventing unnecessary ER visits, unnecessary law enforcement intervention, and just better serving people in crisis. I want to thank the team at Spurwink for their leadership in this model, and we are so excited to expand this model with the support of the legislature in Aroostook and Penobscot counties and right here in Androscoggin County. I also want to note July marks the 2-year anniversary since we rolled out 988. With the successful implementation of 988 here in Maine, we've entered a new era of front door access for crisis services, where individuals experiencing a mental health or substance use crisis can be immediately connected to support. Since July of 2022, we've responded to over 220,000 calls. That includes just over 10,000 calls a month in 2024. Our answer rate is 97%. Our response time is 2 seconds, and 83% of those calls are resolved on the phone. I want to thank our partners at the Opportunity Alliance for their great work on this. We also haven't shied away from innovation here in Maine. The most dangerous phrase in systems change and improvement is, we've always done it that way. In Maine, we've been willing to pilot new initiatives, to take informed risks, and to lean into the evolution of our behavioral health service that's based on responsiveness and community needs. We've invested $1.2 million to establish community-based harm reduction workers across the state, serving high-risk communities, providing harm reduction supplies, education, and resources. Over 5,000 individuals have received services through this program. And we've been focused on expanding access for incarcerated individuals. The Office of Behavioral Health has been partnering with Somerset County Jail, piloting the use of Sublocade, which is extended release buprenorphine, to support higher rates of treatment retention and lower rates of recidivism. According to the literature, our Sublocade pilot was the first of its kind in a rural setting and included the largest number of participants in any Sublocade project in the United States. Using Sublocade, we've been able to treat almost 4 times as many individuals. And I want to thank Sheriff Dale Lancaster and Elaine O'Connor for their leadership. And while we have moved swiftly and decisively here in Maine, our opioid response efforts are not just about grand gestures. The success of what we have achieved together culminates from small actions, the voices of recovery, the power of individual agency and advocacy. And we know that the diversity of our perspectives and experiences are our greatest strength. And we can honor this diversity and work in partnership with that shared sense of purpose and a collective belief in the possibility of a better future for Maine. I have learned that true systemic change moves at the speed of trust. We must double down on our commitment to partnership and to collaboration, to break down stigma, to take care of one another, and to promote and support recovery with unconditional positive regard, acceptance, and most of all, hope. And now it is my distinct pleasure to introduce our keynote speaker, Dr. Miriam Delphin Rittman. Thank you. Dr. Delphin Rittman is currently the Assistant Secretary for Mental Health and Substance Use in the U.S. Department of Health and Human Services and the Administrator of SAMHSA. She previously served as the Commissioner of the Connecticut Department of Mental Health of Addiction Services in this role for 6 years. In her role as Commissioner, Dr. Delphin Rittman was committed to promoting recovery, integrated and culturally responsive services, and systems that foster dignity, respect, and meaningful community inclusion. As Assistant Secretary for Mental Health and Substance Use in the U.S. Department of Education and as the Administrator of SAMHSA, one of her proudest achievements is her key role in leading the nation's transition to the 3-digit 988 National Suicide Crisis Lifeline. We are so grateful to her leadership and the support that SAMHSA has provided to Maine to support our implementation. I also want to thank Dr. Delphin Rittman and SAMHSA for their compassionate and swift response to Maine in the wake of the Lewiston tragedy. Dr. Delphin Rittman was one of the first to reach out and to offer support and made available critical SAMHSA emergency response grants to support our work here in Maine. We are so grateful to your leadership and your support. Please join me in giving a warm welcome to Dr. Miriam Delphin Rittman.
So good morning, everyone. And thank you so much for that warm introduction. And I just have to say, it is just such a pleasure to be here, such an honor. Maine is near and dear to my heart in so many ways. For the last 10 years or so, my husband and I will often camp at Bar Harbor or go to Ogunquit, and so Maine always has a piece of my heart. But I'm also really pleased to be here because, the work that you all are doing is just so incredible. It is life-changing, it is life-saving. And so, again, just such a pleasure. And I want to thank the governor, Governor Mills, just for the commitment to this work, and Commissioner, Director Squirrels, for the amazing work that's happening really across the state. So appreciate Gordon. I had the opportunity to speak with Gordon at our naloxone saturation policy academy, and we said this year we're really going to sort of make it happen in terms of working with my schedule. So again, it's just such a pleasure to be here. And each year that other SAMHSA members have come to this conference, they've come back and said, it is just an amazing conference. The energy, the vibe, the work that's happening across Maine is really something to witness. And so, again, just such a pleasure. We often talk about just the creativity and the ways in which Maine is implementing our state opioid response grant as well as other grants, and creative work focusing on correctional settings, and creative work that's happening within tribal communities and tribal settings. And so again, just so applaud the work that's happening, and know that we are partners. and that you can continue to reach out to us as needed to advance this important work. And so welcome everyone. I mean, it's just a pleasure to be here. To those online, happy to share a quick update and some of the work happening at SAMHSA. I'm going to try to be disciplined and keep my remarks somewhat brief, maybe 15, 20 minutes, I think 20 minutes or so. And then I believe we have time for a couple questions. Is that still the case? But yes, so great. Okay. So real quickly, I'm just going to do a quick budget update to show you a little bit about some of the resources, where we're focusing. Our resources absolutely align with our strategic priority areas. We'll share a little bit of data, and we'll go through that quickly because we've talked, and you've heard a little bit about some of that already in terms of some of the dips that we're beginning to see. We still know there's a lot of work to do there. We'll talk about some policy updates and some of the work happening across SAMHSA in a number of different policy areas. And then we'll continue on and talk about some of our substance use and prevention related work as it relates to addressing overdose. And then we'll have time for discussion. So looking forward to that. In terms of our budget, I mean, this is just a quick snapshot. I've certainly been grateful in my time as Assistant Secretary that we have received consistent resources to be able to continue to address the overdose trends we're seeing, to continue to address the mental health related trends that we're seeing. And our work often is about trying to get it out as quickly as we can in different grants or contracts, and to continue to partner with all of you who really are doing such amazing work on the ground. We often say that we cannot do this work alone, and so our budget is very much about then enacting and standing up important partnerships to be able to advance and partner so that the important work that you all are doing can continue as well. Real quickly, in terms of the President's FY25 budget, there are some areas that, again, align with some of our strategic priority areas that we have asked for additional resources. For example, about $20 additional million we're requesting for the State Opioid Response Grant. We know that that is such a valuable grant. It funds a broad range of prevention, treatment, recovery, harm reduction. And I can say in my job and in my work as Assistant Secretary, I have so appreciated going around the country and seeing the ways in which those resources are meaningfully being used at the community level to outreach and connect with people who are struggling. This work is near and dear to me. It is near and dear to my heart. I have family members that are included within the groups of folks that are being reached out to and connected with and connecting with services. And so, we are all in this together, and I'm grateful for the work that everyone is steeped in. We have an additional $10 million that we're requesting for our harm reduction programs, and we know that harm reduction is so important. We're hearing that is not getting a lot of love right now in the initial House markup, but we are confident that where we land will include additional resources, because we know the harm reduction work is about ultimately meeting people where they are, helping to keep people safe, helping to keep people healthy, alive, and in many instances, we're seeing a lot of work happening related to connecting people with meaningful services and supports as well. In addition, our PPW program, Pregnant and Postpartum Women program, requesting additional resources there. We did recently award about $1 million for the PPW program. And again, we know that is so important because we know it's so critical to be able to keep families together and for women to get connected to the needed services and supports when they're struggling with substances or even mental health challenges, to be able to keep families together to address those needs. So this is just a quick snapshot of the FY25 sort of budget request. We are optimistic that many of these areas will remain. Real quickly, in terms of data, we're like everyone else watching the trends. I think some of the trends that you're seeing here in Maine, when we look across the board, recent CDC provisional data suggests that we are seeing a slight dip in overdose rates. We still have a lot of work to do. They're still far too high. And the fact that they're so high is very much a call to action, right? It's a call to action that lets us know that it's critical that we continue to double down on all the areas that we know are making a difference, expanding those areas, scaling up those areas we know that are making a difference, and certainly that's something that we are committed to. But it is heartening to see that the trends are going in the right direction, but nevertheless, we have a lot more work that we still need to do. When we look at some of the trends just based on substance, what we see is that, continually synthetic opioids, so fentanyl and other synthetics, are driving and continue to drive the trends that we see. Psychostimulants as well as cocaine and other substances as well are contributing. And of course, we see quite a bit of polysubstance use that individuals are struggling with. And so, again, lets us know that the work around continuing to get naloxone and other overdose reversal medications out far and wide, that remains important, as well as the range of work that's happening across the country to be able to meet the needs of individuals that are struggling. Wanting to now, in the next few set of slides, just share some of our resources and programs and initiatives that we have in place, very much in partnership with all of you. We'll share some of the vision related to these works and some of the next steps as well. One thing I wanted to talk about is our overdose prevention strategy, our overdose prevention and response toolkit. There is a QR code there for that. Please help us get this out far and wide. It is such a valuable resource. It is an update of this toolkit, and it includes information around sort of overdose reversal strategies, information about prevention, harm reduction, really quite rich, and you have the QR code there for that. A lot of content related to responding to an overdose. We know that is so important. It's not meant to replace the training, naloxone and training related to other overdose reversal medications, but it is a really important, I think, addition or addendum to some of that work. So please help us get it out far and wide. That you have the QR code. It's also available on our website, so you can download it on our website as well. Wanted to talk real quickly also about our state opioid response grant. We did recently release that grant, so I know folks, states are working on that, territories and also our TOR grant, tribal communities, are working on that as we speak. There are a number of changes that were included in that, very much in response to what states were sharing with us. Typically, TOR was a 2-year grant. We have extended it and made it a 3-year grant because what we were hearing is that it's a lot of resources, and sometimes with hiring or just the range of like setting up different programs or initiatives, a 3rd year would be helpful. And so we figured, we can definitely do that. This new TOR grant also builds on and really stresses the importance of continuing to do the work around disseminating naloxone and other overdose reversal medications far and wide. States are working on and developing plans related to that. Quite a bit of focus also on the importance of really looking at the full continuum. So not just adults, but also thinking about addressing the needs of young adults as well. Unfortunately, as we look at the data and some of the trends, we are seeing overdoses at younger and younger ages. And so so important to be able to address the needs of young adults. And it's been wonderful to see the work in terms of standing up and disseminating naloxones within school settings as well. Also, a lot of language in there around really taking a total person approach, and then ensuring and expanding access to medication for opioid use disorder. One thing we've been really, really pleased to do is to work with states around naloxone saturation. That we've been holding policy academies. And the goal of the policy academies is wonderful. States will bring forward planning teams, and then the teams develop plans related to getting naloxone out far and wide. We last week just held our 3rd naloxone policy academy. Maine participated in our last policy academy. And in addition to the academies, we have we call them the learning communities. So there are calls in which states who have participated in the policy academies, as well as others, can come together to share content around sort of what's working, what's not working, and to be able to continue to move their work and move their plans forward. So really excited about that work and so appreciative of the partnership with everyone along those lines as well. Just to share a little bit of data, we have seen an increase. So naloxone is getting out there. And we know that's so important. We want, if somebody is struggling, we want them to be able to, and the people around them to have naloxone to be able to intervene. We have seen a 36% increase in the dissemination of naloxone over a 2-year period. And so again, I so applaud the Maine team, whether it's the community providers, the work that's happening at the state, because it's making a difference in terms of continuing to ensure that naloxone is available. So thank you for that work. In terms of just some of the trends, I mean, when we look across both SOAR, so the State Opioid Response Grant, and the Tribal Opioid Response Grant, and when we look from 2018 to the end of last year, what we find is about 1.3 million people have been connected to services and supports, and about 9.9 million naloxone kits disseminated. And so that is, I'm just so appreciative of the dedication and the passion and the commitment that's happening at the community level and with states to be able to get this life-saving, overdose reversal medications out far and wide. Also quite a bit of work related to disseminating fentanyl test strips. And we know they make a difference as well. What we're hearing is that people appreciate being able to test substances, to know what's in them. And so quite a bit of work around disseminating and making fentanyl test strips, as well as xylazine test strips. They can now be used, or our federal funds can now be used to purchase xylazine test strips as well. And we've seen over 550,000 overdose reversals. And for me, I mean, it's heartening because it means over 500,000 more individuals that have the opportunity to experience long-term recovery and to reclaim all those things in their lives that are meaningful to them. So I'm grateful again for the work that's happening at the community level. Want to talk real quickly also about our harm reduction work. I'd mentioned earlier that we are requesting an additional $10 million for our harm reduction and community engagement related grants. Some of how this came about 2 years ago now, maybe 2.5 years ago. Rahul Gupta and I did a roundtable after the RX Summit. And one of the things that was shared is that, people want to see more grants at the community level for small organizations that are already doing this work to be able to do more harm reduction related work. And then members of our prevention team also heard similar things that, we really need to get additional resources out far and wide to recovery organizations, to harm reduction organizations, to state health departments, just far and wide. And so this grant will ultimately award an additional 82 grants. We're planning to be able to reach about 181,000 additional individuals. And so we are optimistic that will remain in our budget, in the final budget, but we know it has a way to go. Also, we're continuing to fund the Harm Reduction TA Center and then looking to develop guidance around the intersection of harm reduction and recovery. We were really excited earlier this year to be able to convene and bring together individuals from the harm reduction community and the recovery community to sort of share space together and really unpack what are the important areas of overlap? What are some of the areas of difference? And what are some areas that the two communities that ultimately sometimes have different visions, but have a lot in common as well? What can be done together in a shared way? And so we're really excited about that work as well. In addition to that, stay tuned there, because we're looking to continue to bring the groups together to continue to work on and develop some areas of common work. Last month, actually might have been about a month and a half ago now, we were so thrilled to be able to announce the winners of our first ever Fent Alert Challenge. And what this was, it was a challenge that we put out to young folks, 17 years of age and under, so 17 and under, around sort of developing messaging, like help us, please help us with messaging around the importance of raising awareness about the dangers of fentanyl overall, within fake pills, within other substances. Send us your ideas and let's develop and work on developing ads and just awareness raising events and content together. And so these are the winners. We had 21 individuals overall, 6 first place, and the remaining individuals were the second place winners. They did receive additional resources to help to continue to advance their ideas. The content is available now on our website, and so you all are welcome to access that, share that as well. We're going to play a really, really brief video. It's just a clip of snippets from the 6 winners, and so I think we have a link to that in the slides. Oh my. Maybe I'm not able to play it. Oh, they have to do them back. So is that possible? I'm not sure who's running the computer, but if you click on that video clip link, that should take you to a quick video that is just a compilation of the Fentanyl Alert Challenge. The young people were amazing. I mean, what they sent in, it was just so creative, and quite honestly, we were a little bit stressed out trying to pick 6 winners because they were all so good. But hopefully we can play that, and then if not, we'll make sure everyone has access to it. Yay! Oh, you guys are awesome. Thank you.
Never asked how you was doing, now I'm seeing it was better you was doing. Man, I always thought that you was stronger, I thought you was a father. You had something to lose, who gon' care for your daughter? Stay strong, that's what you was telling me to do. Now I'm staring through your window, seeing your body turning blue.
Escape Room, Maryland.
7 out of 10 fake prescription pills seized by the DEA contained a potentially lethal dose of fentanyl. With no luck in finding her at school or her favorite hangout spots, you decide to search her bedroom for any kind of clue you can get your hands on. With time ticking, you have to find your friend before it's too late. Can you do it?
Narcotic Nightmare Game, California and Hawaii.
We would like to introduce our new game, Narcotic Nightmare, which allows youth to investigate the fatal formula inflicting the main character in the game's plot. In the game, players act as investigators, tasked with uncovering mysteries surrounding various substance-related deaths.
Project Fentanyl, New York.
Over 90% of American teens using social media on a regular basis, it is a great place to promote fentanyl awareness. My videos feature 3 different fentanyl-related topics that all teens should be familiar with. These topics are fentanyl overdose symptoms, the benefits of naloxone nasal spray and how to properly use it, and the dangers of fake pills and emerging drug contaminants.
Safe Youth Ambassadors, Florida.
For over a year, we've researched fentanyl facts that we thought teens could relate to, with a focus on the dangers of counterfeit pills bought on social media. We met with police, legislators, and victims' families, and then combined all what we learned into a 9-minute multimedia presentation to share with our peers.
Show, Don't Tell, New Jersey.
The best way to educate teens is to encourage young animators to create short animated videos that visualize the symptoms and effects to give teens a deeper understanding on how fentanyl affects one's body.
Congratulations, winners. To learn more, visit samhsa.gov/fentalert.
Yeah, aren't they amazing? Yeah. Thank you. They just did such a great job. We were just so proud of all of the content that came in. Again, it is available on our website, so you're welcome and free to share any of that content. We are looking to hold a youth summit in the fall, and so that will be another opportunity for some of the youth to come together again, and so really looking forward to that. We're also looking to, in terms of just other resources, you may have heard about our Screen for Success app, and so we are looking to update that to have additional content for providers, additional content for parents, more vignettes, So excited about that app as well. And it's been award-winning. It's won some awards, so do take a look at that. That also is available on our website. Also wanted to share, 42 CFR Part 8, as you know, that we updated that. It had been, I believe, 20 years or so since it was last touched. And so just so pleased to be able to get that over the finish line. We were so grateful for all the feedback that we got related to that. It does go into effect October 2nd, so it's coming up. Again, you do have the QR codes. I love seeing the phones go up and folks getting that information. Aren't QR codes like amazing? They're just amazing in terms of being able to share info quickly. But some of what we're looking at to work on there moving forward is just working with states around and communities around and OTPs around implementation and any work that may be needed there with respect to implementing 42 CFR Part 8. And we will be sending out a letter soon, and then we anticipate meetings and some of those webinars and convenings starting in August, so stay tuned there, which is like right around the corner. Real quickly, ESPERT was mentioned earlier. I won't spend too much time here. This is such an important grant, though, in terms of being able to identify folks early and then ultimately connect them with services and supports. We see some areas where like the data goes right in the direction that we would want. Other areas that suggest, sometimes with 6 months, people may need a little bit more time for some of the pieces to sort of see impact. But overall, we were really, really pleased to see, some of the changes and improvements with respect to a couple of the areas there. That may be a different slide than the one that we were planning to. But nevertheless, ESPERT is an intervention that we're committed to continuing to advance and move forward. I'm going to try to go through these last two pretty quickly because I do want to leave time for discussion. The other thing that we were really pleased to get out is our core curriculum elements for substance use disorder. One thing that we know is that training programs could do a bit more, right? Could do more with respect to training individuals to be poised and ready to be able to address substance use within their practices, whether it be primary care physicians, nurse practitioners, really across the board, even within psychology, psychiatry. And so this core curriculum, it outlines just areas to sort of consider and areas that are critical and important to include within curriculum, including sort of history, overview of SUD, screening strategies, treatment strategies, and so we're really pleased to get that out as well. And there's a QR code that can connect you to additional information there. Almost lastly, I think there's one more after this, but we are so thrilled to bring back our Recovery Star Awards. The Star Awards are, you can nominate folks who are in recovery with lived or living experience, and ultimately it's just an opportunity to honor the great work that they're doing in terms of bringing hope, helping people to find recovery, to stay on the recovery journey, to navigate services and supports, and so certainly that is an opportunity to recognize folks. And I believe that it just closed, but we will be honoring folks in September, so stay tuned there. And then we have our Art of Recovery, and so that's something that we're probably going to do on an ongoing basis, but we did receive over 300 submissions, and what we asked for there was folks to submit content related to recovery and just express it through art. And our intention is to develop an online gallery related to that. And so again, thank you so much. So appreciate the opportunity to be here. Appreciate the work that you all are doing. And I'm going to stop there. And I believe we have a bit of time for questions. Yeah.
Microphone up front here. Use the microphone.
And Gordon, you just let us know how much and how much time, and because I want to be respectful of. But I come from a big family, so I love the discussion. I don't want to. Yeah, and I know you all are steeped in the work, seeing things, have ideas for ways to advance. So definitely looking forward to questions.
Thank you. I'm Representative Scott Searway from Albion, Maine. I've been a senator for 8 years and then went to rep, and now going back to Senate. So I've been on the opioid task force. So I just, lately I've seen a lot of suicides, hangings. We had 4 in one day in one town. So that just happened last week. And then we had an officer, thank God for Narcan. There was a lady that was stumped over the steering wheel, and she had her foot on the pedal, and she was unconscious. He reached in to shut the car off, and he got exposed. He barely made it to the cruiser, and Narcaned himself, and so he did get recovered, and so thank God for that. So I know the Narcan, there's a new one out like 5 times even stronger than what we've been dealing with, and I don't know what's being done with that. And also, is the suicide being counted on the overdoses, or how's that work?
Yeah, and so it sounds, my sense is that states may manage that a little bit differently. It sounds like here in Maine, it is counted, and Gordon can share more there. I remember in Connecticut, if it could be teased or sort of figured out based on the scenario, then certainly was included. I think really what it lets us know is that there's more that we need to do to really let people know that there is support available. And that's why I think the 988 work and helping people to know that 988 is not only for folks struggling with sort of mental health related crises, it's also for folks struggling with substance use related crises, or in addition to suicidal ideation or any other mental health challenges. And so some of the work over the next, certainly moving forward, is around sort of continuing to build out that part of the messaging to let folks know that if they're struggling with substance use as well, please do call 988. Maine, again, has done such a fantastic work here. Across the country, we see 10 million. We just hit 10 million calls, texts and chats that came in over 2 years. But certainly, I think there's more that we need to do there, because our numbers for both, for suicide as well as for overdose rates, are too high.
Thank you.
Thank you. Thank you for your work. One thing I will share, in addition to the line, what's been important to us is it's not just about making sure that the call centers are strong, it's also about continuing to build out the rest of the care continuum. So, the director mentioned it earlier, we're also continuing to expand CCBHC, so Certified Community Behavioral Health Clinics. They are so important because for folks that do need to connect to additional supports, it's important that they have somewhere to connect. And so CCBHCs are one opportunity, in addition to expanding mobile crisis, so that there is somebody, there is a team that can go to them if necessary. And then the stabilization centers, we're seeing that as an important goal as well, and supporting that as an important alternative, right, to emergency departments. We know not everybody needs an emergency department, but a stabilization center may be really helpful. So, thanks.
Good morning. Thank you for coming all the way up.
Good morning. Good to see you.
You're
You're everywhere, because I saw you 2 days ago in DC.
That's right. But back in my home state, thankfully.
Yes.
So I wanted to, I guess it's more of an encouragement or a shout out for the suicide prevention strategic plan that was just released. There's not a QR code for it, but it's fantastic. And so I wanted to encourage you to highlight that, since there are so many good strategies, and that SAMHSA and Suicide Prevention Resource Center and others did such a good job, including the Voices of Living Experiences throughout that process. So I thank you for that, and wonder if you wanted to say a few words about it.
Yeah, thank you so much. No, really great flag. And please do take a look at that. It is a new national strategy, so our 2024 National Strategy for Suicide Prevention. It comes with an accompanying federal action plan, And that federal action plan has over 200 items that are sort of in the process of being worked on or that are coming up to be worked on related to suicide prevention. I think it also is a really valuable blueprint for the rest of the country in terms of different areas to think about implementation. At the community level. So take a look at each of those, the 2024 National Strategy for Suicide Prevention and then the federal action plan that goes along with it. I think each provide really valuable content for areas to move forward. So, but thank you. Thanks for that flag. Great to see you.
Just these 2 questions.
Hi.
Okay.
My name is Lynn. I've lived both sides of this coin. April 5th, 1997 is my sobriety and recovery date. Okay, thank you. It's not about me. It's about helping others. So I've seen with my own, my problems and my addiction, and it is person fit. Not one person is going to help get recovery from another one because we all live different lives.
Yes.
What I do know, what I've learned in my classes years ago, was that it is about the brain. It's what we want to escape from. What children go through. And I certainly had my escapisms. And today is definitely above all because people want to play the games, want to be attached to the cell phone at the hip, which is a great idea for some of those programs to get the teenagers involved. Yes. Get them involved, get them right where they're hitting. And so, but yes, we need more in-house. In-house. We need places for people to go to get help so they can recover. Thank you.
Yeah. Thank you so much. Thank you for your...
Austin's also state legislator.
Yeah.
So he'll be the last question.
Okay.
Austin, go ahead.
Thank you, Madam Secretary. Austin Terrio, State Representative from Fort Kent. Quick question and wanted your comments. I like that we're talking about dual diagnosis and increasing access to that, but I still sense, and at least from personal experience, a lot of people I'm dealing with have really underlying mental health challenges, and there still seems to be a huge separation between and a lack of wraparound services. So when somebody goes into a detox bed, for example, they may not be able to manage the detox because of the mental health issues they're dealing with, and they get kicked out and they end up back on the street. So wanted your thoughts on how we really have to move forward in that direction to look at this not just as one or the other, but both.
Yeah, thank you so much for that question. I mean, I think that is right on, that, often we know people are struggling with both. And so increasingly we've been looking at that, like what are some ways that we can increase the opportunities and the chances of people being connected to co-occurring services and supports. So one thing, CCBHCs, so our Certified Community Behavioral Health Clinics, it does provide an opportunity for people to receive both mental health and substance use related treatment and services if needed, as well as to be connected to any other primary care services and supports. And really that's sort of the hallmark of that model. And we've really worked on sort of strengthening the piece around addiction. So for example, now it's a requirement that addiction professionals are part of the treatment team. In addition, a requirement more focused on sort of harm reduction, medication for opioid use disorder, to really bring that into the model more. In addition to that, CMS and SAMHSA a little bit, there's a new model we call IBH, the Integrated Behavioral Health Model. And through that model, it's, again, another approach that's taking a whole person approach to care. That is actually an 8-year grant, and so it's quite a bit longer in terms of the amount of time. But it is an opportunity, again, to build out those integrated sort of models of care. From a community-based perspective as well, that's also an additional requirement of the grant. But again, appreciate the question, and it is definitely an area of needed focus. And some of our training and TA centers are focused there as well. So, great. Thank you so much, everyone. Thank you. Thank you both. So good to see you.
Thanks. Please don't leave, because Sarah's been so kind, first voice of recovery, to wait an hour, although she was a little nervous. So, and I do, just before introducing Sarah, I do want to introduce our fabulous team from Region 1 in Boston, the regional director, Everett Hanford. Everett and the talented and capable Taylor, Brian Turner. Taylor is also the regional director for HHS and works closely with Everett. And Tamika McCants is over here. She's a communications person. And our own, now transplanted to the federal government, Scott Gagnon, who's the new Region 1 SAMHSA regional director. Scott, stand. I want to acknowledge we have a lot of legislators here, and for fear that I'll miss some, I'm not going to introduce them all. I am going to introduce the chair of our Health and Human Services Committee, Michelle Meyer. Michelle's a nurse. She does a fabulous job chairing that committee. She's sitting with former Senate chair of that committee, Dr. Ned Claxton, former state senator. I know Scott's here, Austin's here, Nina may be here, Lydia Crafts is probably here. But again, I fear that there's more than I know about, but please do give them a hand. This is an important branch of government for us. I think with that, our first voice of recovery, and it will be followed, we've got 27 voices today, but Sarah's been with us before. She spoke before the governor in Bangor 2 years ago. She's been on the cover of Journey magazine. She's the star of one of our recovery films. So I feel like Dustin from the fishing industry and Chantel, we've made celebrities of some of our fabulous people in recovery. So thank you for staying to hear Sarah's story. And then we'll break, and then we'll start those breakout sessions as close to 10:15 as we can, and then be back in here for the governor at I think 11:25 maybe. Sarah.
Hi, everyone. Thank you for staying and listening. My name is Sarah Langevin, and I'm an addict. I was raised in Mattawamkeag, Maine, a really rural area in Maine. I am an only child. I grew up with everything that I needed. I was very loved. I had lots of friends. I had good grades in school. I was a cheerleader and played multiple sports. I was a happy kid. My community loved me and helped as the village to raise me. In middle school, I started to question everything. Where I belong, do I belong? I started experimenting when I was 12 years old because everyone else was doing it. I could have never known the way that my brain would chemically and biologically react. I was hooked to it all, to the risk-taking, to the relationships, to eventually substances, starting off with marijuana and then into Adderall and painkillers, and eventually substances like crack cocaine and heroin. I suffered through being homeless, being in abusive relationships, being on probation, and losing my license. While I was spiraling, my father was struggling with his mental health and also self-medicating and became an active alcoholic addict himself. I was tired, lonely, and scared. I had suffered through multiple miscarriages in my journey, wondering each time why I couldn't just stop. I wanted to stop. But this grip that these substances had on me, I had no idea how to do that. I searched for a long time. My family began to mourn my life for what it once was and what it could be. They had lost hope. I tried to do it on my own. I purchased Suboxone off of the street, but that wasn't enough. I met my now husband and decided to change areas, but that wasn't enough. I got word that my dad had lost his battle with mental illness and had taken his own life. Everyone had judged me, but that still wasn't enough. A few weeks later, I found out that I was pregnant again. At that moment, it felt like all the weight that had been piling hit me at once. I don't know if this one thing was enough, but I had enough. I'm Sarah Langevin, and I'm a person in long-term recovery. So I had set out. I was now strangely determined, tired but determined. And I was calling all over to find some kind of help, some resources. And I found some, few and far between, and 2 hours away from where I was living. 12 years ago, a doctor had helped me stabilize my dose of Suboxone. I was able to go without substances for a few years, becoming healthy and having 3 more children. But I didn't feel like the void I had been trying to fill was actually being filled. For me, I was trying to fill a God-sized hole with everything but. There are many different avenues to recovery, but faith in Jesus are mine. I began to put in the work to find out who I really was after all this time. I began living my life. Then others wanted to join me, asking, how did you get sober? How are you doing it? You look so much better. You're like a whole new person. So I shared everything, where I was, where I wanted to go, and what had helped me so far. I started a life recovery meeting at my church so that like-minded friends and family and community members could come together. I first sat alone and cried because it's scary at first. Then one person came and another, and now we have up to 30 community members that come regularly to celebrate their recoveries and find their voices. Then more people who wanted to learn and ask questions. They became lawyers and recovery advocates like me. Things started to change in this state. Laws were made and changed. Resources started spreading across the state, and this wonderful community of amazing people came together. We educate, we share, and we have a voice. We make changes, and we bring back hope. I'm Sarah Langevin, and I am a professional in the recovery community. What was once on my record is now on my resume. I was able to lean on this group of people. I was able to lean on this group of people. I was able to learn how to take everything I had been through. I was able to learn more about this disease, to become a professional in this field. I had not been to school. I have no fancy letters after my name, but I do have a voice that I am learning to use and learning how to help others find theirs and use it. I was able to become a professional peer recovery coach, grow and educate myself and others around me. I volunteered my time, years of my time, and I truly loved every minute. I was able to then make connections, join a board in my community, and help build a recovery center from the ground up. Some of you may have heard some of my story 2 years ago, and I was pregnant with my 5th child working at this community center. Something that still happens is life, even in recovery. This is why we have recovery communities to support, educate, and love, and so much more. I gave birth to my daughter Pearl shortly after I spoke last year, and she unfortunately passed away 9 days after she was born due to chromosomal issues. This was the first moment in 12 years that I can honestly say I thought about using. I knew no one could blame me, that this was a horrible thing to go through. This was my golden ticket. But I didn't. I decided to use what I had learned, to use my support I had created and built, and that God had provided for me. To say I'm grateful for my church, my community, my recovery community, supportive family and friends would be an incredible understatement. When I no longer could save myself, God stepped in, giving me these people that I once had and taught to have me. They picked me up. They believed in me. They loved me. I was blessed with an incredible opportunity to join an amazing group of professional people in an outpatient treatment facility. I was able to really put the saying that what once was on our records is now on our resume to work. I was valued because of the hard things I had been through and the way that I chose to overcome them. I became a licensed peer recovery coach with the state and community outreach worker. I opened 3 different satellite offices, and I had learned a lot about workflows, operation, billing, something I never thought I would do, as well as patient care for patients just like I was that day I called and was ready to change how I was living. It has truly lit a spark in me that I had been doubting since junior high. This is where I belong. I wish I could say that I was something special. While each life is precious, anyone can do what I did and what I do. Anyone can find their voice, step away from addiction, and become what they once imagined they'd be. Our state, lots of you in this room, helped create something that has saved my life. On more than one occasion, has saved my family and countless other lives and families. I want to end with saying thank you for believing in me, trusting in me, and teaching me. I want to thank you for allowing me to speak on platforms such as these in hopes that more people we love will step forward. Your community cares about you. We are here and want to help you grow, want to love you, and God wants to bless you. A very special friend of mine once said, "Where there's breath, there is hope." Thank you.
Nothing to be said, nothing left to be said. Proceed to your break, visit our exhibitors, try to get to your breakout session in the next 10 minutes. We'll see you back here with Governor Mills in an hour or so. that voice is. How was that? That's what I think.
Some bright radios.
Yes. Well, thanks for being here. We'll get this started. It's kind of transition period. But we wanted you in the main. And the good thing, remember, we're recording this in the live stream. So people can watch it over and over again. Hey there.
Do you know if Jack's on the table here? What's happening? It's too crowded. Everywhere it's too crowded.
Yeah, well, it's busy. I mean, it's we're all over the place.
How is it standing here?
It's good. It's an upper farm church.
Still visible. So your daughter's
Appreciate it. Gordon, I know you're being pulled a lot of different directions, but I want to shoot Ghetto.
Hi, how are you?
And she's working on some important things. I hope you guys have an opportunity to see
We have some avenues. We've got to break up what we advocate for adolescents.
starting his first year. He's really excited because presidential campaign is the first one he's
So, I mean, the tax credit.
and he feels like he's going to be on the ground in the district.
Because I'm going to be craft.
Our one seat.
To help you. Yeah. That's a big lift.
So we have
We've looked at it. But I'd be happy to talk to you about it. Tell you what we know about it. And what we can, and what it would take to get it. But thank you for the introduction and thank you for being here. Yeah, if you'd take your seats, we want to start the Jackson Lab program, and it's really hard to do that while you're milling about. So try to make it to your next session. If Brian Massey is in the room, I need to, there you are, Brian. Come on up, I want to talk to you.
I still live in Maine. My uncle's doing There he is.
All right, here we go.
So, good morning, everybody. Those of you who are here to learn about current research in precision medicine and addiction, you are in the right place. Feel free to come up to the front or stay where you are. My name is Michael McKernan. I'm the Director of Government and Community Relations at the Jackson Laboratory, based in Bar Harbor. Just a brief word about the Jackson Laboratory, because as I travel around Maine and speak to members of the community, I often ask, what have you heard of the Jackson Laboratory? And most people say, yeah, I've heard of Jax, and I think what they do is a good thing, but I don't actually know what it is they do or why. So I'll tell you just a little bit. So the Jackson Laboratory is an independent, nonprofit biomedical research institution. Our mission is to discover precise genomic solutions for disease and empower the global biomedical community to improve human health. And so from its base in Maine, JAX is empowering the global biomedical community through education, through its mice, and I don't want to steal too much of thunder from my colleagues, but also through its genetics research. And I'll leave that information to the experts. So in addition, Maine's biomedical research community includes institutions like the University of New England, and we're delighted that Dr. King is with us today, as well as Maine Health Institutes for Research, the University of Maine, and many others. Several of these institutions have projects focused on the biological origins of substance use disorder. And while broad understanding of the biology of substance use disorder is critical, research is increasingly focused on personal genetics. So the last voice of recovery reflected on her own personal story and how perhaps her personal biology had an impact on how she experienced the disease. Including genetic background, including environment, these things come together to provide a more holistic picture of the complex biology of substance use disorder. So today we have assembled an expert panel to share some of the important work they are doing in their own labs and centers. As a panel, we know that this is a very heterogeneous audience, including fellow researchers, some physicians perhaps, and others who have some knowledge of these topics, but then there's probably some others in the room. We're very happy to get out of high school biology with a passing grade. So we're going to try to be aware of that and present information in a way that's interesting, engaging, and encourages you to ask questions. Everybody here on this panel is a teacher by heart, so please don't be shy. Ask any question that comes to mind. So to make that easier, what we've done is we've have a Slido opportunity, which means that using your device, you can log on to Slido using that hashtag and then type in your question anonymously. If at the end you wish to come up and use one of the microphones and ask a question in person, that's perfectly fine too, and I will moderate the questions from the podium. Okay, that's enough from me. I'd like to just run through who's on our panel today. Our first speaker is Tamara, Professor, Department of Biomedical Sciences in the College of Osteopathic Medicine at the University of New England. Our second speaker is Jason Booyer, Senior Research Scientist, Center for Addiction Biology at the Jackson Laboratory. And our final speaker is Vivek Kumar. Vivek is Associate Professor, also in the Center for Addiction Biology at JAX. So each speaker will present, and we'll open the floor to questions at the end, and we'll get going. Dr. King. So, at your advance. Yep.
All right, thank you very much. Those chairs are very, very tall. It is my pleasure and my privilege to be here and be a part of this panel. I'm looking forward to a discussion and hearing people's questions. As mentioned, I'm a professor at the University of New England, and I'm the director of the Behavior Research Core. So today we are going to be covering some research learning objectives to really start to talk about the biology underlying substance use disorder. So where do I come in? My research is actually on pain and chronic pain. And as many people are aware, those pain and substance use disorder often intersect. And so I want to talk a little bit about the biology, what we know, and maybe what we need to learn about that. So An important aspect of substance use disorder is that substance use can be driven by changes in pain, in isolation, and negative affect or negative emotions. But what a lot of people don't often know is that substance use by itself can actually induce pain. So, opioids can create something called opioid-induced hyperalgesia, which is a hypersensitivity to pain, and this develops during use, so while the opioids are being taken, and if you withdraw the opioids, that pain and any pain getting treated becomes worse. Alcohol use is also associated with development of pain, and again, when you remove the alcohol, the pain gets worse. And more research is finding that cannabis use also can induce a state of pain, and again, withdrawal is associated with heightened pain as well as emotional pain. And so what happens is you try and quit, you remove this substance, or you stop taking it because your pain is supposed to have gone away, and you're in pain. So what do? You go and take the substance again. And of course, this creates the negative spiral that so many people talk about. So as I said, my research focuses on pain. So why? The burden of chronic pain is enormous, okay? So according to a recent analysis, about 1 in 5 United States adults have experienced or reported chronic pain. That's an enormous number of people, and it's larger than heart disease, cancer, and diabetes combined. The financial burden is enormous as well. Over $600 billion annual is spent on dealing with pain and chronic pain. This is medical costs, but also loss of productivity. And again, this is exceeding the costs of heart disease, cancer, and diabetes. So it is a pretty major problem. And in order to deal with this problem, what we need to do is learn more about it, because we just don't have a full understanding to adequately prevent chronic pain or to treat chronic pain. Treatment of pain is currently done pharmaceutically through 2 broad classes. Many people are familiar with the first one, opioids, right? So this would be your oxycodone, morphine, fentanyl. However, one emerging problem is that the rise in opiate addiction, overdose, and deaths have led to a significant reduction in appropriate opioid prescribing, leaving many patients in pain because there are no good alternative drugs. What are the alternative drugs? Those are the quote-unquote non-opioids. These span a lot of different classes of pharmaceuticals. So most people are familiar with NSAIDs like ibuprofen. Gabapentinoids and SNRIs are used to treat chronic neuropathic pain and is effective in some but not all patients. And some people can use peripheral nerve blocks such as lidocaine or capsaicin creams or patches. However, these are not optimal, and there are many patients, even on these therapeutics, that remain in pain and are seeking to alleviate that pain. And so what are we doing? We're looking for the answers. To do that, we need to build and expand upon what we already know. And we actually know quite a bit about the neurobiology of pain. So we have discovered a lot about the molecules that transduce the environmental signals to a neural signal that transmits this information through the spinal cord to the brain. We've learned a lot about how this signal is processed, leading to the perception of pain, how it's modulated, how the brain can amplify or reduce pain depending on the context or the situation. If you're running away from a bear and you scrape your knee, you don't want to be focusing on the pain. You want to be focusing on getting away from the bear. We learned a lot about the endogenous mechanisms by which that can happen. One thing that's becoming more and more evident is that opioids and cannabinoids overlap in a lot of these areas and a lot of the biology underlying the neurobiology of pain. And so they are found in the same peripheral tissue, the spinal cord, the brainstem, the limbic structures that mediate the emotional component of pain, and cortical structures that are important in decision making. Do I escape? Do I avoid? What do I do? And what do I do in the future? They are also found in the reward pathways. So one thing about pain is very, very complicated, right? And we've learned a lot about the sensory discriminative aspects of pain. These are the things like the intensity, the duration, location. But we still need to learn a lot more about the affective motivational aspect of pain. This is the unpleasantness associated with pain. And this is what motivates us to escape, avoid, and teaches us, don't do that again. Pain relief feels good. So pain relief has been shown to elicit reports of that feels good in patients. Moreover, it activates the reward pathways in the brain of both humans and animals. And so we can use this information to better assess and create better tools to figure out what's going on. So the motivational aspects of both pain and reward are included within the same areas of the brain. And so this creates complications when you're talking about the intersection of pain and substance use disorder, because they impact one another and your brain changes in response to both of these inputs. Both humans and animals will escape something that they find painful, and both humans and animals will approach something that provides pain relief. If I have a headache and I'm a migrainer, I have learned over time what medications help. Caffeine helps, blocking bright lights helps. Okay. And one of the things that I've done in my research is I've applied these concepts to animals to show that pain relief in animals, in our rodent models of chronic pain, can create a preference for a novel context that has been paired with pain relief. And this happens both in postoperative models, but in chronic pain models too. And this opens up a whole new arena in which we can learn more about what we don't know a lot about, the emotional component of pain. We've also shown that pain relief will actually actively activate the reward pathways. And this can allow us to gain more interactions of how does this change in the context of chronic pain? How does this change in the context of chronic substance use? Maybe we can get a handle on this and treat both. And so this is the goal. If we can improve our treatments of chronic pain or pain in general, maybe we can come up with alternatives that are more specific, more comprehensive, and doesn't leave people in need and in search of alternatives. We also need resources to do this. And the NIH has put forth something called the HEAL Initiative. And this initiative has two primary goals. One goal is to improve understanding, management, and treatment of pain, because this might serve as a powerful prevention tool. The second goal is to improve the prevention and treatment of opioid misuse, addiction, and overdose. And this is happening at a very lucrative time. We are really in a new era of research, very exciting times. So we have advances in genomics and proteomics that is giving us so much data on molecular entities and pathways that may be optimal targets for both pain and substance use disorder, and maybe allow us to figure out where do these intersect. Many people are turning to pharmacogenetics to try and figure out how do we create more individualized and specific therapeutic options for patients. Because as you heard earlier, pain is an individual thing, substance use disorder is an individual thing. And there are biopsychosocial models that try and take into account these different aspects. I work on the biology, but we can't ignore these other aspects because they impact, guess what, the biology. Finally, the emergence of artificial intelligence is getting better and stronger, and this is a critical tool in analyzing the enormous amount of data that are coming in, both with the proteomics and genomics, as well as looking at, I think it's the next slide, using large language models to determine and analyze what patients are saying about their pain so that we can get a better understanding of what they're going through. And that might lead us to novel targets within the brain that we can better understand this. And we are also using these tools within the preclinical setting to better analyze behaviors that we might associate with pain. And this is true in humans as well as in animal research models. This is going to allow a higher rate of translation from the bench to the bedside and hopefully get tools in people's hands that are trying to treat both of these issues. And so with that, I will end and allow my colleagues to speak. I'd like to acknowledge the federal funding that I received from NIH. I am part of the NIDEA Award, which is to expand research opportunities and infrastructure to states that don't receive as much funding as our close neighbors. And we have built a center of excellence for pain research that I'm a proud member of, and we hope to keep growing. Thank you.
Good afternoon. Thank you for joining us here today. I'm really excited to be able to address you and talk to you about some of the research that I'm doing at the Jackson Laboratory. But first, because this is Maine and we're all 2 degrees away from one another, let's see how we might be even related. I went to the University of Maine at Farmington, so go Beavers. Nice. And a shameless plug for my nephew, who's a nature photographer right there. But I went to do my graduate work at Marquette University, where I got my PhD. Go Golden Eagles, not so exciting. But my family is many generations from western Maine mountains, up in Phillips near Farmington, and it's my pleasure to have a research career in academia. I come from a working class family with very blue collar roots, first generation college student, never mind PhD. So I'm really just an honor to be here. And now I'm showing you a tantalizing view of where I spend my time, and this is the Jackson Lab. A nice view of it. A lot of people don't know it. It's kind of nestled there amongst a national park. It's a great recruiting tool to get people to come live with us. We don't show the snowy picture, but here's an example. So as Dr. King mentioned, opioids can do a lot of things, and some of the things that they do are analgesia or pain relief. But they also target respiratory depression, cardiovascular depression, decreased gastrointestinal mobility or constipation, sedation. They cause euphoria, which is why you keep going back to them, and then urinary retention. Now, all of these things have common mechanisms that are controlling them, such as the opioid receptor. That would be an obvious thing that opioids would bind to. But each of these traits is biologically distinct, and it is possible to actually identify pathways or molecules that will affect analgesia only, but not respiratory depression, or will affect euphoria, no euphoria, and just give you pain relief. So the idea would be to separate these different effects of opioids. Now, as I mentioned, the biological basis for overdose. So I said respiratory depression, that's the big thing that I study because that's basically what people are dying of and you're using naloxone to prevent. You get a bunch of cells in your brainstem. They recognize the fact that you're not breathing well and you're getting low carbon dioxide and the high carbon dioxide and low oxygen, and the opioid causes them to not increase your respirations. Instead, they go down and down and down. And as a result, you're going to have opioid-induced respiratory depression and death. Now, reversal. As we mentioned, naloxone, this is a great molecule, and I'm so glad we're getting it everywhere. And here's just showing you a little picture of a schematic where the opioid binds to the opioid receptor, but naloxone also binds to the opioid receptor and kind of displaces it. And we designed it so it actually binds tighter to the opioid receptor than classical things like heroin or morphine. But a caveat here is, and that's something we need to be trying to stay ahead of, and as researchers we're always trying to stay one step ahead, is that these newer drugs such as fentanyl, carfentanil, they bind also very tightly to the receptor, so you may need even more naloxone to get the effect. So we need to look for reversal agents to supplement this, in addition to continuing to get this widely available. All right, so at the Jackson Laboratory we study mice. Why do we study mice? Well, mice are genetically related to us, similar, about 92%. But the human population, we're all related to each other about 99.999%. And I'm representing the diverse population here by these minifigs. Now, each set of minifigs carries with it their own set of genes, and so we also have a population of mice on the left that is like a population of humans. So each one of those is supposed to represent a mouse minifig or a mouse individual. So now we have mice that are also 99.9% alike, and we can look at them and say, okay, what are their genes in their genome that's causing them to be extremely sensitive? So that bottom line shows that one half of a dose is all that's needed to cause overdose. The middle line shows a full dose is needed for overdose, and then the top shows a lot is needed for overdose. And so this is a very important diagram because we don't know what we're walking around with for alleles, and you don't know what your person you're using with it has either. And so you're sharing a dose with them and use the same thing that they used. I can see where it could lead to problems. Within the mouse room where I can control the dosage and have very pure compounds, there's a 150-fold difference in sensitivity between one mouse and another mouse, only looking at 8 different mice. Now imagine if I look at more mice, how diverge, and that's for fentanyl. Morphine, it's about a 4-fold difference, and morphine and fentanyl work differently even though they're both opioids. All right, so using this system, I was able to identify loci or regions of the genome that when you vary them, you get respiratory depression or you don't. And that was using mice. And then humans have taken and looked at clinical data for using a trait is basically how many times somebody has overdosed and been brought back is the trait, and see how likely, use that as a risk score for how likely they are to overdose. And in those genome-wide association studies, they've been able to identify regions of the human genome that also vary with this particular phenotype or this particular symptom, overdose. So here we have humans and mice, and we can look for overlap between the two of them. Now, why do we care about this genomic knowledge? Dr. King got into some of the pharmacogenetics, pharmacogenomics uses. Here, this figure lists, that it's stolen from a website there, lists a bunch of different uses for the allele, the genetic knowledge. The example that I like to give is being able to know if you should or should not be prescribed an opioid based on your risk. Like, this person is so sensitive, we shouldn't give them that. They should have something else. Or if if somebody is using, how risky is this person who's in your clinic in front of you, can you give them a warning, a heads up, like you're kind of a sensitive individual, and they may already know that, but it's just knowledge is power. Emerging threats, as I said, we have to stay one step ahead. So right now on the street there's xylazine and fentanyl mixed together called tranq. This causes nasty wounds. And xylazine is something I was always familiar with since I've been at the Jackson Laboratory because it's a veterinary anesthetic. We use it to put down mice to do surgeries. And as a result, there is no known reversal agent for humans because we don't use it in humans. And so there's nothing approved to reverse. It binds to a beta-2 or alpha-2 adenoreceptor, not the opioid receptor. So naloxone is going to help you with the fentanyl threat, but not the xylazine threat. So there's where we need to look for another intervention or another angle. And again, something else that's also coming out are these nitazines and derivatives. And by derivatives, I mean they'll just add a methyl, ethyl, or a little, an extra carbon here or extra carbon there, and make different variations of the same drug with extremely different potencies, ranging from 1 to 100 times that of fentanyl. So these are the emerging threats, and we can use this approach to try to find out which genes are involved in those pathways, and those could become targets for either screening or interventions, like what is the human body, what is nature showing us is a mechanism to make you more tolerant to a drug? How can we make somebody else more tolerant to that? So we're kind of using the natural variation in the population to inform us about the biology underlying these traits. So the key takeaways, and something that I was glad to hear the doctor at Millinocket Hospital indicate, that addiction is a disease and it has a biological basis and it's not a moral failing. I have mice that love to use and I have mice that don't want to touch this stuff. What did they do? They didn't go to church on Sunday? No. There's a basis, it's often we talked about these comorbidities. Some of these mice also do have signs of depression, if you will. So there are comorbidities that associate with addiction susceptibility. But like addiction, opioid overdose has a biological mechanism, and if we can understand the mechanism that causes the difference, we might be able to dig in there and find a new target or something to help us help with the situation. And then finally, model organisms give us the ability to try and separate out the different functions of the opioids. For example, separate that pain relief away from the opioid-induced respiratory depression. Or as I like to say, stay high but not die. That's my bumper sticker. All right, that's it. Thank you.
Good afternoon, everyone. My name is Vivek Kumar, and I'm going to build on what Dr. Bouvier and Dr. King talked about and give you some concrete examples of how genetics shapes responses to drugs of abuse. So we should think about addiction as a cycle. Essentially, individuals start off by consuming drug on a social basis, drinking on the weekends, having fun on the weekends. And then slowly it kind of cuts into the weekday. That's kind of this escalation, binge drinking in terms of alcohol. Then the person becomes dependent. When they don't consume the drug, they don't feel well. And they may realize this, that I'm maybe drinking, consuming drugs too much, and they may want to stop. And when they do that, their body says no, and they go into withdrawal. That is a very unpleasant feeling, and person will likely relapse. They'll start using again. And this cycle then continues. A few individuals will go into protracted withdrawal and then recovery. And they, hopefully will stay in recovery to kind of break that cycle. And on the left, we talk about kind of what affects this cycle. So genetic variables, we saw good examples here, affect that cycle. Environmental factors affect that cycle, such as stress. And a lot of conditioning effects affect that cycle. So for instance, certain places are in our brains are associated with drug consumption. And a part of recovery is kind of having some sort of behavioral cognitive therapy to kind of break those habits, right? And so I always use the story. I had a colleague who posted on Facebook that, she hadn't smoked cigarettes for like 20 years. And she put on a jacket. She's had a leather jacket for a really long time, and the first instinct was to reach for her cigarettes in her pocket, right? Same thing, if someone is using drugs in a basement, that place is conditioned with the drug response, and as soon as they kind of go into that basement, there's kind of this, the brain activates its memories, and they're like, oh, I should use drugs. So a lot of conditioning effects are also responsible. So why do we use mice as a model organism? So Dr. Bouvier covered many of the reasons. Genetics is a really important one. I see the slides are slightly, our brain circuits are conserved. Obviously mouse brains are smaller, but we have essentially the same cell types, the same connectivity between brain regions. And we can, if you were to see it, you would see we can control their environment, we can control we can essentially do experiments in these animals at great detail. Okay, so one of the assays that we use is sort of a locomotor activation assay. So let's see, maybe not. Well, yeah, okay. The mouse on the left is not moving, but essentially the mouse on the right has been administered a cocaine, and it's a stimulant. So mice, get hyperactive, and we can use this as a sensitivity measure to the drug. We can, of course, do much more complex experiments, like teach them to press a lever to get the drug, and do more kind of self-administration type paradigm. So with that in mind, I want to give you an example of how a single nucleotide, one base pair in the DNA of the mouse out of 2.8 billion base pairs, can actually affect sensitivity and addiction vulnerability. And these are things we can actually do in mice, but are very challenging in humans. So in 1951, a colony of mice from Bar Harbor, Maine, were shipped to the NIH in Maryland. And these were essentially identical mice. So imagine if we had 100 twins, not twins anymore, but clones, and we shipped 50 of them to one location, kept the other 50 in the original location. And these mice are just, they're breeding amongst one another, but they're essentially identical in 1951. But because the process of DNA replication has errors, it's a process known as genetic drift, there are kind of subtle changes that are picked up. So we then got mice from Bar Harbor and from NIH, and we tested them in 2013 for that sensitivity to locomotor response, right? So nothing has really changed in these. The mice have just kind of picked up a few changes through this kind of process of genetic drift. And it turns out that response is just very different. So I've just condensed a lot of data in about 2 years worth of work here. But the Maine mice tend to have that high locomotor response, and the Maryland mice, the NIH mice, tend to have that low locomotor response. But so then as a geneticist, I can ask the question, well, they were identical in 1951, what has actually changed in 2013? And this is a process known as genetic mapping. We do a lot of crosses, we do a lot of sequencing, and from that, we're able to identify one nucleotide change, and that's that in the Maine mice, you see that TCT, and that codes for phenylalanine, and that changes to TTT in the Maryland mice, and that codes for serine. And that happens in a very specific protein called CYFIP2. It's a complicated name, you don't need to know it. And that is actually regulating that difference in cocaine response, right? So what we've essentially done is identified a pathway and a novel allele or a novel mutation that regulates this kind of cocaine response. Now we can actually ask a lot of interesting questions. So we then we used, again, the resources of JAX to create a precise mouse model. So we went in and we took mice that didn't have the mutation and we created that mutation, and we took mice that had the mutation and we corrected that mutation. So now we have kind of 4 strains or kind of a reciprocal change, and we then shipped it off to colleagues who are really good at studying nicotine. In University of Maine, Alan Rosenwasser and his students study alcohol drinking, and then at Boston University I have a colleague who studies binge eating. Now, it turns out that gene actually regulates all 3 of these phenotypes, right? So going back to this idea of overlapping circuits that Dr. King brought up, the brain, there is no one circuit for taking cocaine or nicotine. It's a common circuit for reward. It's used as a survival circuit, and it regulates many things. A reward to drugs of abuse like nicotine, cocaine, alcohol, but also reward to natural rewards. Food is a natural reward. Sex is a natural reward. Exploration, exercise, these are all natural rewards. And in therapy, we try and substitute a non-healthy reward with a healthy reward. So these are the kind of advantages we have with mice, and these are the kind of experiments we can do with mice. In fact, so we discovered this back in 2013. Over the past 3-4 years, there have been a slew of human genetics patients with mutations in the same gene called CYFIP2. Not the same mutation that we found in mice, but in a different region in that same protein. And it turns out that these are individuals with intellectual disability, epilepsy, really severe kind of developmental disorders. And in many cases, they die. They don't make it past some development. And these are human mutations. So what does that tell you? So really, that gene and that pathway is serving multiple functions. If you have a certain mutation, you have a reward dysfunction. If you have other mutations, you can have very severe neurodevelopmental disorders. So again, advantage of using mice to dissect these complex traits. So so this is just meant to show, so this is the brain, and the different parts of the addiction cycle are regulated by different parts of the brain. But it's a very complex system, basal ganglia or mesolimbic reward circuit, and we really need to study, and we need to kind of, now that we have a gene and a pathway, we can go in and perturb the gene in specific circuits in the brain, and we can determine its function in each one of these parts. So the next part is, Dr. Boubier talked a little bit about this, and Dr. King too, in terms of, can we predict who's at risk, right? This idea of prediction, prediction. So this is an old field. So, we know that there are traits that teenagers show, such as impulsivity, anxiety, sensation seeking, and hopelessness, and these put kids at risk for addiction. There's newer kind of predictive algorithms out there. There's a machine learning one that on the right that was covered by the New York Times that pretty much, it's a proprietary system, so we don't quite know what's in it, but the idea is when you go to your doctor, the doctor uses this machine learning app and predicts your addiction liability, and if you meet a certain score, you're not going to get prescribed opioids. But there's a lot of even polygenic risk scores based on our genetics can we predict what the person is doing. So again, here's where it's a very non-precise field, I would say right now. I would not use these black box algorithms, or even polygenic risk scores are not very accurate right now. But in mice, we can again work on a lot of these. So we can observe behaviors in mice. Can we, based on the behavior and the genetics of the animal, predict which animal will likely show uncontrolled drug intake behavior? So mice, we can observe them over long periods of time and say, well, if the mouse is fighting, or if the mouse has certain behavior, is that mouse more likely to consume drug? So for this, we've kind of again turned to machine learning or AI methods. At JAX, my lab has pioneered the use of kind of digital phenotyping, and we built these very fancy home cages where there are cameras and mice can live in it, and we essentially are, like a big brother type observing these mice for weeks and maybe entirety of its life. So this is what kind of a view of a camera looks like. Here are, 3 mice kind of happily living. There's a wheel, some nestlets and things like that. And we can then use this to kind of extract behavior from this. And this is a process that uses machine learning. We don't need to go into this too much, but essentially we take the raw videos on the left and we end up with kind of abstracted images of the animal. Then we can go from that to look at animal behavior. And so I feel like this, and we can then correlate that behavior with drug intake behavior, with genetics, or many other things. So this is, I think, a new field that, in my opinion, is going to have a lot of impact. Okay, I'll stop there. I'll just say one thing, which is funding. For my postdoctoral work I've been funded by NIH. It was great to see Shamsha here. I think, the National Institute of Drug Abuse and the funding that they brought into this area is really important and deserves our support. Thank you.
Okay. Hello. All right. Thank you all. Fantastic introduction to the topic of the day. We have time for some questions, and I've asked that so the slide is back up there. Thank you. And feel free to use your device to go onto Slido, or help yourself up to one of these 2 microphones, and we can start our discussion. So, oh boy, I think I lost my slide here. Anyway, I showed you the question earlier, so we'll remember it, right?
Of course.
Okay, so somebody asked a question regarding cannabis, and I have to log in to find that question again because it logged out. Do you recall?
I think I remember, yes. Hi, so it was an excellent question, and I actually have a little story about the question. So the question was that I had mentioned that cannabis can be addictive and lead to substance use disorder, but that they had heard that cannabis is not addicting. And this is very, very common. In fact, I worked with my daughter, who just graduated high school this past year, on educating their peers on this very topic because so many were coming up. Oh, well, here's TikTok, and TikTok told me cannabis is not addicting. Cannabis is legal. So we know everything about it, right? We know how safe it is and everything. That was my sarcasm hat. And so, I think this is very common, and I don't think it's an easy yes or no answer. We just heard a tremendous amount on genetic variability, individual variability, and I'll remind you that biology is one component of a complex system. So we have genetics and biology, we have social determinants, right? Social networks, what's going on in that person's life, what's going on at school, and we have psychological factors all contributing to whether or not a substance could be addictive. And so I'll leave it with that. I'm sure my colleagues could also answer.
Excellent, thank you. So I'm back online. I can now see your questions again, which is very helpful. So a question came in, is there any research into the impact of mental health symptoms and the perception of pain?
Yes. So that is ongoing and a fascinating area. And as I said, we are kind of moving into gaining a better understanding of the emotional, motivational, cognitive aspects of pain. But there has been a lot of research on things like effectiveness of cognitive behavioral therapy for people with chronic pain. Has been shown to be very effective. Combination therapy, exercise, CBT, and that kind of thing has been found to be helpful with patients with chronic pain. And there are also patients who tend to be more susceptible to chronic pain and more resistant to therapies, especially there's something called catastrophizing, which can complicate treatment of these patients quite a bit. So yes, that was the long answer for there is definitely a lot of ongoing active and forward thinking on the impact of mental health on chronic pain and the impact of chronic pain on mental health. Depression, anxiety are comorbidities that are very common.
All right, I'm going to go down. Vivek. Oh, I'm sorry. Thank you. Go ahead, sir.
Hi, this is for Dr. King. First of all, I'm Paul Vinsel. I'm a alumnus of St. Francis College and Unicom. So, very nice. Go Nor'easters. You talked about opioid-induced hyperalgesia, and I'm curious if buprenorphine can also produce opioid-induced hyperalgesia.
Great question. So buprenorphine, it's a polydrug, and so I think basically what it's been shown is that it's less likely to induce the opioid-induced hyperalgesia. Whether it will actively block it or not, I don't remember off the top of my head.
All right, lots of questions are coming in, so thank you. I'm going to go now to the other end to Vivek. Since you were attempting to show a video of cocaine-induced behavior. So if we were to perturb the gene that regulates cocaine response, could this lead to research or avenues for medication-assisted treatments for stimulants like cocaine and nicotine?
Yeah, I mean, that's exactly the idea, like to develop and find novel genes and pathways that can be targeted for therapeutics. In the case of CYFIP2 that I showed you, we have to think real carefully about it because overactivation of this pathway can lead to kind of that neurodevelopmental disorder or seizures. Underactivation or kind of loss of this pathway, at least embryonically, can actually be lethal. Mice that have two mutated copies of this gene or deleted copies will actually die. So it's somewhere in the middle that we have to titrate, for this pathway. And that's kind of fairly common. I mean, as I mentioned, there is no specific gene for cocaine use. So we have to think about, like how these drugs may affect other phenotypes.
Great, thank you. Go ahead.
Yeah, my name is Lynn. How many decades ago did they actually, within the mice and with humans too, did they narrow down a specific gene that's addictive receptive, so why one person is not an addict and another is? Had anybody narrowed down the gene? Because we all know it starts out with genetics.
So there is no the gene. It's it's hundreds of thousands maybe of genes are involved, each with small amounts of changes, and that's why it's a very tough thing to determine.
Yeah, I just want to add to that it's kind of like many roads, one destination, and I recently did a study with like 33 different mutants, so 33 different genes we knocked out, and we had screened them in advance and predicted that some of them would be associated with addiction or compulsion. 17 of them were, and then we looked at the pathways, and none of those 17 pathways overlapped. So that was 17 unique roads to one destination.
So this is another question for the Mousers. Somebody in the audience was curious about the environment in a cage, in a container, and what else you would find in the container in terms of a behavioral assay for mice. Are they alone? Are they with groups? I've heard of enrichment. Can you talk about that a little bit?
They're all of the above. It's really up to us. So we have mice in shoebox cages where we're just using them to breed. There's not a lot of space for them to do enriched behavior. We have mice in 2-foot by 2-foot arenas with mazes and toys where we allow them to hang out with their friends and do all the actual cognitive tasks and things like that, or administer drugs. So really, that's the nice thing about using these this amazing organism is we can customize the environment and the animal to the questions we're asking. Do you want to talk about your Lego? The operant Lego bots you guys built. I think that's a really cool place of.
Oh yeah, so one of this classic in vitro self-administration assay, or mice giving themselves drugs, is in an operant box or a Skinner box where there's two levers. And using the Lego Mindstorm robotics kit, a high school student came into the lab and built out of Legos a Skinner box with two levers that dispenses a food pellet when they press a certain lever, and then you could program the computer so that they have to push the lever 3 times, work harder, or they switch the levers up in the middle. Can they figure out it's the other lever? So we could do all those experiments using Legos, and that was much cheaper than scientific equipment.
So, a couple questions here about psilocybin, and they're distinct, but the one that I want to ask is the following. Is the idea that the brain doesn't really know the difference between when somebody uses opioids versus psilocybin or marijuana accurate? Can the brain distinguish between those 3 very different substances? Whoever wants it.
I'll take a crack. So there are billions of neurons and millions of pathways, and they can really finely distinguish between experiences and learning. So they all have different effects. So I think if you were to take somebody, instead of Coke and Pepsi, do these different drugs and a taste test, they would be able to tell you that they have different experiences. They might not be able to tell you which drug they took. And I will do one last thing. For example, cannabis, 151 different strains. What you get in whatever you're taking or administering depends on what strain and where it's harvested and how it's processed. So even within cannabis, you could have 3 different things of cannabis and have very different responses.
I was just going to add that, like, cannabis has cannabinoids, and they bind to cannabinoid receptors. So nicotine binds to nicotine receptors. So there's this specialization within, and it's not just one receptor. There's a family of these receptors. So those levels can be higher or lower in some cells and not in other cells. So it really is a moving target that we're after, but we're trying to find ways to find it.
All right, we have just time for maybe 1 or 2 questions, depending on how long the answer is. So xylozine's been mentioned a couple times. The question is, where is the research with creating a naloxone-type treatment for xylazine? Is there a projected date for which they hope to have a response treatment available to the public?
I'll just say that prevention, of course, is the best measure right now when we have the test strips for xylazine. And Maine was one of the first states, I believe, to actually push for that. And so they are available. The National Institute of Drug Abuse, which Vivek mentioned, is very interested. So I speak to my program director a lot, and he's like, okay, where's your protocol for your proposal for xylazine? You got to realize that science is kind of glacial and it's moving with regulations. It can take like 18 months to go from an idea to money. So that's kind of where it's at. I have lots of ideas.
Come see him afterwards. Okay, final question, and there are a couple questions here about children. So does age, parentheses, brain development, have any impact on whether or not someone becomes addicted to substances? For example, is an adolescent or young adult more susceptible to SUD?
Yes, I talk about this quite a bit. The same drug in a 10, 12, 13-year-old it will have a very different effect than that drug on a 23, 25, 40-year-old, right? So, I think of it as like a rainstorm when your house is incomplete and it's exposed and it's being constructed. It can do a lot more damage than when the house is fully constructed. So yes, exposure, and when does the brain stop developing? In men, it's around 25, 26 years old. So the drinking age should not be 18, 21. It's 18 in Europe and 21. It should really be 25, 26. I mean, insurance companies figured this out, right? This is why insurance rates drop when you hit 25, because men don't make stupid decisions as much anymore. So yes, the answer is a big yes. I think it's really important that the brain, the developing brain, not be exposed to even things that are quote unquote thought of as non-addictive, like cannabinoids or hallucinogens or things like that, because they will alter circuits and have long-lasting effects.
The questions in science are endless. Thank you so much for your attention. Please come back afterwards and chat some more. Thank you to the panel. So, am I to introduce the next speaker? No. 10-minute break. Is somebody here to share their story through a voice of recovery? Oh, we do. We do. All right. Thank you so much. Brian, the mic is yours. Sorry to almost run over.
It's all right. I wasn't sure either. And all right. First off, I want to thank everybody for coming out, and Gordon Smith and Janet Mills for putting this on. My name is Brian Massey, and I am in recovery, and I'm here to talk about medically assisted treatment, which is what I'm currently doing. And I haven't used since September 13th, 2017. So a little, thank you. Thank you, guys. I have quite the history with recovering and attempting to, and I've been to over 50 rehabs all throughout from California to Florida and tried many different ways. And it took this one time, I finally had enough when it was either I was gonna die or I was gonna get better. That's where I was heading. I've seen a lot of overdoses, and I've lost more friends than anyone in my family combined, everyone combined, really. And I was desperate, and I failed at AA, NA many times, and I didn't feel comfortable talking to people, and I had to do something different. So I found groups over in Augusta about a month after I moved here. I moved from South Florida, and I got on Suboxone, and my goal was at that point to work and save money to go to California to be with my ex-girlfriend, who I used with. We were running mates. And then about a month into it, I realized I didn't want to use. I was going to die. And I can't explain the feeling of every day thinking that you might die, brushing my teeth and thinking this is the last time I could do this. Or when I saw my mom, this might be the last time I see my mom. It's a feeling that I wouldn't want anyone to go through. And one thing I want to talk about is that when I got into recovery, they wanted to do relapse prevention and treat my addiction. But my addiction was my solution to my other mental health issues. And I've been diagnosed with trauma, with borderline personality disorder, to depression, anxiety, all of it, and ADHD. When I was a kid, I was put on Adderall. So really, using heroin was my solution, and I wanted to work on what led me to that. I started using when I was 18, well really 16 with marijuana, but 18 is when I started using painkillers. And it took until I was 26 to realize that I had trauma, that I had depression. I knew there was something wrong, but I didn't know what. And with that, when I got clean, when I stopped using, and I went to college and got my MRC and associate's degree, I learned all about what led me to where I'm at, to where I was. And I want to emphasize that there are so many different ways to recover, and there's not only one way. And when I was in Florida, they treated it as if you don't do AA or NA, you were going to die. And I was going to die continuing to try to do it that way. And I would never, if you're failing in one way, try something else. Because there's a stigma attached to Suboxone or methadone. But I'm sure parents of my friends would rather have them on Suboxone or methadone and be alive. And because, yeah. So really, I don't have much more to say, but I want to be a voice for medically assisted treatment that it doesn't look like somebody just doing it and selling my Suboxone or substituting one addiction for another. I haven't just been on Suboxone. I did a lot of therapy. I saw 2 therapists at one point, and when I got married, my wedding day, I had a therapy that I had a group, and I went to that group in the morning when I was in Vegas, Las Vegas, And I wanted that. It was important to me because my recovery made that possible. I never thought I'd be planning to have children or even have a house that we own. And I'm a landlord too, which is pretty cool. So, I just wish and hope that anyone that's struggling, or if you know anyone, that there's a reason for everything. There's a reason they're using. They're not just doing it because they want to. Some people may be, but there's a reason. And there's so much stigma attached to it, but they're a person. Like, they were once a child too. Like, and nobody would treat a child like an addict, or like their life is worth less than other people. I just hope one person, even if they're struggling or feeling conflicted for being on Suboxone, and like I did, I felt ashamed and conflicted, like it was just, and I was afraid to talk about it because I know the stigma, even in the recovery community, that comes along with it. So I hope somebody can learn or take something away from what I'm saying, and even if I help one person, that's why I'm doing what I'm doing. This is the first time I've spoken in front of this many people. Yeah. And I'm really grateful for this opportunity, and that my wife is here to just be here and support me, and that I have a wife that's a wife. Like, I'm happy every single day, even if when I struggle, even when I'm not having a good day, like, I come home to my wife, my dog, and my 4 cats. And really, that's all I ever wanted. I just wanted to be and feel normal. And I know there's not a normal, but my idea of what a normal life looked like. And that's what I'm living today, and anyone can do it. Like, don't give up. And thank you for letting me share and being here.
Thank you so much, Brian. I have a wife too, and I'm happy every day, and it's been 45 years, and she's so tolerant. And so I hope all of you have important relationships and partners. It's so important. We're not really going to take a break here. The governor's here. Hannah Pingree, my boss, is going to introduce the governor, but I'm going to have to I'm looking for Danielle Farino. Where is Danielle? Come over. I should have recognized you when I was over there, Danielle. I'm sorry. So as people wander in, we'll give Danielle a couple minutes to get her thoughts together. But Danielle is the founder of the First Mile Active Recovery Center in Fort Kent, and which is our 21st Recovery Community Center, but this is unique because she did all this without any support from the state. She hadn't had a dime of state money. Now, we hope we'll get her into the loop, so she will someday, but I'm so impressed at what she has accomplished in Fort Kent and why, and she's going to tell you her story. She's really not done this in large groups before, probably, but she's our voice of recovery before the governor, and the governor's going to note some of Danielle's work, too, during her speech. So it'll be Danielle, and I know you'll all be moved by her story, and then I'll introduce Hannah Pingree, who will introduce Governor Mills. So Danielle, thanks so much for making the trip down from Fort Kent.
He looked right at me and smiled, but he didn't know it was me. I've only met Gordon a few times before, but he's a great guy. And I want to thank everyone for listening to me over the next few minutes, and thank Gordon for inviting me here to share a bit of my story, because I can't fit the last 6 or 7 years into the next 5 minutes. I would be lying if I said that it was my pleasure to be here. One, I'm super nervous, and two, I'm standing here. The only reason I'm quite sure, the reason I'm standing here is because less than 12 months ago, I lost my son to an accidental fentanyl overdose. My son, Michael Anthony Robertson, 22 years young, was found dead in his car almost 1,000 miles away, working on his recovery in Richmond, Virginia, because we didn't have an option in Maine that didn't include a 3-week wait. Michael did not want to die, and I know this because he said those exact words to me just 3 months prior. Our last phone call, he said, "I'll talk to you tomorrow. I love you, good night." He had plans for the future. Michael's death was just one of the 107,543 reported overdose deaths in 2023. Ironically, the first of the last 5 years or more to report a decline. I don't think there's any appropriate words to say to describe how hard it is to hear or see anyone celebrating that number. Like there weren't over 107,000 lives lost, families turned upside down, mothers crying themselves to sleep every night, or new people finding themselves slipping into the grips of addiction. Because not only do we have a shortage of help for people with substance use disorder, we lack support and resources for people with mental health disorders, and every single death has a ripple effect. I could go on for a while about the barriers and struggles, lack of support, empathy, respect that I faced trying to get him help. However, I have 5 to 7 minutes, according to Gordon, and I want to instead tell you about this beautiful human that existed before the drugs took over. The one that came back to me for a couple of months here and there when he would work on his recovery. Because although the world may see him as just another addict that chose to get high, he deserves to be remembered for who he truly was. The person that those who loved him most knew. Michael was born a beautiful, seemingly healthy baby boy, and his big brown eyes showed curiosity from the moment he came into this world. I remember clearly the slow blinks and imagined him thinking, what is this new place? He certainly was taking it all in, and to me he was perfect. And at 16 years old, I never knew that I could love a human so much until that moment. He was smart, hitting all the milestones early, which reinforced the thought that he was perfectly healthy. Walking at 10 months, running shortly after. He loved the outdoors. You could always find him playing outside in the dirt or the snow with his dog, his siblings, or his friends, riding anything with a motor, taking jumps, racing around right from the toddler years, which sometimes ended us up in the ER, but never broke a bone. He loved swimming and skiing, which came effortlessly, and also had to involve dangerous stunts, like backflips. If there was a level of danger to it, it's as though he had a magnet that was attracting him to it. He had a big personality, loved to listen to tell stories, loved to listen to and tell stories, especially ones that would make you laugh. He was charming and caring, always standing up for his family and friends and the kids that got bullied in school. His heart was inherently good. Just as most individuals I meet that struggle with addiction, I would say his heart was better than mine. He cared deeper, was more accepting, less judgmental, and a much better storyteller. However, the world we live in is not as kind, and when life shows us over and over again how ugly it can be, we naturally look for an escape. Michael found his escape for the pain and anxiety through marijuana and opioids as a teenager. It wasn't until he was 19 years old he would tell me about how incredible the feeling was when he'd take his first oxy years earlier. The boy that once swore he would never do drugs, swore that the pills would never turn to heroin, laid on the couch in early stages of his opioid withdrawal and told me his secret. So there you have it. Your son's a junkie, a loser, heroin addict, and if you want to disown me, I don't blame you. He continued with, I am sorry, I'm such a disappointment. Those were really hard things to hear as his mom, and I don't recall my exact response, but I do remember finally feeling a sense of relief. He finally let me in and trusted me enough to give me a chance to help him. And the crazy thing is, I think we both had this idea that I could fix it for him. I knew for years that something was going on with Mike, often accusing, arguing, threatening, which never proved beneficial for either of us. And I do want to give credit to my changes, actually, to a book called Beyond Addiction, which talks about craft. And I truly believe that the changes that I learned and made were through reading that book twice, gave me the ability to give my son a safe space to open up to. There were no support groups. Again, I'm in northern Maine, so there's not a whole lot up there. But even if there was, I probably would have been too embarrassed to attend. After all, as bad parents, right, that have kids on drugs. It took me a little time, but I learned that that statement is a lie. My mother would say to me, parenting didn't come with a handbook. I did the best I could with what I had and what I knew. And people in the recovery world added, and when we know better, we do better. So that's why we're all here, right? We want to do better. When Gordon asked me to talk, I wondered if he realized that he picked a poster child for an affected other. I lost a cousin, an aunt, and my father to their opioid addiction. My mother and her father identify as alcoholics. I have a sibling and many friends and a best friend still struggling with their substance use. So how do we do better so that we stop losing these beautiful souls? How about we educate younger, not wait until youth are already using drugs and alcohol to cope? How about we talk to the people doing well in their recovery and trust them instead of professionals that think everything is fixable with a new prescription? How about we have 90-day treatment instead of a 28-day reset that sends people right back into the same environment that they became sick in? How about if detox is supposed to be 7 to 10 days, we accept them on day 3 and not tell them, I'm sorry, you're not sick enough to come. Those are things that I dealt with trying to help my son. Additionally, how about we not have a 3-week wait list and treat people with care and respect when they reach out for help? How about we stop thinking about the only people that want help are the ones asking for it, because we know that there's also a huge stigma around simply asking for help, especially if you are a male. My son wanted to go to treatment in Maine, and he didn't want to go so far from his family. The first time he asked for help, we were offered an appointment 3 weeks out over 50 miles away. The first year and a half, he went through 7 different doctors, one of which wrote him a Suboxone script for a month after he showed up to his appointment completely inebriated. I never forced my son to treatment, but I pushed hard for him to take that step, and I worked hard to stick to my boundaries because trying to save him, I was killing myself. The first time and every time after he wanted to go to detox, he was told to call back tomorrow, we have no beds, or we're not doing intakes anymore, or you're not sick enough. The first time that he asked, I didn't want to miss a chance to get my son back, and I didn't want him to think that there was no help. So we kept calling until I found a place that said we have a bed. Of course, there was a catch, $7,000. So of course, I took out the credit card, and then I drove him 6 hours to his first medical detox. The facility was great. It appeared clean. The staff were professional, kind, respectful. I trusted them to guide us to the best option for inpatient, which they connected us with a well-known place out of state that cost over 3 times what the detox stay was. 3 times. People don't just sit on this kind of money waiting for a health emergency to come up. These are people's retirements, home equities, credit cards, money for their basic family needs. And these treatment centers are not a guarantee. Most of the time, individuals are going over 4 times. It didn't take me long to come to the realization that all the money in the world wasn't going to fix this problem. We need people that genuinely care, people with lived experience, people that hold themselves and those around them accountable, people that know the importance of putting their own oxygen on first. And you give these people some capital to help grow resources. I cannot bring my son back, and he doesn't get a great recovery story, but I do know that he wanted to help others. So through my pain and suffering, I did create a nonprofit in his memory and a recovery center with some friends, old friends, new friends. We are a community of recovery allies. We are affected others. We are people in recovery. And we are determined to make resources more available, to advocate for rights and acceptance of people struggling with addiction. And we refuse to stop fighting for those we love and those we lost. I should not have had to send my son to rehab almost 1,000 miles away for him to die alone in his car across the street from his recovery residence only 3 months later, and no other parent should have to either. Thank you.
Thank you, Danielle. I said we'd laugh together, we'd cry together. That's a really hard story to hear. I'm now going to introduce my boss, who will introduce her boss. All our bosses, I guess, boss of all of us. But Hannah Pingree is a former Speaker of the Maine House. She is a native Mainer, grew up on North Haven, went to Brown University, was Speaker of the House when she was like 30 years old. She is, the governor appointed her to be the director of the governor's office of policy, innovation, and the future. And that's the office that I am in. I like to say, and Hannah likes to say too, that we just have the easy stuff. Opioids, climate change, the energy office, housing, hunger, the children's cabinet, the seniors cabinet that they're recruiting me for. It's an amazing group of people, and she is an amazing leader. So I was really pleased when she agreed to introduce the governor so that I could introduce her, the best boss anyone could ever have, Hannah Pingree.
Well, thank you, Gordon. And before I introduce the governor, a leader I have been lucky enough to call my boss for the last 6 years, I want to take a moment to recognize Director Gordon Smith. Gordon and I were the first two staff in the Governor's Office of Policy, Innovation, and the Future, an office the Governor Mills created when she took office in 2019. Gordon and I have been so lucky to work for a visionary governor who believed that difficult and important issues required big solutions that went beyond normal state processes. The governor created our office to break down silos, to bring people together, to seek innovative solutions, and to bring long-term focus and commitment to our state's most important challenges. Gordon was just the right person when this complex challenge of the opioid crisis was on the governor's radar. Gordon has been the force behind this incredible summit every year. And so many of you know that he's been tireless in his work to bring together communities and state bureaucracies, to engage directly with people across our state, to move the needle on this issue. Whether you are in recovery, a family member seeking advice, or the CEO of a large healthcare system, Gordon takes time to talk directly and to solve problems. He has used every relationship and tool at his disposal to make an impact. I know many of you are here today because you cannot say no to Gordon Smith. So I want to thank Gordon for his incredible leadership, and I want to congratulate him again on a successful event. Governor Mills may need little introduction to you all. She's been a passionate believer in saving lives and ensuring that Maine people have the best chance at recovery since her time as Maine Attorney General. You've all heard the stories about her willingness to stand up and to fight when necessary to save lives. As governor, the story of her approach is the same. I live on one of Maine's offshore islands where this crisis has hit our communities, especially our fishing communities, very hard. This morning, I rode the ferry to the mainland with a friend who works as a Mid-Coast EMT, who unprompted told me about the work that he is doing to educate other EMTs in recovery and the options program. He recounted what you all know, that our approach, our diligence, our continued efforts are making a difference. He specifically told me to say thank you to Governor Mills. On the ground, in real-life situations, your leadership is felt. I am proud on this issue and so many others to work for a governor who made commitments when she took office that she has not forgotten. Other political leaders often say things on the campaign trail or in speeches, but after time passes, hard issues start to get fewer mentions. But that is not the case with this governor. Her passion, her commitment drives her each and every day. She's matched her commitments with diligence, with funding, a continued focus on problem solving every year for the last 6 years. Gordon and I can both assure you, she diligently pushes us and many across her administration to do more, to do better. She takes service seriously. She does not take no for an answer. And that is what real leadership that makes a difference, is all about. I am so lucky to have the honor to work for Governor Mills, and it is my great honor to introduce the governor of the great state of Maine, Governor Janet T. Mills.
Thank you. Thank you. Thank you so much. Thank you all for being here. Familiar faces, new faces. Thank you, Gordon. Thank you, Hannah. Thank you all for wanting to be here to keep talking about this vital subject. We're trying to get our hands around it. Hasn't been easy. We've been talking about this for years now. Things are turning. Things are turning. I want to thank our hosts, too, Central Maine Community College and President Libby, as well as President of Community College System, Dave Dagler, who is here somewhere. There he is, right there. And Auburn's Mayor Jeff Harmon. Thank you for being here as well, hosting us. We're also privileged to have Dr. Miriam Delphin-Rittman as our keynote speaker of SAMHSA. I also want to thank the many members of my staff, other members of my staff, including Sarah Squirrel, for convening this summit. The opioid epidemic is still reaching into every corner of our state, but something important has changed these past 6 years. To some extent, the shame and stigma that too often leave people alone and isolated to agonize about how to help their loved ones, that's gotten smaller each time we have come together to talk honestly about addiction and its aftermath. 5.5 years ago, I set 4 clear goals for our response to the opioid epidemic. At the time, I designated Gordon Smith as the Director of Opioid Response, or DOOR, as it were. I issued an executive order that laid out these responses: purchasing and distributing more naloxone, increasing access to Suboxone in hospital emergency departments, recruiting and training recovery coaches, and fourthly, making medication for substance use disorder accessible universally, especially in Maine's prisons and jails. Our partnerships between state and local government, nonprofit organizations, healthcare providers, individuals with substance use disorder, and their family members, and many other people who are participating in this summit today. Our partnerships are achieving real progress on those goals and others. Don't give up. Last year, drug overdose deaths declined by 16% in Maine. The first time in 5 years that we've recorded an annual decrease. In fact, we were just one of just 4 states, along with Nebraska, Kansas, and Indiana, to experience a decline of more than 15%, while other states like Alaska, Washington, and Oregon had increases of overdose deaths of nearly 30%. This year, we're continuing to make progress. From January to June, fatal overdoses have decreased by nearly 12% so far. When you consider the preliminary numbers from July so far, we're on track to record a nearly 15% decrease for the first 7 months of 2024 over the first 7 months of last year. It's possible that the decline in opioid prescriptions is contributing to the decline in overdose deaths. I think there's a connection. In the past 5.5 years, we've enhanced the prescription monitoring program to prevent overprescribing and diversion of prescribed opioids. We've required all Maine providers who are actively prescribing controlled substances to be reviewed every 6 months. We've deployed a clear process for reporting prescribers who are overprescribing to their medical boards. We've created additional training for prescribers whose practices may put patients at higher risk. The number of Maine patients receiving high-dose opioid prescriptions has gone from nearly 4,000 in 2018 to 1,869 in 2023, so more than half. Fewer people are taking prescribed opioids, and that fact alone may be contributing to the decline in fatal overdoses. Fewer people getting addicted in the first place. We all know about that continuum. So that's welcome news. Well, we're not complacent. Traffickers are adapting every day to avoid efforts by law enforcement to stem the tide of drugs into Maine. People seeking a cure for pain, an anesthetic for experiences that are just too heavy to carry. They're finding even more potent and deadly substances, things that can worsen existing mental health challenges or set off new mental health disorders. One recovery coach named Jillian likened her own recovery from substance use disorder to walking in a field of tall grass. Walk through it enough, you've made a path, and it's easy to keep walking down that path instead of finding a new direction. For decades, states across the country, including Maine, walked down the same well-trodden but failed path. Overwhelmed by a flood of legal and illegal drugs that change a person's very brain chemistry, too many policy leaders, nevertheless, blamed those same people for making bad choices. We recognize that while accountability is important, addiction is a disease of the brain, not simply a choice. We're going in a new direction, step by step. My administration is doing all we can in a responsible and reasonable manner to stop drugs from reaching Maine, to prevent substance use disorder at an early age, to treat it when we can't prevent it, and to set people on a lifelong path to recovery, above all else, to save lives. As a grandmother to 5 youngsters here in Maine, I personally want to do everything I can to keep them and other youngsters from starting down what can be at times an all too easy path of addiction. That's why a partnership between CDC and Maine CDC and public health organizations called the Maine Prevention Network puts substance use prevention programs in 78 middle schools last year. Let's make sure we get into every school now with serious and effective prevention programs. One of those schools was Skowhegan Area Middle School. There's somebody from Skowhegan. Somerset Public Health taught 400 Skowhegan area middle school students their risk module to help them identify different types of risks in different situations and discuss with their peers why certain risks feel healthy or unhealthy. And the Children's Behavioral Health Services at the Maine Department of Health and Human Services is working with Healthy Acadia to launch a youth recovery coaching pilot program. That pilot program in Washington and Hancock counties will train one youth peer recovery coach coordinator, 2 full-time youth peer recovery coaches, and 2 youth peer recovery coach interns to sound the alarm on the danger of drugs. This has got to be an effort of young people talking with young people, peer to peer, to be effective. As Kylie, a 14-year-old who helped organize a recovery event in Augusta this past April, as she said, quote, "I feel like more people need to know about it and know how to help," end quote. 14 years old. It's sad that someone as young as Kylie has to think about substance use disorder. But the reality is, this epidemic has touched way too many lives. According to the National Survey on Drug Use and Health, an estimated 1 in 10 Maine people aged 12 and older struggled with substance use disorder in the past year. 1 in 10. Some of those people may experience an overdose. And to save their lives, we worked hard to get lethal drugs off our streets, to identify new drugs in the communities that are also lethal, and to distribute overdose reversal medication as widely as possible. In the first 6 months of this year, MDEA agents have seized more than 19 pounds of suspected fentanyl. 19 pounds. It's probably enough to kill the whole state. In addition to methamphetamine, cocaine, and imitation prescription pills. Last fall, President Biden and Chinese President Xi Jinping took steps to limit the trafficking of fentanyl into the United States. They agreed that China will tell its companies to curtail shipments to Latin America of those precursor chemicals that are used to make fentanyl. Hopefully, eventually, we'll prevent these labs from completing the manufacturing process and sending fentanyl into the United States. Alarmingly, so far this year, 17% of fentanyl overdose deaths in Maine have also included xylazine, a veterinary tranquilizer that can cause painful open wounds, ulcers, abscesses on the skin. Quite an increase from last year. And there are no known reversal medications for xylazine. Maine's not alone in dealing with this problem. In 2022, across the country, there was an almost 300% increase in xylazine found in fentanyl-related overdose deaths. 300%. Over the past year, my administration has used about $1 million in federal funds just to educate people on the dangers of xylazine and purchase and distribute nearly 83,000 xylazine test strips. If you're going to use these dangerous things, at least try to find out if xylazine is in them. There may be no known reversal medication for xylazine, but there is one for fentanyl, which we all know is naloxone. So far this year, we've used $1.25 million in federal funds to boost our distribution of naloxone, reversing more than 10,200 potentially fatal overdoses since I've taken office. Sometimes I think about my predecessor who once said, naloxone merely extends lives, it doesn't prevent death. Then I think about people like a man named John, who's in recovery now because naloxone saved his life. John said, quote, I now have an 8-month-old son, a wonderful fiancé. I have a wonderful life today, and I want other people to be able to experience that, end quote. Recovery is possible. New life is possible. And to give more people in Maine a chance at that wonderful life, we're making naloxone as widely available as possible. And most recently, the legislature and I have enacted laws to make it available over the counter and online, and to require law enforcement officers to carry naloxone. To help further prevent fatal overdoses, we've also worked with municipal governments to expand emergency housing to keep people from sleeping on the streets, especially during cold winter months. The city of Portland has said the opening of one of those shelters has played a huge role in, quote unquote, in a decline in fatal overdoses. Imagine that. Housing is a benefit. Given that shelter staff are able to identify somebody who's overdosing and administer Narcan to save their lives when they're in a shelter. In fact, January marked the first month in 2.5 years without a fatal overdose in Portland after opening a shelter. Emergency housing is one thing, but how someone's supposed to focus on recovery if they don't know where they're going to sleep tomorrow or the next night? So, we're also focusing on creating more permanent housing, especially for people with chronic substance use disorder. We're leading an unprecedented expansion of Housing First, a program that is proven and cost-effective to providing permanent housing and wraparound services to set more people on a path to lifelong recovery. Amanda Olson, former executive director of the Augusta Housing Authority, says that the Housing First program is the obvious solution in the face of Augusta's housing shortage, its lack of recovery services, and exploding rents. She said the Housing First program has renewed a spirit of hope and optimism in our housing community. I'm so glad to hear that. But Amanda made a good point about the lack of local recovery services, too. And in addition to housing, my administration's focused on expanding treatment and recovery services statewide. So earlier this year, I signed a bill to encourage Superior and District Courts to ensure that adult treatment and recovery courts are available everywhere in Maine, especially in rural areas. Androscoggin County has one, but many other counties do not. And I know it's hard work. It's intensive work on the part of judges and staff, probation officers, etc. And it's hard work on the person in recovery, but it's got to be done. And it is proven successful. Since 2019, we've also expanded access to Suboxone in 28 of 33 hospital emergency departments. And we're working now to expand access to the last 5. This year, I included $4 million in our supplemental budget passed by the legislature to expand medication in the county jails. This all builds on the important work being done by the Maine Department of Corrections to provide universal access to treatment, including medication for substance use disorder, peer recovery coaching, and mental health treatment services across its system. Now, I don't believe, as many people did in the past, that we can simply arrest our way out of this epidemic. Diversion from the justice system is an important tool, but we should recognize, too, that for some people, the experience with the criminal justice system has turned their lives around. One man named Brock credited his incarceration at Somerset County Jail as the beginning of his recovery from an opioid addiction. Brock now advocates for the expansion of that diversion program at other jails. Brock said, quote, "When you see somebody get clean, you really see the life come back into their soul. Everyone is worth saving, everyone. That's the biggest takeaway," he said. I agree. In addition to expanding treatment in county jails and state facilities, we've also increased the total number of treatment beds statewide by about 50%. In the last year, we've opened nearly 70 new beds in both rural and urban communities. That includes 10 beds in Bangor, 12 beds in Auburn, 6 beds in Windham, 4 beds in Presque Isle, and 34 beds in Portland. And I just heard Danielle talk about the terrible experiences of her son and her efforts to get him into treatment and detox. And we're addressing that. We cut the ribbon on 14 new beds at Milestone Recovery recently. And the center's director, Tom Doherty, said, quote, "Every day, our nurses and our counselors have to turn away about 70% of the people seeking detox services." That's Danielle's experience. This project now is going to allow us to say yes to a lot more people. I know there's a perception, reinforced over the past few decades, an accurate one, that there are only a few beds available in Maine for treatment. That has been the case in the past, but things are changing. New treatment beds are coming online every day, and I want to make sure anybody who needs help should ask for it and should get it. Here in Maine. As our keynote said earlier, Delphin Rittman, quote, "We know recovery is real and it's possible. We know people are able to recover. People do recover. They are living full, happy, healthy, productive lives. It's important for people to have hope and to reach out to get support and assistance if they're struggling, because they're not alone. There is a vibrant recovery community to embrace them and work with them." In the supplemental budget, and I see many legislators here, and thank you for your support for all of these measures, but particularly for the $5 million in the budget to launch crisis receiving centers, including one right here in Androscoggin County, as well as Kennebec, Aroostook, and Penobscot counties. These centers serve as anchors in communities for substance use disorder and mental health services. They are in addition to the 21 other recovery community centers across the state. I see the volunteers are here. With more than 800 paid and volunteer staff who served more than 14,000 people last year alone, these are the doorways to help, the doorways to recovery, the doorways to communication and community. And to support these recovery community centers, we're adding nine new recovery coaches to our options team. And we've added 3 recovery coaches and a coordinator to serve family recovery court participants in Lewiston, Augusta, and Bangor. And we've implemented recovery-friendly workplaces. What's better than a good job? Housing and a job. Certifying, those certifications of a recovery-friendly workplace, that's being used by nearly 40 businesses who employ nearly 3,000 people. There's work out there. And another 16 businesses have applied for that certification to hire 6,300 people. We know that getting and keeping a job while in recovery isn't always easy, but we're rewarding businesses that understand the unique experiences and skills of people in recovery, and that's important. In the past 2 biennial budgets, we've invested nearly $500 million in funding, federal and state, for mental health and substance use disorder services, in addition to the $30 million in this year's supplemental budget. The measures I've mentioned today are just some of the ways we're using that funding to address the opioid epidemic, according to our strategic action plan. Each of those strategies is a step on the path to a new future that we're forging together. A future where we balance accountability with a better understanding of addiction. A future with strong communities that help people, every individual, especially young people, help them cope with life's challenges without resorting to drugs or alcohol. A future with a thriving economy and endless opportunities, a healthy population and a healthy state with no demand, no need for these deadly substances in this state. That's the dream we share, and it's the direction we're headed in together. The recent decline in overdose deaths in Maine is reason to hope, but not to rest. Everyone in this room has played a crucial role in the progress we've made and in the progress that's yet to come. Today, may we all redouble our efforts to save every life, to lend our strength to people as they start, stumble, or resume their recovery, and to bring communities across Maine together to build a brighter future for us all. There are tragedies every day. There is sadness in this room and elsewhere, but there is hope. And I'm never giving up on every person who needs help to make sure we provide that help, on every child who needs mentoring and help to find direction in their lives, to find a way to say no, to find a way to make choices that are healthy and informative. I'm never giving up. Don't you give up either. Don't give up. We're making progress, and we're going to make more progress in the years to come. Thank you all so very much. Thank you. Thank you. Oh, yeah. Okay. Thank you. Thank you very much for all you do every day. Now, I want to present a couple of awards, the Governor's Awards, to two individuals who are dedicated to saving lives. I'd like to ask Dr. Marcella Sorg and Danielle Farino to join me at the podium. Marcy. Marcella Sorg. Let me introduce, if you don't know her, Marcella Sorg, Marcy Sorg. In addition to her current job as a research professor for the University of Maine, Dr. Marcella Sorg has served as a consulting forensic anthropologist to the Office of Chief Medical Examiner in Maine for 45 years. Our paths have crossed for decades, and I remember working with her on so many cases when I was in the AG's office and working with Henry Ryan and other medical examiners to solve cases. And now she also consults with the New Hampshire, Vermont, and Rhode Island Chief Medical Examiners, and is an associate member of the Maine State Evidence Response Team of the Maine State Police, and a member of the Maine Overdose Review Panel, and a guest member of the Maine State Opioid Clinical Advisory Committee and Maine State Opioid Coordinating Committee. Look, her resume is 45 pages long. Not going to recite it, but we rely on her all the time for her deep expertise to understand the trends in opioid overdose deaths. She's also a tireless advocate for the people behind those statistics, each of whom has their own story and their own struggle with substance use disorder. So thank you, Dr. Sorg, for your long-term commitment on behalf of the state of Maine and on behalf of the nearly 1.4 million people of the state of Maine. I thank you. And I have an award. Where is it? There. Oh, there we go. It reads, in grateful appreciation for over 45 years of serving Maine as a public health and public safety researcher and advocate. This day, July 25th, 2024. Ms. Boss. Thank you. It's also my privilege to present the Governor's Award to Danielle Farino of Fort Kent, whom you heard from earlier. You've heard her story, but it bears repeating. After losing her own son, Michael, in 2022 to substance use disorder, Danielle has turned her grief into action, founding the First Mile Active Recovery Center this past May. On top of running her own real estate business, Danielle has ensured that more than 120 people have received recovery services at First Mile Active Recovery so far. People who knew him described her son, Michael, as having the biggest heart and living to make others laugh, with a smile that lit up his face and a heart of gold and a willingness to help others. I kind of know where he got that from now. Thank you, Danielle, for carrying on your son's memory and for your commitment to the people of Maine. Danielle, it's a pleasure to present you with this award, which reads as follows. In grateful appreciation for her leadership in establishing the First Mile Active Recovery Center, Fort Kent, Maine, presented this day, July 25th, 2024. She epitomizes the phrase, never give up, never give up. So I'll turn things back over to our Director of Opioid Response, Gordon Smith, and thank you again for attending and taking part in this important conference.
My able assistant Cheryl insisted that I be sure to give the boxes to Dr. Sorg and to Danielle. So you can take that over to Danielle. Apparently last year this did not happen. So stay right still. Thank you so much for, hearing the governor's message, for being with us this morning. I know it's warm in here. We have a little video that's our 6th or 7th Recovery in Maine series, and this features some of our LBG TQ population and the intersection with substance use disorder. The film's only about 9 minutes. It's going to be introduced to us by our friend Sarah Irwin from Point North Institute, which we contract for. Sarah prayed right down here, and I know you're going to introduce the film. And then I remind you at 1:30, when the breakout sessions start after lunch, that the people in the film, and these are not actors, these are real people, many of them in this room, and they're going to do their own breakout session and talk about the film. So I encourage you to take an active look at that breakout session. But Sarah, thanks for all the work the Points North Institute does. I know that Rick Rector is here too, and the work all year that we do these community events, we do these films, and it's a wonderful partnership. So thank you. I put you in the capable hands of Sarah Irwin.
Hi, everybody. My name is Sarah Irwin. I'm here from Points North Institute, which is the home of the Camden International Film Festival. And for the last several years, I've had the immense privilege of overseeing our Recovery in Maine series, which has brought documentary film screenings and community discussions about the opioid crisis to nearly every corner of the state. Something I hear over and over again while speaking with community partners or the very brave people who agree to be featured in our films is that there are as many different paths to recovery as there are people. But there is one constant to all of these journeys, which is the need for community and connection. And at Points North, we believe one of the building blocks of the connections we make are stories. At all of our screening events, we've witnessed the power of sharing stories on screen, on panels, and from the audience, which can break down isolation and stigma, connect people with resources, and build a dialogue that is centered on the experiences, perspectives, and leadership of people in recovery. We're honored to partner with Gordon Smith and the Governor's Office in this work, which now includes the creation of original short films profiling Mainers in recovery. And today, We are thrilled to present the newest installment in the Recovery in Maine series, Recovery in Maine, Queer Voices. We hope this film inspires much-needed conversations around the intersection of marginalized identities and recovery. And I want to thank all the incredible film participants, James, Val, Tess, and Cole, for their courage to share their stories and speak their truth. Also, special thanks to filmmakers Rhys Bickford and Alexandra Morrow for your dedication to telling these stories with such integrity and care. And for all of you, if you're ever interested in partnering with us to bring an event like this to your community, please come find me today. Or you can visit recoveryinmaine.org, and we'd love to come and share any number of our films with you and your community. Thank you so much for having us, and we hope you enjoy the film.
This next entertainer I'm very excited for.
When I took away the drugs and the alcohol, that's when I got sober. But I didn't shift from that place of being in sobriety to being in recovery until I started to do the things that I wanted to be doing.
For my friend, the one and the only Luz!
Queer people are brought up and are bombarded with these messages that things aren't for them. The world is not built for them. We haven't designed our society to include them. When I first entered my own recovery journey, I realized very quickly that I was muting my queerness in such a way when I was accessing these recovery spaces that it became a barrier for me to truly heal. And I realized, if I am feeling this way, what are my other queer and trans siblings going through?
When I first came into recovery, I heard the word authenticity a lot. And what I thought that meant was just like, you are who you say you are. And for me, I wasn't me when I still had a female chest. And I wasn't me when I didn't have little chin scrubbles and like a deeper voice. Like, I didn't feel like that matched up with who I was on the inside.
You know, like when that sober house owner asked me if I would be attracted to the women in his house, it made me feel like he was only seeing one dimension of who I am. I mean, personally, I think me being gay is the least interesting thing about me.
In recovery, if you can't tell your story, you know, if you can't get it out, if people can't relate to you, then you just feel alone. It's hard for people to understand the reasons why we started using drugs and alcohol and how drugs and alcohol became part of our survival.
And/or support the recovery lifestyle. An all-recovery meeting is non-denominational, meaning all pathways of recovery are embraced here. Today, I will choose a universal recovery topic, and then we will discuss.
Idea starts with a couple people getting together and just making it happen.
Up to you again. My name is Josh, and I'm an addict and alcoholic. My pronouns are he, him. Hey, Josh.
Hey, Josh.
And it just continues to keep growing and growing, but you have to start it first.
The Equality Community Center in Portland, Maine has done a phenomenal job of creating a place for the intersection of recovery and LGBTQ issues.
Queer Recovery is a group for queer folks who are struggling with addiction, living with addiction, or affected by addiction. And we're committed to creating peer-led spaces where people can access resources, find support, and build community.
At the root of most addiction is pain and trauma. and people in the LGBTQ community have maybe experienced more pain as a result of stigma, discrimination, lack of opportunities. Being in that kind of space, I can just be me. I don't have to worry, are you gonna accept me? Are you gonna reject me? Are you gonna view me differently?
I think when we're talking about substance use treatment, mental health care, queer community, it's so important, even necessary, to have someone who has navigated that experience themselves, who has that lived experience, be the ones who are providing the support and leading the charge.
Wherever they want to see themselves, I help them take those baby steps.
Here at the barn, we started off with a simple, on a Saturdays, we want to have a meeting for LGBTQIA plus people, allies, and all pathways of recovery. We offer harm reduction trainings here so that people have that option. And that's what recovery is all about, just finding what works for the person and really letting them lead their life because it's their journey.
A few years ago when I realized that I needed more help than just my own triumphant willpower to enter recovery, to stop doing drugs, to stop drinking, I smuggled my queer ass into an all-men sober house. Picture this now. Okay, so flannel went on, earrings came out, backwards hat went on, and voice went a few octaves lower as I was interviewing to go into the sober house. And I knew they weren't going to think I was straight, but I was afraid to be me. Afraid to even try to be me.
I think there's a real difference between being invited to something and feeling included in something.
We have a real problem in society where we tell people if you don't fit in this box, you can't be here. And then we wonder why we have higher than ever rates of substance use. What would our world look like if you could just come as you are?
We need fewer chairs now.
But I would love to talk about the role of leadership and the impact that has on your life, positive, negative, neutral. The floor is yours.
I feel like that heaviness of there's something more that we have to do. How many kids are going to die of suicide or drug overdose or whatever the case may be because they don't feel accepted, and it's, I don't want more kids to be numbers because that's a fucking scary place to be,
We also need to set the tone for what we think is acceptable for other adults that include allies and having them step up to the plate. Like when you think of any social movement that has actually made a difference, it wasn't just the marginalized group. It was at least 51% of society saying we've had enough. So I think there needs to be some call to action of you tolerating me. That's not enough.
Tolerance is just so 90s. Don't tolerate me. Love me for, who I am.
People who use drugs are often criminalized by our society. They are stigmatized. They are othered, where we end up in a world of others instead of a world of us and we. And I think when we break down stigma, when you see me as Tess rather than as a former substance user or a lesbian, things change.
I deserve recovery just as much as anybody else does, and so we have to make it available to everybody. There's queer people everywhere, but there's not queer spaces everywhere.
For right now, if we were to open up something to help queer people in recovery, that would be looking like having safe places for them to lay their heads at night. All-inclusive, all-supportive places for recovery residency. Our primary focus is to feel seen, to feel loved, to live in recovery, and to know that we matter.
When we see each other living and covering out loud, if you will, just being who we are in the open. It's just a way to recognize that we're not alone. We've never been alone, and we're never going to be alone. This is for us. We belong here.
All right, we are going to get started for the breakout at 1:30 for the options, community partnerships, and action. Before the panel comes up and joins us, I just want to welcome our voice of recovery, Rob Porter. Thank you all.
Good afternoon. My name is Rob Porter. I'd like to tell you about a guy named Panda. I met Panda 23 years ago, and during one of our many conversations, he told me a story of how he ended up in prison once again. Panda could not understand what his problem was. He believed he was a good person and had a good heart, yet without fail, he would make a bad choice or a series of bad choices, self-destruct, and cause everyone around him harm. Panda was a good man who behaved badly. Over the years, he started to use drugs more and more to ease the ever-increasing pain he was causing himself by harming others. Panda was a thief who loved cocaine and other drugs. Panda stole money from his parents, his grandmother, the little old lady down the street. Friend, foe, or regular citizen, it did not matter. There was no discrimination. All were a target. Panda was not a good thief. He kept getting caught. In and out, in and out. The rinse and repeat cycle went on for 20 or so years. During our conversations, Panda admitted that he was tired of starting over only to end up back behind bars. He also admitted that he had never really accepted responsibility for his own actions. Panda decided this needed to change. Panda's process of change was not easy. There were many inner conflicts that he needed to work out and some beliefs that he needed to reason out. Panda was able to enroll in some college classes thanks to a lovely lady by the name of Doris Buffett. May she rest in peace, the sister of Warren Buffett, through a program called the Sunshine Lady Foundation. He completed some philosophy classes and some ethics classes and was astonished at the fact that people in society actually viewed the world differently than he did, and more than likely his perspective of how to be in the world was one that was quite deviant. For one, in his worldview, he was not accountable for his own actions. Someone else was always to blame for his behaviors and the consequences of his behaviors. Another fact that he found was that his substance use caused harm to others that he may not always be able to see. Panda's transformation continued by regaining a sense of hope that had been missing from his life for quite a while. This hope was the foundation. Let me stress, this hope was the foundation for Panda's recovery process. He became aware that things just do not have to remain the same and personal change is possible. He began to realize a sense of patience, understanding that it is much better to enjoy small successes than to demand instant gratification. Over the years of his most recent incarceration and subsequent release, Panda's transformation occurred. As you may have already guessed, my nickname is Panda. I have told this story many times, and other iterations of this Panda story. I used to say upon release in 2012, I served my debt to society and never looked back. In reality, I have stumbled a bit here and there. The reentry and recovery process is not linear. I'm here to say that reentry and recovery is not easy. For all of us individuals who have reentered society successfully, quote unquote, I am sure that there are plenty of stories just like mine. While they are not pretty stories of success neatly packaged and gift wrapped, I believe they are the true stories of reentry and recovery. I continue to look back at my past through the lens of others who are doing time and others who are struggling with life. I continue to navigate those same mental health and behavioral struggles on a daily basis. Some days are easier than others. Some days I just want to curl up in my bed with my cat Hafiz. Some days I'm ready to take on the world. I continue to move forward. I continue to be accountable. Since 2012, I have earned a bachelor's degree in mental health and human services. I have a graduate certificate in public health, and I am a licensed alcohol and drug counselor and a mental health professional. During these 12 years, I've worked as a mental health case manager for both children and adults and a substance use disorder clinician. More recently, I assisted in the development of a co-responder program in Waldo County and became the diversion program manager. I am now currently working for the state of Maine in the Office of Behavioral Health as a substance use disorder program manager, one such program being the statewide options program. I have arrived where I am today through a personal recovery process, my education, my experience in working with others, and the help of a lot of people that I will forever be grateful to. The road that I traveled to be where I am today is not a conventional one, nor is it one that I would encourage others to follow, but it is the one that I chose. Thank you.
Thank you, Robert. Just one of the many people that I work with and am accountable to in my work. My name is Eric Harum, and I'm one of the technical assistance providers for the Maine Options Program. And I'm very proud and pleased to be working with all of the liaisons, recovery coaches, their employing organizations, and the different stakeholder groups that they interact with. This afternoon, we've got two panels. Our first panel is going to be from Penobscot County, and our second panel from the York County region. And what we're trying to illustrate with these two panels is how partnering with your options liaisons in your communities can improve response time and improve outcomes, and in fact, help save lives as we all grapple with the ongoing problems with opioid and substance use related to overdose and overdose death. So a little bit about options. Options is an acronym. It stands for Overdose Prevention Through Intensive Outreach and Naloxone Safety. What it is substance use disorder clinicians, licensed clinicians, as co-responders embedded and heavily partnered with first responding agencies. You probably have heard this throughout the course of different trainings and breakouts and discussions today, but nationally about 75% of referrals to substance use disorder treatment services come from the judiciary and law enforcement. And so it's a pretty logical place for the options programs and liaisons to be connected to where about 75% of the referral base comes from. And I know that there can be some criticism around that because we want to be inclusive of the full range of different stakeholder groups in all of our communities. What you'll see with the two panels this afternoon is diverse stakeholder groups that have knitted themselves together to be able to respond to very, very complex situations, cases, and needs. And ultimately improve the response time and, in fact, the outcomes. So more on options, right? Again, you have embedded liaisons with first responder agencies, co-responding to overdose and other SUD-related emergencies, connections to recovery coaches, and this year adding recovery coach positions in all of the option county liaison regions. Right, and ongoing technical assistance. Myself, Oliver Bray-Dean, Amy Carter, we meet with liaisons as groups and as individuals and help problem solve barriers that they interact with in the community and spread facilitators or things that work so that other people can learn and we can accelerate those improvements. Community-based partnerships for low barrier access, such as syringe service programs, recovery resources or clubhouses, education and connection to local harm reduction services, recovery capital gains, community coalitions, hospitals, hospital emergency departments, med-surg floors, county jails, all very logical places for these connections and relationships. So primary responsibilities, as you can see, post-overdose follow-up, connecting people to other services in our continuum of care, such as the Maine Mom Network and programs, helping people get Maine Care applications or other benefits and entitlements. Community engagement. We track a lot of data from this program at the individual client level so we can learn what's working and what's not working, and where it's working and where it's not working. Connections to federally qualified health centers and other providers, naloxone distribution and community training, harm reduction support, professional assessments and referrals to treatment, lots and lots of education to community members around stigma and bias and racism, resources, navigation, and barrier removal. So some key metrics to date. So looking back from when we started in 2020 through last month, the end of June, right, there's been 4,909 co-response or post-overdose follow-ups statewide conducted alongside those first responding partners. 4,400 clients referred to community-based treatment programs. 4,700 individuals referred to community-based recovery support programs. 14,000 individuals trained in overdose and anti-stigma education. And nearly 20,000, 19,000 doses of naloxone distributed. And that's in part to the work that you're going to see from the liaisons and their really key partnerships that you'll meet. Now, what they're going to do is they're going to talk a little bit about how they organize themselves in their own community to improve response. And then each of the panels has a de-identified case, a real-life client that they interacted with as a response team to help that person access services that ultimately resulted in them still being with us today. And the point here is that all of the stakeholder groups that you'll see in these two panels exist in each county. The opportunity to replicate these response efforts is very, very high. And what we'd like you to do is go back to your communities and do that. Everybody got hopefully handed out this little trifold as we started walking in this afternoon. Information in here, how to get to know your county liaison, how to make referrals, and we've canned some questions in here for you to consider when you go back to your communities. Do you have a go-to list for resources about harm reduction, recovery supports, and treatment in your community? Who's the option liaison in your county, and how can you connect with them? What services and resources for substance use disorders do my local hospitals provide? What pathways does the local emergency department use to help people for substance-related emergencies? Those are good questions for members of the public to be thinking about, and in fact, to know the answers to. And so a part of what we've done with front-loading the talk with these things for you is because we want you to go back and find out the answers to those things in each of your communities. And if you don't like the answers, interact with those stakeholder groups and let them know what you need, okay? And so with that, I'm going to turn this over to our first panel from Penobscot County. And Ashley Roberts, who is the liaison in the Bangor area, is going to introduce the group and walk us through their case.
Hi, so I am Ashley Roberts. I am the Penobscot County Options Liaison employed through CHCS, and I have been a drug and alcohol counselor for a few years, working with the Options program about 3 years now. So in Penobscot County and Piscataquis County, we have a very unique situation in that when Options was first started, we have a co-grant with Bangor Public Health that was started at the same time. And so not only did they start Options, but they also formed an overdose response team, which Megan and myself are part of. So that has brought us a few bonuses. So that gives us a few members of the Bangor Police Department that have chosen to be on our team. We have our favorite one here today. This is Officer Alvarado. It has also given us the benefit that we have had recovery coaches as part of our team since day one of Options. And so I will turn it over to Pat, our recovery coach, and let him introduce the rest of the team for you.
Hi, my name's Pat Cayley. I am the certified peer recovery coach with the Penobscot County Overdose Response Team /Options. I am also a certified intentional peer support specialist based out of the Together Place on 2 2nd Street in Bangor. It's a great little place. You should come down and check us out sometime, right? I am a person in long-term recovery. I am formerly incarcerated. I've been out on the streets. I am also the holder of several problematic mental health diagnoses myself. Right? My job is to get out and connect with people on the street and also to connect with our law enforcement partners, right? I am going to introduce the rest of the panel right now. We've got Amy West. She's a family nurse practitioner, the Associate Medical Director of Substance Use Disorder for PCHC. We got Jessica Taylor, Senior Director of Population Health and Care Transitions from St. Joseph's in Bangor, Maine. And we have Megan Harrigan, who is our second options liaison and covers Piscataquis County. Be handing it over to Megan right now.
Hello. Today we're here to chat with you guys about why we made this whole team kind of happen. Ashley and I had been going out in the community in Bangor, and we were meeting with folks responding to non-fatal overdoses with PD, and we were also connecting with our people to maybe get to detox or a recovery pathway that met their needs. And sorry. And we were also going out 1 to 2 times a week, building relationships with folks and just getting to know them. They were getting to know us, and just giving out, supplies, Narcan, all that stuff. And that amount of time that we were doing that, we noticed that people were having really high needs medical issues and not being able to make it to their appointments and or to a clinic or emergency department, half because there were a lot of barriers from where they're maybe houseless outside to getting there, were too many steps. The second half was their experience that they've had in the hospitals, in the clinics, because of their active use and how they were treated. Why do you want to keep going back? So what that ended up looking like were a lot of folks with lots of medical needs, untreated, out in a community that maybe they weren't getting their basic needs met. Therefore, it was making their medical conditions a lot worse than what if we had been able to treat at the very beginning. So through a lot of networking, talking to a whole bunch of people, and putting together a medical outreach team, because that's what we needed on the other end of Ashley and myself. We needed medical folks to come out so we could say, this is where we are, this is what we're doing. We need to do it in the spot the person is right now, wherever they are. So we were able to focus on meeting medical needs in the community and putting a different experience for our folks who are living out there to meet with medical people and have a different outcome while they're being treated and then being followed up, with people that they were connecting with along the way. And now it's your turn.
Thank you very much. I am French and I talk with my hands. So I don't want to stab one of my counterparts with the microphone, so I'm actually going to probably go up to the podium if that's okay.
Perfect.
It's for your own safety. You're welcome. All right, can you hear me okay? I'm also a little vertically challenged, so I'll try to see you over the podium while I'm talking. All right, so my name is Jessica Taylor, and I am the Senior Director of Population Health and Care Transitions at St. Joseph's Hospital in Bangor, Maine, and I am so excited to share with you the positive outcomes that we have realized with this partnership, and how grateful I am that the options team have allowed me to come out with them and learn from them and have all their little pearls of wisdom to help to inform the care that we are giving to such a vulnerable population. But before I do that, I wanted to just take a moment and just kind of call out what I've seen as a pattern here today, and specifically what Megan and Ashley were speaking to, and Amy will speak to as well, is the real benefit when dealing with vulnerable populations in our community. The real benefit to that population is really creating those relationships, not just with the patients, but with your other community partners. There's a lot of great work that's happening out in the community, but if we are not connected and we are functioning in silos, it's not as meaningful to the patient, and it's not patient-centered. So I'm coming at this from a hospital perspective, because that's where I work, as a hospital. And by the time patients come to me or get to the emergency room at the hospital, they are so sick. They are very far into whatever exacerbation that they're having. They have other chronic diseases as well, that's making that exacerbation worse. And they have delayed their care for many different reasons. One might be out of fear. The other, stigma. We have a long way to go in the healthcare system when it comes to stigma. And again, that's another benefit of having these partnerships, so they can teach us and they can help us to receive folks in a much more compassionate way. The other issue is they may delay care because of lack of access to care. The care's not there when they need it. And so that, very important, having that timely care before things get really far down the road, and that's what Amy will speak to when she speaks, and the value of her role. Again, so from a hospital perspective, when we're waiting for folks to show up in our emergency room, that's very reactive care. We're reacting to the person coming into our building in the condition that they already are in. So how do we switch that from a proactive approach to a reactive approach? And getting out there to seeing folks, reactive approach to a proactive approach where we're helping to prevent folks from getting very, very sick. How do you do that when you're in a hospital? You're in the hospital, you're kind of stuck there. What we had to do is we had to look at ways to collaborate in our community and move the healthcare out of the brick and mortar of the hospital and into the community with the people that needed the help. So that way we could reach them before they got really sick, and to create those relationships that are so important. Again, the magic happens with the options team and with Amy and the officer over there. They're doing the boots on the ground. They're the folks that have the relationships with those folks and the work that they're doing, and we're just seeing them in a little snippet in time. So those relationships are really important to ensure that the care is holistic. Each team brings their own skill set to the table. And Megan touched on that a bit when she spoke about identifying the need for the medical piece to it as well. So again, creating those relationships with your partners in the community are very important to the patient to make sure that they have the care that they need and that's appropriate. But it also helps to switch the view of our healthcare system, again, from a building, like it always has been, a doctor's office or a hospital, but switching that view out of the building and into the community, again, as I mentioned, out of that brick and mortar, so that healthcare does not become a locus or a place, but rather a continuum. So healthcare is what's happening with that person at that point in time, where they're located and when they need it. There's lots of studies out there that show that when vulnerable populations come into the hospital and they've already waited a long time to seek care, the outcomes are not good. They're sick, they have a higher mortality rate, they have a higher rate of morbidity, and they have a higher length of stay, higher amount of ED visits for ambulatory care sensitive conditions. That's stuff that can be taken care of out in the community. And so that taxes the healthcare system, and it's a limited resource. We want to make sure it's there for when folks need it and can access it. So what have we seen so far with this collaboration from a hospital perspective? It's just been a short amount of time, but I will tell you we have seen some wonderful things, implementing what I've been taught from the options team and Amy in the hospital, and changing our lens and perspective of how we're treating care. How are we discharging people back out to the community? Because we all know that there is a perfect scenario, best practice, in a perfect world we'd have this. This is reality. And I think all of us have to, meet in that intersect there to make sure that we're providing, great care. Prior to this collaboration, our discharge planning was speculation. I mean, we would talk to patients and we would try to learn what was happening with them, but it was really based on what our perception was, not what was meaningful for them. And so with this collaboration, they have the wonderful advocates that can help to inform their discharge plan and to help to advocate for them and to call us before they come in and say, hey, this person's coming to you, this is what's going on with them. I'm also able to see folks out in the community when I'm going out with the teams, and then see them in the hospital for that warm handoff and that friendly face. So again, it's that creating that continuum, for care, to make sure that the care is passionate and patient-centered. So I'll stop talking because I'm a talker, so others get to talk. But before I do, I'll leave you with one thing. I would invite all of you, every single one of you, to go back into your communities and see if there's a partner or someone that you can partner with that's giving great care. It doesn't have to be huge bells and whistles. I think we connected because we picked up the phone and called each other and said, hey, do you mind if I come out and see the great work that you're doing so I can learn from you? I invite every single one of you to do that, and that's really what's going to help to make the care a little bit more patient-centered and create that continuum. Thank you.
I'll just come up to the podium too, because like Jess, I talk with my hands and the microphone would be everywhere and no one would know what I'm saying. So I'm Amy West. I became part of this team when I was working in a low barrier MOUD clinic on a pretty main drag in Bangor. Boston was a while ago, in Bangor. And I was seeing a lot of patients that were really high risk for overdose, but I was seeing them walk by my office instead of coming in for their actual visit. So understandably, a lot of those patients that were really high risk for overdose and death weren't making it into me regularly, if at all. But I would watch them walk by my window on their way to the shopping plaza, often within about 10 to 15 minutes of when they were supposed to see me. And then a couple hours later, I'd see them walk back by. And I knew that there was an encampment right close to my office. And it started to feel a little ridiculous that I was sitting here twiddling my thumbs, watching people walk back and forth when I knew where they were. And not just one of my patients, but a chunk of my patients, many of my patients, and understanding that their priority that day wasn't coming in to talk to me and giving me a urine. It was, how do I eat? How do I stay safe? How do I not feel sick? So it seemed wild that I was expecting them to know what day it is, what time it was, and be a priority for them, when it really, I wasn't. And realized I need to go to them. In my background, I worked in medical outreach in Boston and knew that my success as a provider and providing medical care was only as good as the community partner that I was working with. These folks don't know me. They don't trust me. And I needed somebody that they trusted and that they knew their intentions were pure. And Options was literally the perfect fit for that. I had worked with Ashley at PCHC before she was on the Options team, and Ashley had outreached us to just be aware of what Options was offering, what they were doing. So I called Ashley and said, hey, while you guys are doing outreach, could I come with you and maybe provide some medical support? And they were like, medical support? We need medical support. So that's kind of how it all started. And over the past couple of years, because of the work that they did in the community, knowing where patients were, knowing what the needs were, how to meet the needs, who the other community partners were, we were able to grow not just our nuclear team, but kind of the spokes of the wheel, knowing who else in the community was seeing our patients and the day-to-day, and them having a way to connect with us when they noticed a patient needed something. So for instance, the director of the Bangor Public Library might call me or call Ashley or Megan if somebody needs something. Pat may see someone at the recovery center, and we can all communicate with each other and come up with a concrete plan just for the day, the week, the long-term plan for those individuals to make sure that their needs are met, with the long-term goal of engaging them in recovery treatment, which we have had great success with, but also keeping them out of the hospital and keeping them alive, frankly. So it takes a village, and I think we've created that for our patients. Thanks.
So to quickly kind of round off our panel, I want to give you guys a real life example of how we use this and how this team is so important and how we come together. So mind you, on a typical outreach day, we could see anywhere from 10 to 20 patients in 5 or 6 hours, okay? And this is just one of those people, okay, that we see. So there was a person who identified as male in their early 20s who is diabetic, co-occurring mental health and substance use disorder, and chronic homelessness. He was living in a vehicle or a tent with his long-term partner, who also had significant mental health and substance use disorder. There were concerns for domestic violence, exploitation, or trafficking by the partner towards the male. Options and Amy West started seeing him for medical visits. We saw him for medical visits for about a year on a weekly basis, whether that be diabetes or a wound or whatever the need was that day. We would see him at the encampment. After about seeing him weekly for a year, he lived in his tent all winter, and he got frostbite on both of his feet and had to have all his toes amputated. He did have this done in a hospital, obviously, and he chose, after his surgery, to return to his tent against medical device. He also did not engage with any medical follow-up, which, how do you blame him? He doesn't have a phone, he doesn't have a car, he now has a very hard time walking. And so we started seeing him again. We said, hey, he's back in his tent, we're gonna start seeing you. By that time, Jess was also coming out with us. And so we started doing wound care on his amputated toes in his tent in the middle of winter in a homeless encampment. And we encouraged him to go back to the hospital. We called ambulances. We had him even in the back of an ambulance one time, and his partner was able to convince him not to go. And so we continued this for a while, and Jess was able to meet him on outreach. So she'd come with us, she would help Amy do his wound care, they would have conversations, and they started to get to know each other. After 4 months of these weekly visits, wound care in the middle of winter in a tent, he did go back to the hospital. Jess already knew him. She had already formed a relationship with the patient. She was able to connect him immediately with all the care that he needed. So she knew he had these wounds. She knew his medical conditions. She was able to get him proper treatment for his infected wounds, his active substance use, and his diabetes. Working with Jess at St. Joe's, they were able to keep him in the hospital, transition him to a medical rehab, and then further coordinate for him to come to Southern Maine to live with his family again. And I wish he was here so he would know how proud we are of him, that he is still living in Southern Maine. He is in recovery, and he is cleared of all infections at this point. And so this is just one of the many examples of things that we've run into, why this team is so important, and why we want other communities to also take this on. So yeah, I think that's it, guys.
All right, thank you. Let's hear it again for Penobscot County. Okay, now I'm going to call up our panel from York County. This is going to be led by Lacey Bailey, who's the options liaison in York County. And put up your slide. And like this first panel, what you'll hear is how they got themselves organized to improve response and a case that they will walk you through.
Hello, everybody. Thank you so much for coming out to hear us, learn more about the Options Program and what we're doing in each community around the state. As mentioned before, there is a liaison or multiple liaisons in every county around the state. I came into this work about 2.5 years ago, February 2022. I have a long history of working in social work in general, substance use, mental health. I am a woman in long-term recovery myself. A wife, a mother, a recovery ally, advocate to people who use drugs. And it's really an honor today to talk to you about kind of where it started and where it's gone. So when they first said, you have this position and we're going to put you with Sanford Police Department, which I have Shannon Bentley here today, who is the mental health first responder for Sanford Police Department. I didn't really know what I was doing or how I was supposed to do it. They just said, here's a county, go do the work. And so That led to some challenges, lots of lessons, but I've been really honored to be a part of a police department that really supported what I was doing in the work and really letting me try to come in and to offer services versus maybe take somebody to jail, stabilize on scene when possible, divert from the ER, or when the ER was necessary, be able to advocate for that person to get the services, which I think in this role I found was a lot harder than I thought it would be. And so that will be more explained in the case that we're going to present. I'm going to let each person on the panel just introduce who they are and what their role is under their title and who they work for. And so I have Shannon Bentley from Sanford Police Department, Aaron McGann from Sweetser, who was crisis during the case we're going to present, but is now also in Options Liaison in York County with me, and Marsha Thomas, who's the intensive case manager inside York County Jail. We also had Todd Prevet, who's the intensive forensic case manager for Office of Behavioral Health, who also had a pivotal role in here, but is lucky enough to be in Las Vegas gambling with his buddies as a yearly trip, so I couldn't really blame him for wanting to go there, but I will explain his role and how he really helps this case. So I'm going to hand it to Shannon.
Is this on? Okay, I'm Shannon Bentley. I'm the mental health first responder, like Lacey said, with Sanford Police Department. I'm hired directly through the police department, whereas Lacey is contracted through Options. We share an office space in the PD with 2 other officers who are assigned to our mental health unit and work as a team to respond to mental health, substance use, homelessness calls for service in the moment, and then we do a lot of follow-up work after the fact. Lacey and I both have like long-standing clients that we work with in the community. I would say our roles are pretty similar. Do a lot of education for the police officers and how to respond to mental health emergencies, substance use emergencies, overdose, stigma. We do a lot of work building partnerships in the community, which is what this is all about. So this is Erin.
Thank you. My name is Erin McGann. I also work for Sweetser. In my role here, I worked at the crisis unit, or the crisis department. I was embedded in the York Hospital, and we'll be talking to you a little bit about that. My background is 20 years in criminal justice in Texas, and when I started there, I was a parole officer, and the vast majority of my clients did have substance use issues, and my answer to that was just stop using meth. I'm sure you can guess exactly how many of my clients listen to me. If you guess 0, you would be absolutely right, and I've learned a lot since then, but I still think that if they'd all stopped using meth, their lives would have been better. Just saying.
Good afternoon. My name is Marsha Thomas. I work for the state of Maine, Office of Behavioral Health. You met our fearless director this morning in opening remarks, Director Squirrel. I work for the Justice and Health team. If you're not familiar what an ICM is, Intensive Case Manager, they're located in all the county jails. They're located at the state prison in Wyndham and also at the IMHU. And we also have intensive case managers at the both state hospitals, Riverview and Dorothea Dix up in Bangor. My job is when an individual who's been out in the community gets involved in doing some crimes, I hear from either Lacey or Shannon that they're on their way and is going to be booked at the jail. That gives me an opportunity to go down and meet the individual and learn a little bit about them and about their history and follow them through their case. I work, with their defense attorney. I sit on the York County Mental Health Court. And I do reentry planning. And that's about what my role is.
Thank you. So the case that we're going to present to you today, we all know very well. It's been a very long road with this client, so I'm going to give you some background. This is a 32-year-old male, primary diagnosis, a schizoaffective disorder, bipolar type, secondary diagnosis of an opioid use disorder, severe stimulant use disorder. And those things together make a very challenging person to work with. However, also lovely, very sweet kid. Has, lots of trauma background, very paranoid in the way that thinking that other entities, mafia, they, them, the police were out to kill him. And so it was very sometimes complex when we would come across him, and he really just thought people were out to get him. He often would also be vulnerable to sexual exploitation by way of trying to get some of his survival needs met and ending up in those vulnerable situations. Chronic homelessness, very high utilizer of police services. When I came in and met him in February 2022, he was actually my very first client with Options. He had had 40 plus intakes to just the hospital in our local area that year. Just in and out, sometimes every 24 hours. And so when I went in, this was an individual that just to me was clearly struggling and clearly sick and clearly needed more than he was getting. And so I thought I was just gonna walk into that emergency room and be like, this is what this person needs, and it was not easy. That led us to about 6 different hospitals in southern Maine before we would actually get a crisis worker that was listening to what we had to say and give this gentleman a shot at a better life. And we knew that he needed a very high level of care, and that is always not the easiest thing to access, and that was one of my biggest lessons in the very beginning of this. So kind of my role with him is I thank my supervisor, Alyssa, for, I think I needed some supervision around this quite a lot, and I was feeling really defeated and like we're not getting anywhere, and how are we gonna get him this help? And she reminded me of what I was doing, and that was being a lifeline for him. And so even though it didn't feel like we were getting very far, that really stuck with me, because no matter where he was, barefoot in a subway, 3 towns away, with one of my officers, out in the woods somewhere, on a stranger's phone, I was the person he called. When he was in crisis, when things were going wrong, when he was in another town and might be coming across a different set of law enforcement, he would say, call her, and I would be able to offer some information and try to help guide him more so to a hospital than to incarceration. So again, 6 different hospitals, feeling really defeated, kind of trying to take a new perspective, doing a lot of harm reduction with him, and we ended up at York Hospital, which is where Aaron came in. And Aaron also works for Sweetser, so we were, kind of already part of the same team, but to have somebody listen to what was going on, to understand his behaviors, to not let them get in the way before somebody treated him like a person, was just instrumental. And so I'd like Erin to just explain kind of her interaction with this individual and where that went after she assessed and met with him.
So this client wasn't necessarily somebody that every crisis worker would think, oh gosh, they need to go inpatient. He was having a lot of delusions and hallucinations and substance use issues. And lots of times people will dismiss that as, oh, it's just substance use, just send them back out, they're fine. He clearly wasn't fine, and he was willing to talk to me, which is always amazing when somebody's having those kinds of delusions. I'm not special in getting somebody to talk to me. I didn't do anything special except that I listened to him. I let him talk about what he thought was going on. Just because I don't see the people he sees or hear the voices that he hears doesn't mean that they're not happening for him. And that is that basis of what I talk to everybody about. If somebody says that they're suicidal, I listen to them. It doesn't matter if I feel what they're suicidal about is a good or bad reason. It's their reason. And that's how I work with everybody that I work with. Whatever's going on with you is going on with you, and I believe it. And so I believed this guy, and he was, bless his heart. So I said I worked in criminal justice for 20 years. I also worked in criminal justice with veterans for 20 years. So I've heard literally everything that I could be called I've been called already. And he was good at it. And that was probably my favorite part about these conversations with him, because it doesn't faze me anymore. And so he would just go on these tirades, and some of the staff at the hospital were like, how are you letting him talk to you like that? And I'd be like, what are you talking about? And they would say it, and I'd be like, oh yeah, no, like that doesn't have anything to do with this, you know? And so that always cracked me up. But having those not having those preconceived notions of like, you can't call me this or you can't talk to me that way, was really, really helpful. The York Hospital does an amazing job working with their crisis workers. It's the only hospital I've worked at, so I'm not saying any other hospital doesn't, but York does an amazing job. They listen to the crisis workers, they take our assessments really seriously, and they listen to our reasons that we think that people should be hospitalized. And in this particular case, we had to reassess him for a few days in order to get him into a behavioral health hospital, and they listened every time that we thought that really he was going to be in danger to himself if he was out in the community. And so it was a really amazing collaboration there. And
And so, and for me as a liaison, you know, having another professional listen and take the information that I had been able to gather over this period of time was very validating and just relieving for me. But for our client that we worked with, it made all the difference to him. And he wanted to be there, and that was the thing too. Even though he ultimately probably could have been there, maybe against his will, given his circumstance. He wanted to be there. And so I want Shannon.
If I could just interject for 1 second.
Yep.
And Lacey did mention that we worked together. We worked together really closely on this case. She would call me and give me information, and having that outside information was very, very helpful. We absolutely could have blue papered him if it was necessary, but he did choose to stay because we were able to make him feel safe and comforted. If I remember correctly, the very first thing he said when he started talking to me was, I can't talk to you, I'm hungry. And I was like, okay, here's some food. You know, like that really, really easy thing to fix. And I think that that really helped with the conversation.
He certainly felt validated. And so Eric had mentioned that about 75% of referrals come by way of law enforcement, and that is one reason that Options has been partnered with law enforcement. And in my experience in the 2.5 years, I could probably say without some stats in front of me that that number is absolutely true, just as far as even who I've been connected with in the community. And that has been very helpful, not only to connect with people, but to also be part of the police department and help educate them on new ways to deal with patients like this that they otherwise don't know how, and we've traditionally just been arresting the problem away, and we're trying to change that culture. And so I want Shannon, she's going to talk a little bit about how, as a liaison and the police department, we work together and kind of their role in that.
Yeah, so for this specific client, he was a police co-response call that Lacey had responded to with the officers. That's, like she said, probably how we meet most of our people. We get like follow-ups or referrals as well from the officers or from the local hospitals, but most of our clients come from police interactions. For him, also specifically, there's a lot of paranoia around police trying to kill him. So we did a lot of education around this, you know, what are some things that you can say that could trigger him and make him more fearful and less likely to work with us. Our officers are really, they take everything in and they follow our guidance. It's wonderful. And they learned how to work with him really well. So that was good. And then some of what Lacey had talked about with some of the other hospitals, we kind of partnered to build better relations in some of our local hospitals, and I think we've worked really hard to do that, and kind of a result of this case. So,
and I would say one of the best examples of helping the officers work with him is because he was so paranoid about the police and very convinced that they were going to set him up to either just kill him or go down suicide by cop. He felt very comfortable talking to them in front of their cameras. So if they were in a cruiser, it was talking to him in front of the cruiser where the camera could pick it up. That made him feel safe. When our department took on body cams, it was tell him your body cam is on. And so that was just very helpful, coordinating this case. And eventually, What this led to, unfortunately, at times was incarceration. And this is kind of where Marcia comes in. You know, he gets incarcerated, and we brought Marcia in as the intensive case manager. She did exactly what she had said to meet with him.
So I went down and met with him, and I find out a little bit about his case, what crimes he committed to come into the jail. I find out who his defense attorney is. I work with the attorneys, and we come up with a reentry plan, and with the courts. Sometimes with an individual like this, who has, severe, prolonged mental health issues, it's still in the jail. Oftentimes, I'm called upon to make referrals to our state hospitals. And in this case, we did make a referral, but he also had bail conditions. When he first came in, when Lacey and I first was involved, he had bail conditions. So I had made a referral for him to get services at Riverview, and but it was a waiting game. Is he going to get the money to bail, or is he going to go to Riverview? The first time, whoops, I'm losing my glasses here. The first time, he made bail. And so I think that then he went back out into the community, and I think there was a lot more police involvement and options involvement and a lot of substance use, which inevitably brought him back to the jail. This time, we were able to get him more services and make outside referrals, and he did end up at Riverview.
And that's not an easy sell. And so collectively, we were able to even provide Riverview the information that they needed to make the decision to take him. And he was there for about 4 months and came out into recovery living, did well for a little bit. And we still had some slips, and that's when we brought Todd on, who is the community intensive case manager. He's been with OBH for about 27 years, so the amount of relationships that Todd came with, he just played such a pivotal role. So after one more hospitalization, after this, Todd worked to get a referral into a PNMI level of care, which is really what this gentleman needed. And it still took quite a bit, and it took even a few months from there. But eventually we were able to get him to the level of care that he needed, and it was really because of this team and only because of this team that we were able to do that for him. And that's why this coordinated response has just been so pivotal to the work that Options does. Thank you.
Thank you.
So we've got about 5 minutes for any questions or comments from the audience. And I'd like to have both panels come up, if you don't mind. There's microphones here and here, or if you speak from here, we could hear you.
Hi. Maybe somebody back there wouldn't. So, my name is Lynn, long-term recovery myself. What are your thoughts about taking mobiles out into the community? I know during the winter it's going to be a little more challenging, but just being there, showing people that you are still advocating, you're still helping when they need it. I know it can't be everywhere all at once, but into the bigger communities that in the area that like more people are at and more drug use there is and drinking and all that and encampments, just to show them that, hey, if I need to talk to somebody, I can't get them on the phone, because even I know that. Leave a message, we'll call you later. Sometimes it's a week, So I just wondering about the thoughts about a mobile unit at some point going out.
I'll take that if that's okay. So I worked on mobile units in Boston. There are some talks of mobile units coming to Bangor. There's a lot of plus and minuses to the mobile units. One of the minuses is you're kind of like, come on my dark, creepy van, even though you've never met me. I promise you'll be fine. So it's one of the downsides. The other downside, they're very expensive, and they can't get everywhere that we're trying to get to. So one of the pluses is it's like having a sign that's like, hey, we're here for you, come see us, which is great. So you're a little more visible. And in the wintertime, when you do have someone that needs wound care, it is warmer in the van than it is in the tent. So there's plus and minuses to them. And it's something that I know in Bangor we're continuing to explore. Some of the community partners have secured a van, and now it's just a matter of using them and using them well.
Okay. Right here.
Ryan, alcoholic addict. I was just wondering how options team like that starts, and how would you go about doing something like that?
So how to get into options work specifically? So, I mean, for me specifically, I saw this opening come up, and it was, for a clinician working with police department. I think if you would have asked me 10 years ago, no way was that something that I even felt like I could do. But it was really just by way of being connected with the position, and how we've created the team is just a lot of community outreach. It's in the relationships that you build with others, getting out into the community, letting people know who we are, what we can do, the services that we can provide, and how we can help them. It's not just how they can help us do our work, it's how can options help them. And so I would say if you are ever interested in a role like that, definitely moving forward with some sort of substance use education, certificate programs, working in the field, and even just checking out your local liaison and asking them questions and getting some more information in your area. You're welcome.
Right here.
Hi, thanks. My name is Anna Graham, and I'm sit on the Health and Human Services Committee, and I want to thank you for all that you do. Whenever we have things come before us, I always want to hear about boots on the ground. I'm a former nurse practitioner, and I really want to hear boots on the ground. So my question, and I wonder if we could talk to some of the two law enforcement individuals, is, we know that many individuals who interact with you all are in crisis, and mental health crisis, and how you approach that, how you de-escalate that, and engage, because not every department, not every sheriff's department has mental health professionals to be able to address that. So, and then one was mentioned suicide by police officer, and so I just kind of maybe a situation where you found this really working.
Are you asking specifically how to de-escalate a situation where it's like mental health?
Yeah, and how how law enforcement and mental health really engage and make a difference for a client.
So I can just tell you where I work at the Bangor Police Department. Again, my name is Officer Alvarado. At the Bangor Police Department, we have 2 mental health liaisons from Acadia that works along with us. It so happens that I'm fortunate to have one of them ride with me like most days when I'm working. It's good to have them with us because in our community, as options know, we have a lot of people that suffer from substance abuse disorder, also suffer from mental health. So most of the time, if I go there and I notice that it is a mental health situation and I have the Acadia liaison with me, I will have them try to de-escalate the situation first before I get involved. A lot of time when they see not a uniformed officer talking to them, they tend to be more relaxed. Sometimes it's not the case. Sometimes the officer is the one that relaxes them. But vice versa, I think it's good because we both help each other. We feed off each other.
I don't think we have any more time. We're right at 2:30, so thanks very much for joining us for this hour. We really appreciate your time and attention. And go back to your communities and answer those questions in the brochure. Great job.
Okay, thanks for being here. It's just 3 o'clock, and our voice of recovery for this session on youth development organizations, part of our prevention work, is Michael Smith, who's living in Lewiston, and we're going to hear Michael's story. So he's a little nervous. Give him a nice hand.
Thank you. My name is Michael Smith. I was born in the town of Plymouth, Massachusetts. I come from an upper middle class family. My life started out normal enough, but it was very apparent at an early age I had some serious mental health issues: ADHD, ADD, conduct disorder, bipolar II. At age 11, I had sexual trauma. At 11 and a half, I lost my brother. From 13 to 15, I was sexually trafficked. At that point, I was using alcohol and marijuana. I ended up in the Maine Youth Center and Goodwill Hinckley, also Jackson Brook Institute and Spring Harpur on several occasions. At the age of 17 and a half, I thought it would be a good idea, due to my past, to start selling drugs. Yep. I ended up in jail, in and out, on a constant basis. On my last day in jail, something happened. I had found what some call my rock bottom. The feeling I endured was that of complete and total surrender to God. In doing so, I found the means to get into the St. Francis House 72-day program, and from that point, I knew this would not be enough. I'd get 6 to 9 months of sobriety and have a slip. My life was no longer acceptable to me, so I researched the best programs I could find, the 6 month to 1 year programs, and ended up in the Travis Collins House. After getting there, I dove in headfirst, taking on my underlying issues, and also a service position in NA locally. I only make the coffee, but it helps build up my self-esteem. Funny how the small things will do that very thing. I now have a sense of pride in myself I didn't have before, and can feel the changes working in the 12 steps, getting a sponsor, and both my programs. I can be proud of the man I am today. I will continue to excel with the help of Travis House and of that in NA and AA communities. Also, with the help of God guiding me, I will prevail. I will no longer be a failure or a shame and have self-doubt. I will now and forever be a success story. Thank you.
Hey, get ready. No. There's a reason they put us at the end, guys, so get ready. I almost want to tell everyone to come forward because it's kind of awkward, but I won't. It's okay. We won't boss them around yet. But welcome to our session. I'm here with my esteemed colleagues, of which you will get to know a little bit more throughout this presentation. But I'm Julia. You're?
Adam.
Katie.
And Don.
There we go. We at least know our names. Okay. And these are some of our organizations. See, you went too fast. I told you to be in charge of the clicker. We got it. Okay. That's a joke, guys. We're going to have a lot of sarcasm here. All right, get with it. I'll raise my hand for anyone that doesn't understand. That was sarcasm. All right. So we are from all these different organizations, and we have come together to really build and talk today about this field of community-based youth development and the importance and the value that it has on prevention of substance use disorders, especially with our young people across the state. So we're gonna be talking more about that. But before we do, I told you it's gonna be a little interactive here. We have some icebreaker questions, which I know you're really excited for. So this is what's called a think, pair, share strategy, which just basically means you gotta think about it, you gotta pair off with someone, and then you gotta share it. Okay, and we're not going to do it long for anyone who's like, please don't make me talk to anyone else. All right, so we want you to take a minute and think about, and then share with someone around you, who was a safe and trusted adult who had a positive effect on you as a teenager. And if you're still a teenager, you can still think about that. Or if you're pretending to still be a teenager, well, we can talk about that at a different session. But take a minute. Chat with someone else in the room. Go ahead. Yep, that requires you to, move and. All right, you need to switch. Someone else should be talking now if you were talking the whole time. All right, I'm going to call you back in 3, 2, 1. And get excited because there's another one. Click. Oh, that's right. We must reference. So we're going to do some reference points to these questions. Having just one trusted and safe adult in or outside of the home contributes to better overall health and less risky behaviors. So the fact that you are able to likely recall someone in your life, there's a reason that is stuck with you into adulthood. The impact of that can really have tremendous impact for our young people as they grow. And that's part of what we're going to talk about today is the ways in which how do young people access that, especially if they don't necessarily have that in their home. So let's keep going. Now get excited. There's another one. All right. So when you were in your teens, or currently are, what were positive experiences that helped you grow and still influences you to today? Can you think of an experience or an ongoing experience you had as a teen that still today impacts you? Go ahead. Now we should. Oh, are you ready? Let's keep going here. A little known factoid. The more positive childhood experiences, the less chance of lifetime substance abuse. So those experiences that you were citing is something you were able to recall, you brought it with you, but also may have been a contributing factor or can be contributing factors to lessen the chance of lifetime substance abuse. Those experiences can be very meaningful and very pivotal. Let's keep leading in. Last question, right? All right. Where in your community, okay, think of whether you want to think back to when you were younger or in your current community, can young people find a caring and safe adult and positive experiences, especially if things are not going well at home or at school? So if you kind of take home and school out of the equation, where can kids find positive adults and experiences? Chat. All right, and we're going to call you all back in 3, 2, 1. Excellent. So, these are some of the amazing little friends that I work with every day at Tree Street. And we're going to talk a little bit about all of our different organizations and the ways we engage with youth and young people. But we really want to uplift this concept of community-based youth development. They're very unique organizations, and they're also unique relationships that get built in community-based youth development field. But for a lot of people are kind of still a little unsure sometimes, like, well, what do you mean by that? And so we're gonna take a little bit of time to just help you understand what we mean by the term community-based youth development.
Thanks, Julia. I'm Adam Burke. I work with the Peter Alfond Foundation, and we have the opportunity to stand back, look at what's happening across the state as we're looking to invest in strengthening communities through innovative wellness and education opportunities. And when we were setting out on this work a couple years ago, and we saw stats like 50% of middle and high school age youth feel like they don't matter in the Maine Integrated Youth Health Survey data, as well as worsening outcomes in terms of mental distress, suicide ideation, attempts, etc. It's very concerning for what's going on with our young people. So we've asked ourselves these questions about where young people can get positive experiences and relationships so that those aren't the outcomes that they experience. And what we found is we've worked very closely with everybody you'll meet today and about 30 other organizations, as well as with young people themselves. It's this concept of community-based youth development that's congealing. And I'm going to talk a little bit about what that means to differentiate it from some other things we might be familiar about, as well as more specifically what people are doing in these environments that seem to be effective as well. And then we'll hear some stories. So first of all, this is one side of the guardrail of what community-based youth development seems to be, that it's year-round direct youth programs, services, and relationships, which is key. It's designed to support individuals and not just groups, and it's focused on a whole person, offering 360 degrees of support. It's locally designed, and this is really important, and co-created with youth, not just one size fits all. And it's working with the proximate support networks, including schools, and that might also include the families, JCCOs, other people that are involved in young people's lives that are trying to help them. These community-based youth development organizations are restorative. One example is that it means there's a no eject or reject model. Kids can be there. There's always a way for them to be involved, even when boundaries need to be set. They're responsive and dynamic, and they're culturally relevant and strength-based. And I'm going to leave it there because you're going to get some illustrative examples in a moment of what some of those things look and feel like in practice. On the other side, we've tried to understand, well, what isn't it? And we've seen that when it's a one-off or temporary or short-term program, that's not what's working today with young people in terms of changing outcomes in the long term, generally speaking. It's not about being exclusive and accessible to only certain youth. And it's not about only supporting youth during very specific program hours. Again, it's 360. It's about a relationship. It's about both when the young person's at a site or in a program, but it's also maybe seeing them at a local game or someplace out in the community. It's not dependent on the ability to pay. It's not focused on the number of kids served over the quality of how those kids are worked with and in relationship. And it's not about prioritizing the scaling of programs over the ability to scale the relationships. The being known, the being seen, the being heard is at the core, and that's preserved throughout these programs. So those are two sides of how we might understand what community-based youth development is. And then within there, what we've seen, and it's been validated by the people that are working directly with young people, as well as the young people themselves, most importantly, as we've talked with them, is that these are things that are working for them, that they're having welcoming and affirming experiences, that they have the chance to connect with land and nature, that there's plentiful food. There's the chance for social emotional learning, and in this case, we've highlighted non-clinical mental health. Not that clinical mental health is not important, because it is, but in these environments, there's other opportunities in how young people are supported. That there's these durable relationships between the community-based youth development organization, as well as with the families and the schools and with others, as mentioned before. There's the chance for young people to lead in ways that are meaningful to them and to build skills along the way, and that they're connected to meaningful opportunities and networks. And lastly, there's these 3 hexagons in green, which are kind of a leading edge of what we're seeing happening in the field, and that folks here on the stage are deeply involved in, including the idea of long-term relationships that are spanning transitions, That might be middle school to high school, it might be incarcerated to out, it might be in foster care to out, all sorts of circumstances there. That there's educational credit or a stipend that's available, and as said before, that there's this co-designing, this co-creating of programs that's occurring. So this is a high level. I just want to give you the range of what it feels like, sounds like, not sounds like yet, you haven't got there, but what community-based youth development is in practice, and where young people are able to find a trusting, positive adult and experiences when school and family's not necessarily going well for them. I'm going to turn it over to Katie.
No, I don't want that. Hi, everybody. Thanks, Adam. I just want to offer really quickly to Mike Smith, I apologize because we moved past his story, and I just want to say thank you for your bravery and for standing in front of all of these strangers and sharing what you shared. It was really powerful, and I am in awe of you. So thank you. My name is Katie Lutz. My pronouns are she, her. I'm the associate director at a little organization called Out Maine. We serve LGBTQ plus youth across the state, all the way from York County all the way to Aroostook County. So if you know of some programs who need our support, let me know. I got lots of cards. Also, I'm not here to talk about that. I'm here to talk about the work that we do in regards to prevention. It's really incredibly powerful for our youth. As you can see in the yellow, you have some quotes from some 9-year-olds who access our online youth programming that talk about why coming to our weekly online programming is so important to them. They are safe there. They know that the person who facilitates that program is going to listen to them, validate them, they have safety, they're included. The environment there provides that sort of safety net for them. The photograph you see in the bottom corner, that's roughly 120 youth from across the state who come to our annual event called Rainbow Ball Weekend. Rainbow Ball is the reason I work at Out Maine. It is the queerest weekend I have ever attended. I went as an adult in 2019 with at the time I was an advisor at a school for an LGBTQ plus program at my school. And I walked into that room where all the kids were and all the adults were, and I said, how do I do this all the time? How do I feel this sense of safety and welcoming and belonging and genuine joy all the time? That's my hope for all the youth programming that exists across the state, is that every kid walks into that space where they go, whether it's after school on the bus, whether it's being bused there on the weekends, whatever it might feel like, that's the feeling we want them to have. That's prevention. Kids who come to our program know that when they are there, they're not engaging in anything else, because the community that they're building and the friendships that they're making in what can be a really short period of time are going to last a lifetime for them. That's the power of relationships. I was a health teacher before I started working at Out Maine, and I got to tell you right now, a lot of times I would say to some of my peers, I know that math is what you teach, but I'm going to need you to talk to this kid like they're a human being, because I can guarantee they're going to do a lot better on that algebra test if you just recognize that maybe their weekend was tough because they struck out every time at the plate. That's the step. That's the work. And it's hard sometimes for adults, it's hard sometimes for grown-ups, and it's even harder sometimes when there's a barrier that may or may not be real in regards to a kid's identity or their gender or whatever there else might be there. That's the step. Treat me, see me, I am here, I am a whole person. It's okay if you get my pronouns wrong, try again next time. The step is Prevention is the relationship. Out Maine works with communities to build third spaces for youth. Whether it's home or school, that's maybe not great. What's that third space? Is it after school at the church program? Is it at a rec department? Is it at the Boys and Girls Club? We have the power to create that third space for youth where they're gonna find that trusted adult that Julia talked about that you already identified. That's the power of the work that we can do. And our lens at Out Maine is specifically for supporting LGBTQ+ kids, but anytime you do anything that supports that group of kids, it raises everybody else to the next level as well. That's my statement. I'm gonna pass it off to Dawn.
Hi, everyone. Thanks for this opportunity, and thanks for choosing to come to this session in the midst of all the other wonderful opportunities. My name is Don Carpenter, and I am the founder of a 30-year-old organization in the Mid-Coast community of Rockland called Trekkers. I am also the executive director of the Rural Futures Fund, which is a foundation committed to raising the aspirations of young people growing up in rural spaces. And I'm the president of the Rural Youth Institute, and that's really what I want to talk about for my couple minutes. The Rural Youth Institute is a youth development incubator looking to identify particular evidence-based and promising practices that can enhance the youth development field in Maine, especially for those organizations and youth development professionals who are supporting young people growing up in rural spaces. And in that incubator, we have an immersive learning lab, and we have demonstration sites all over the state. And in that immersive learning lab called the Aspirations Incubator, we're exploring different youth programming principles and pillars and practices to see if we can evaluate it, to see if they work. And there's one concept that's already been mentioned that I just want to explore a little bit deeper with you that we know works with young people in terms of really turning around their lives, and that is putting a life on a life. Long term, not just a month, not just a week, not just a summer camp, but putting a life on a life long term. So really focused on long-term engagement. And two really evidence-based practices that have come out of the incubator are cohort-based mentoring, to be specific. And this is not a one-on-one match for kids growing up in a community. This is taking a cohort of students and finding caring adult mentors and cross-age mentors of their own peers to commit to that cohort of students for over 6 years, from the age of 13 all the way to 19. That's one evidence-based practice that has come out of the incubator. The other one is a concept called looping. And looping is made famous out of the educational systems in Finland and Estonia, where it's common practice that the kindergarten teacher would loop around and be the first grade teacher, and loop around and be the second grade teacher, and such and so forth. And we've taken that concept and incubated it in the incubator to see what it would be like if a youth development professional followed that cohort of students throughout 6 years of their life, interacting with, supporting, training those adult mentors and cross-age mentors, having a connection to the schools and the community-based and regional support systems so that if and when something came up in a young person's life that was above the pay grade of that youth development professional, they would know who to turn to in order to support and intervene quickly. I'm going to hand this over to Julia so we can get to questions, but I just thought I would read you an email I got from one of those professionals that has been committed to a group of a cohort for the past 6 years. This is a student that joined the program when she was 13 and is now a senior, just graduated, because I got this 2 months ago. But I just thought I'd read it because I think it really highlights the support the individual youth, the idea of engaging community support networks, and the focus on the whole child. So if you'll just bear with me in my old eyes. So I got this email. Hey, Don, we have a current senior whom I'll call M, who was involved in a scary rollover car accident about 2 months ago. While the hospital initially only checked her hand, I noticed a significant change in her behavior afterward. She seemed dazed and unfocused, often quote unquote floating through the hallways at school. Concerned that M might have a traumatic brain injury or TBI from the accident, I started to gather information from those around her. I first spoke to M's friends, who mentioned she had become short-tempered and seemed to start talking to herself randomly, and they were worried about her sudden change of behavior. Next, I got permission to contact M's supervisor at work, with whom I have a strong relationship in the community. She expressed similar concerns about M's health. After that, I consulted the M's guidance counselor at the school. We reviewed her grades and noticed a significant decline since the accident, a stark contrast to her previously strong academic record. The change had not yet been noticed by the school and wasn't on anyone's radar. After going to the guidance counselor, I went to the school nurse, who frequently collaborates with us, where I explained my concerns to her. She let me know that student athletes at the high school use an app called Sway for concussion protocols. M is an athlete, meaning that she has had previously established baseline for cognitive functioning that we could now measure against. After collecting all this information, I then went and spoke to M herself, who I have an incredible relationship with. I gently let her know she had seemed a bit different to me since her accident, asked her how she might be feeling lately, reminded her that I cared about her health and success, and asked her to check in with the school nurse to use Sway. She agreed and did so that day. The results were concerning, prompting the nurse to contact M's mother, who, despite her own life challenges, took the situation seriously and agreed to take M to a neurologist. And in this case, in this rural community, was 200 miles away. M was soon diagnosed with a TBI and received the necessary academic accommodations at school, along with follow-up medical care. The story exemplifies why establishing caring relationships with all stakeholders is crucial. By connecting the dots and ensuring everyone was informed and involved, we are able to intervene to support M effectively. This highlights the importance of focusing on each student's unique adolescent journey, engaging in community support networks to leverage schools and local resources, and providing comprehensive 360-degree support that nurtures all aspects of student development, not just the social, not just the emotional, not just the cognitive or the physical, all of them. These strategies have become vital in our community-based youth development work, ensuring that we remain proactive and preventative instead of reactive and crisis-driven when it comes to meeting the needs of our youth. That's what we're trying to do, is put a life on a life and be able to really know what's happening in all dimensions of a young person's life as they move through their adolescence. And that's what we mean by community-based youth development as a preventative strategy to support youth. Julia.
So the first time I was on a panel with Don, I leaned over and I was like, you know, you're the OG of youth development in Maine, right? And he didn't know what I meant, but that means the original gangster of youth development. So it's always a privilege. And a lot of my inspiration to lean into this field came from, I grew up in the Bangor-Brewer area and moved down to Lewiston. And in doing that, I met some amazing kids. And you guys are right here in my backyard of where then I started what is now Tree Street Youth. So we're 12 years old now, but when we started, it was basically 8 teenagers from the neighborhood, me and a couple of college students who all came together. We're like, let's hang out and see what happens. And we needed a space. And so our particular community-based youth development model is centered in having a physical location, which a lot of the programming does, like having that third space that Katie referenced, where kids can access mentors and those 360-degree individuals. And then, so that was kind of how we started. We just hanging out. And then you get to know those students and you get to know their families and you get to know the networks. And so if you sort of fast forward from those early stages of the grassroots sort of experience to where Tree Street as an organization is now, we serve upwards of almost 1,000 youth now across like the Lewiston community. And we're located right in kind of the heart of downtown Lewiston, which we obviously, like, if you're from across the state, people like, I think recognize like Lewiston's a unique community in Maine. In particular, the neighborhood that we're in, which is called the Tree Street neighborhood. All the streets are named after trees. It's very Maine of it. You know, maple, pine, birch, ash, spruce, get it? And so when we were building the center, we named it Tree Street Youth because we were drawing all these kids from the community, from the neighborhood. And as we started having more time together, kids are pretty good problem solvers, and they like to live on the edge. And so we had to come up with more things for kids to do, because it's one thing to hang out, but if you're hanging out consistently, kids get on each other's nerves. You got to start programming. You got to get activities going. Kids want to try things. They're bold, and they have ideas. And so we started just sort of building from their ideas. At first, kids wanted to know what college was, so we built a branches program to help explore what college was. Kids need help with homework, so we built some spaces to do that. Then kids really wanted to dance. Now, Adam and I had a historical moment where we danced on, we will not do that today. However, I taught him how to do, what was it? The whip and nay-nay. If it's not your thing, it's okay. We won't expose you to that experience today. It's more like the, yeah, okay. So anyways, kids really wanted to dance, so we started creating spaces for dance. We didn't have teachers for any of this, y'all. We just put music on. Like the kids kind of did it themselves, but you gave them a space to try. And then a kid who's never danced steps in and tries that. And then they want to do art. So then we had to create an art space. And then they all wanted jobs, of course. So then we had to start figuring out how to employ them, which we created what we call street leaders, leadership models, where kids act as mentors and role models to the little ones. And for some of our families and our kids, those kids have grown all the way up through. So now Tree Street's unique in the fact that we are pre-K through 12th graders. Now, so we are very comprehensive of any school-aged child. And not every community-based youth development model is that or can be that, but you'll see those threads of those elements that flow through, that constant contact with the mentors, that 360 degrees. So my prevention strategy that I really wanted to speak on, though, was what's called novel experiences. And so it's exactly like the title says, something novel, something new that kids have never done before. And you'll see some pictures up there of things like roller skating. How many of y'all love to roller skate? You know you do. Or you've never done it. Some people have never done these things. Roller skating is an example of that. The other one, we took kids ice skating. They built garden beds. We cooked meals. We had dialogues about things. And then our most epic and most recent trip, of which I will highlight, is this is our third trip ever, but we had kids summit Katahdin this past weekend. That was crazy, y'all. And those types of experiences can be very transformative. So a novel experience is an opportunity to do something you've never done before. All right, and that can be pivotal. It rocks kids' world, okay? Nothing humbles you like Katahdin. Okay, especially in the first time we went up there, we brought some of our absolute most vulnerable, all system involved boys. And there's nothing that has humbled them more than Katahdin. Still to this day, they talk about it. And that was 8 years ago. Expanding perspective of the world or yourself or others. Sometimes it is a dialogue. Sometimes it's coming to a place like this and interacting. It can increase social capital. So the concept of social capital is experiences you had that contribute to your knowledge base of understanding of things. For example, the young man sitting in the front in the green sweatshirt, he had never been in a boat before this weekend. He's 16 years old. Whereas my little one has been in a boat since she was 6 months years old, right? So when she's reading a book about a boat at school in kindergarten or first grade, she knows what that means. He never knew that. He could understand, he could look at a picture, but to have that experience when someone talks about the waves or the balance, that's significant. That's social capital, all right? Giving that opportunity is significant, especially for lower income youth or youth that don't have the same access points. And then last but not least, youth learn about themselves and they learn to manage their emotions and their bodies. For kids that are going through trauma, who are experiencing incredibly challenging things that like we can't even fathom, a lot of the factors of what contributes sometimes to kids seeking substances is they don't feel right. They don't physically feel good. There's emotions, there's things pulsing through them that they can't understand why, and so they're seeking to physically feel differently, and someone says, this might help. And I'm not saying that's everyone's story, but that is an element of the prevention, is to show them there are different ways to make yourself feel different. You can try different things, and there are strategies to this, especially today with like a lot of emergence around like somatic practices, social emotional learning, understanding like kind of the ways these experiences can impact. Because when you put those kids on the side of a mountain, trust and believe, they learn that their bodies have limitations. And they also learn how to manage their emotions in different environments. So our goal at Tree Street every year is everything's a tree acronym or metaphor, so get ready, this one's big. So we try and have every kid crack an acorn. I saw an acorn outside, I almost brought it in. But so it's having a arts experience, a community organized, like maybe something like this, a community organized experience, novel experience, and R, a recreational or physical kind of athletic type of experience, and an N is a nature-based experience. So every year we want every single kid we serve, no matter what age, to crack an acorn. And having novel experience means it also has to be something that majority of the kids have never done before. So it also forces the creativity of the leadership around that. And I'm gonna close with just like a very, very brief uplift. So the young man in the back that's holding the sign in the black t-shirt up on the far left, that is a young man that climbed that mountain at age 16 for the first time. This past weekend, he led that trip for all of those kids as someone who grew up through our program and was a staff member. And to uplift our story from the beginning, so many parallels to his story. And he is now substance-free. He worked at the center and is now here leading other kids in novel experiences because it was his experience on Katahdin that day that was so transformative. And it doesn't mean every kid has to do that, y'all. Not every kid is built for that, or the adults that serve them. However, the concept of trying something, exploring, discovering that passion, or just pushing yourself in a vulnerable way can truly be transformative. And oftentimes community-based youth development organizations and groups and practices are the areas where kids are getting access to do that beyond their homes and beyond their schools. So fancy. So with that, we're gonna shift to just opening things up. There's mics out front. Questions, thoughts, big feelings, reflections? Or it's really hot in here, you know, whatever. But you're welcome to come to the front.
Hi, my name is Lynn, long-time recovery. So I've been on both sides of this coin because now I hold emergency. So what kind of situation it can be like, because they talked about non-clinical, But what happens when those people, they already feel out of place because I'm different from others? And so what are we doing in this state, anywhere, that's going to help these people? And especially somebody with physical labor, you know, because they couldn't climb Mount Katahdin. So, but I would like to see something happen so that maybe one day they could, you know, get a, you know, who knows if it's going to have to be a super golf cart that helps them get up there. Someday. You know, but at least it's brought up. That's all I care about, that it's brought up and that we don't exclude anyone, because we're all human. We all have our differences and we need help everywhere, you know, especially with the world, where the world is turning at this point. Thank you.
Yeah. Thank you. So I think I'll just name that I think you spoke to quite a few of the elements of like the inclusivity, the needing to be able to include everyone, but also adapting and designing models around who's in front of you. And I think Dawn wanted to chime in a bit. And then also some of the places that are already doing this, I think Adam could speak to some groups that we work with. Like these are not the only organizations. We work with 30 plus organizations across the state, and there's more who are doing this type of work. And that all the models look different, and that's the power of it.
Yeah, I appreciate the question. One of the thoughts that come to mind is the idea of turning the educational process over to young people to design and co-create the actual novel experiences. And that way, a young person who might be physically disabled has a voice in the process of defining what they do. And so we're really doing a lot of training around that type of consensus decision-making and really sharing power with students as a way for them to make decisions, as opposed to the adult saying, we think this is what's best for you. So we're just trying to flip that script a bit, and in that moment, we can come up with solutions to address some of the concerns you have. I would also say that I think any of us who have been at this work for a while recognize that we don't have enough mental health professionals out there to support adults alone, but adolescent young people. And one of the things that these organizations that we're working with, it's not like they have clinical folks on their payroll. Many of them can't afford that. And so what we're encouraging folks to do is to, again, build the relationships with the community or regional or statewide support systems needed so that when those issues arise, our job is to build a relationship with the young person and the family, so when that mental health issue comes up, they trust us enough to pass the baton to somebody we trust. And that's the key of connecting those dots. It's not enough to do this work in isolation. We've got to build the relationships with all the stakeholders in the community so that when that issue arises that's above our pay grade, we know who to turn to.
Other questions, y'all are welcome to come to the front.
Hey, thank you. My name is Annie Graham, and I'm a legislator. I sit on the Health and Human Services Committee. I think my middle name is Prevention. As a retired former pediatric nurse practitioner. So one, thank you for what you're doing. My question is, and what's your first name again?
I'm Julia.
Julia, thank you, Julia.
I guess I should have started with that.
No, it's cool. It's all cool. Talk a little bit about, you have a very multicultural city, and how the kids work together, how they learn with one another. And, you know, I think that in many of our other areas where you don't have as many cultures and differences and so on. So can you talk a little bit about how the kids do that? I think they probably do a hell of a lot better than we adults.
Well, kids usually do. That was a joke, but not really. I think, well, obviously, again, like Lewiston, Auburn area is a really unique in regard to like racial diversity and cultural and language diversity. So just for some context of that, so Tree Street has over 25 different languages spoken. We have 7 on staff. And we serve a very diverse array of kids from all different backgrounds and identities. That being said, like, kids are kids are kids, you know? Like, now, don't get me wrong, identity matters. And anyone that's trying to move past that, like, you're missing it. I'm just gonna keep it real. Like, it does matter. Your racial, your cultural identity, your sexual orientation, who you are as a person matters. And that's what we teach kids, is it matters. So you have to begin to understand it about yourself, and you need to begin to be able to share those things, and that it evolves, and it can change, and it can be fluid, and it can be confusing, and it can be challenging, and people will understand you and people won't understand you. And the reality is supporting young people to get to a point of that they like themselves. Like, a lot of kids, especially kids that are acting up or struggling with things, they don't like that they get in trouble. They don't, some do. And then it's like, well, what's that about? Like, you know, there's elements to that. But, you know, the basis of things, creating unity across lines of difference, requires that difference exists, period. And supporting young people. And that's where a lot of these co-creative design processes are about. You didn't think of that person and their need. So how do you design for that? How do you design for this person's need as well? And a lot of it is also about teaching simultaneously kids' ability to advocate for themselves if they do have a different need. And that really requires, a lot of the time, is just getting kids together and supporting them to build the idea that comes out of their head. If we're being prescriptive as adults, it's easy for kids to feel left out, because chances are we've prescribed something, we're saying, we're gonna run this program today. If it's not co-created in some way, shape, or form, there's a chance that then one kid is like, oh, well, that person didn't think of me. Or if they're uncomfortable, can you accompany them through this discomfort? Because next session when we're playing basketball, you know, this friend is gonna feel uncomfortable. So some of it is about, like, teaching kids how to, like, hold their own selves accountable, which helps with them making decisions when we're not there. So those are ways that we approach it. And at the end of the day, like, when it comes to, like, any difference, y'all, like, keep it real. People are different. I don't care if people are predominantly one race or one culture. You all are different. You come with very different things. And the more comfortable we can get adults around us, to recognize that and be able to acknowledge, like, there are differences here and kids need different things, the more we can innovate and we can design for those unique kids' needs without trying to force them to conform to something. That doesn't mean there's not boundaries. It doesn't mean we have rules. The expectation is respect, period. And we don't need to break that down. And for someone who does need that broken down, we're gonna teach them that. But you extend a lot of grace also, like, in the midst of things, because people don't have the same identities or backgrounds or languages or even understandings. Mistakes will get made, but you want that grace extended to you when you make a mistake. And that's a lot of what it is. It's very baseline, like, uniting of humanity piece. And I'm curious, I don't know, Katie, I don't know if you want to speak to that at all. Okay. Or we can have another question, because you're all really excited. Yeah.
So mine is for LGBTQ youth. So I might, whoa, was I too close? I identify as a lesbian. I have a son who has come out to me that he's transgender. And one thing that I noticed that he struggles with is talking about what he's okay with and not okay with sexually. And I don't think he wants to have that conversation with me. But I can notice that he's breaking up with people because, you know, he doesn't feel comfortable with what he has, you know, and so he's going through that process. But what are resources that he can go to that I could just send him a link or something?
Well, let me tell you a couple things about that. First of all, I want to recognize that, like, most teenage kids don't want to talk to their parents about sex. Having been a health educator, I'm going to tell you right now, no one wants to have that conversation with your child. I don't know why I was the one that thought it was great. I don't know. Anyway, yes, I would love to connect with you. Out Maine holds youth programming. Our programming depends on his age. Our what is the age group? I think they're like 15 and up. Has taken a little bit of a side turn, so we're having like more focused programming for the kids in that age group, and then kids in a younger age group we meet weekly. So there's our online programming, which is a home run, and then there's tons of resources on our website. We also have a parent group, which might be really fun for parents to come and sort of just hear what other parents are dealing with and all of that kind of stuff. So we offer that once a month on Monday evenings at 6 p.m. on Zoom. All of our programming is available on our website, outmaine.org. It is for free. I have a card, so I'm happy to hand that out for anybody else who has those questions. But yes, also, like, I would argue that most teenage kids are like not super jazzed to have a conversation with their parent about like intimacy. It's a hard word for people. But yeah, so I'd connect with you after, for sure. It's a great question. I like promoting my programming, selfishly. Any other questions? We could do the whip it nay nay. Oh yeah, let's go. I mean, we could do that still after if you want.
So I primarily work with adults. I'm itching to work with kids, so that's like an agency thing.
Yay!
But right now I'm noticing this trend of younger women in their 20s really struggling in residential with their communication. I'm sure men are struggling. I just don't work with that population as much. So I've been listening and thinking about kids and their communication, especially to their parents, trying to advocate. How do we teach assertiveness and with grace? So when they get to me as an adult, like they already have that skill. I'm not digging deep, on the basics, I guess. And how do I help a parent whose kid has accessed that advocacy, but they're not ready for their kid to have autonomy?
Wow, I'm gonna. If someone here has the answer to that question and you haven't told everyone else, I feel like you have the $1 million answer to how to talk with youth and parents, and I don't know why you haven't told us. I feel like the first one is, like, I hate to be this person to say this, but as an educator who was teaching during COVID, for all those kids in their 20s, like, they're struggle bussing hard with communication in a real way. So I'm gonna say that. They also have a heightened level of awareness of what's happening outside of themselves, whereas like young people never really had that. Like I was allowed to be a total ding dong and not know anything about the world because I didn't have a cell phone. And now I think kids in their 20s are like very aware of climate change and very aware of politics and very aware of like a whole bunch of things that I had to sit down on purpose and watch in front of the TV to learn anything about. And man, was it boring. So I was not interested, right? So now we have a level of kids that I think are really sort of like, there's an expectation perhaps for them to have that kind of knowledge, which is taking them away from like their own internal processing. So that's my like assessment. I do not have a resolution, but I'm gonna start there, and then I'm gonna look at the rest of the people on this stage and see if they have an answer for the other questions that you asked, because they are good ones.
In terms of communication, one of the processes that we've been training folks on is the idea of prep, experience, process. Prep, experience, process. So the point is that when we provide a student's voice into the process and they co-create an experience, we ask them then to come back and say, okay, what do you need to know before you get to that experience? They have the experience or novel experience. And then at the end, we process it together. And it's just a way of doing a full circle of them, their voice being heard, valued, and also expressed in a process. We also, in our case, many of the cases that we're doing, we don't let electronics in the programming. So they're forced to communicate. And because we're turning it all over to them. If they want to sit there, we'll wait it out. But nonetheless, we're teaching them those skills as a way to do consensus-based decision making. And you can imagine, I mean, think about it, for 6 years, these students are working in a cohort of their peers. Every single one has to agree on every decision for it to pass. Imagine us doing that as adults right now. So it's tough. So, but that's how we're helping to build that knowledge base and skill set.
Yeah, and I just think like some basic like practical elements of things. I think obviously by the time you're getting young people, they're a little bit more grown, but if you can start with your younger youth, like we teach personal power, like it's your choice. I know that's like very scary for a lot of adults, especially like people who work in more structured environments or schools. Like it is literally a kindergartner's choice whether they do school or not. Don't freak out. There's laws, there's things, there's boundaries, there's good things for kids. I'm not trying to be, I'm naming as teaching children, like choosing to engage and extend that trust is what's called personal power. And a lot of times we're afraid to talk to kids about personal power, young people or even young adults, because the fear is they can't handle those decisions, and that developmentally, in many cases, is actually true. Like they don't have all the skills to do it, but it does not mean they actually don't have the ability to do it. They do. They're going to make decisions and oftentimes are making those decisions anyways. And so I think leaning into personal power is really critical in helping people understand the difference between sort of external power or structural power and personal power. So they can choose to engage or not in their own processes. And as they get to that age, is also then teaching as a young adult or an emergent adult, if you choose not to use your personal power at this stage of life, other people will then use their power to make decisions for you. And as an adult, that's going to feel even worse because now they should be fully autonomous in their decisions. So we help kids sort of understand where that line is and and then you can unpack why they're uncomfortable with using their personal power, which often circles back to the family of origin or what kind of experiences they had. And it's okay to tell someone like, yeah, and that didn't teach you that. And I'm sorry you weren't taught that, but I can help you now. And I think those elements help. And I'm happy to chat more about a case study. I think we're basically at time. So with that, thank you, esteemed panel. Thank you, esteemed audience. And we'll be around if y'all want to chat. The end.
Yeah, well, thank you. Thank you to the panel. Thank you, Julia, Adam, all of you. We'll just take a couple minutes. You know, you might step outside. It's a lot cooler than in here. You really don't notice how warm it is. Maybe you do, until you go outside and then come back in. And I apologize for that. But as I say, the governor was in charge of the weather, not me. So we have two voices of recovery that are going to speak shortly after 4. I need to find them, and then we have no other remarks. We're just going to hear these two stories. One of them's here. And what about, so let me just find out something here. Yeah, Peter, is Russell? Where's Russell? Is Russell in the room? Yeah, I'm sure Russell will be here shortly. And so again, I would suggest take like 5 minutes, and I hope you'll come back because these are two stories I want you to hear and be exiting afterwards by 4:15, 4:20. Get you home early and enjoy this beautiful evening. So, but please come back and hear these last two stories at about 4:05. Hey, great job.
Thank you so
Great
much.
job.
Yeah.
Thanks so much. Okay. Thanks for seeing us to the end. I really appreciate it. It's warm. You need to get home to your families. We just have one more voice of recovery. And I appreciate our particular respect for him that many of you are coming back from that last breakout session. And then then you'll be dismissed and until next year. But I'm so appreciative of you being here. But our final voice of recovery, and I think it's great to end with one, Many of you have told me today as I've walked around that this is what you'll remember. So Peter Joyce is going to be our last voice of recovery. Please give him a warm welcome.
So my name's Peter. I'm a person in long-term recovery. I'm just going to tell you a little bit a story about what got me to this stage, and then a little bit of hope, I guess. So when I was in my preteens, I can't even really tell you when I began smoking pot and drinking, but I know it was very early in life. So I was smoking at high school football games, cake parties in the backyard. My mother somebody stole alcohol from my mother, and so she thought it was a great idea to make me drink a pint of hard stuff. I guess it was supposed to make me not want to drink again, but it did the wrong thing. I fell in love with it. It took me out of self. I could be more wild. I could talk to the girls. So throughout my teenage years, I started drinking more of it, more often. Late in my teens, I was introduced to heavier drugs, heroin, cocaine, some of the hottest stuff. And just like the alcohol, I fell in love with it. I started doing more of it, more often. I tried to stop, and there was nothing that would make me stop. The loss of my kids, freedom, pretty much I lost everything because of the drugs and alcohol. And it wasn't enough to make me stop. I still continued to use. So, I want to just say that because it doesn't discriminate. Addiction will take anybody. Lawyers, judges, brothers, sisters, aunts, uncles. It doesn't discriminate. It'll affect anybody. It's a family disease, so everybody in the family is affected by it, not just the user themselves. So at the end of my run, I was I overdosed probably six times in 1 week. I found myself at the Bridgeton Hospital twice in one day. The doctor told me that I was going to die if I continued doing what I was doing. I knew that I was beaten, I just couldn't do it no more. I was just so sick and tired and just abused from all the drugs and alcohol I've been doing for 35 years. So I checked myself into Recovery Connections of Maine. And by the grace of God and Recovery Connections of Maine, I've got 10 months sober. And it's been a battle. This isn't the first time I've been to rehab. I've been there over and over, and it's just finally caught on. I would go and not listen. I was forced to be there, but now I'm really paying attention. It really means a lot to me. I got my kids back, a job. There's all this stuff is starting to return in my life. But I guess my biggest message is if you know somebody that has addiction or a family member, don't give up on them. It's not their fault. I get so emotional, but it's not their fault. And what they need is the support. There's so much stigma around addiction that's what keeps a lot of people from getting help. Is because everybody looks at them like they're a bad person, and it's just a disease. It's you wouldn't feel bad if you went to the hospital for cancer, right? Well, it's the same idea. So. I mean, that's my biggest message. Just don't give up on anybody because they need you. They need you. And with the drugs that are out there nowadays, it's just killing everybody. So many people I've lost. And that's pretty much all I have. My biggest message is just keep helping people, And thank you very much.
Thank you, Peter. I think that's a beautiful note to close on. The governor said, don't give up. Don't give up. See you next year.